This conference will now be recorded.
Okay. Can everyone hear me?
Yes, ma'am.
Okay. That's great. So before I start and then forget, I have been given most of the scenarios which appeared in the last exam. There is one scenario I'm not quite clear what exactly that was. I think the candidate told me there was Indian exam. I think that was second last day. So it appears to be case of septicemia. And she said there were loads of investigations given, like full blood count and all that stuff. And there was the only thing abnormal she could find was raised ALT. Is anybody aware what that scenario was? And if you all can try to think about what it was, and then if you send it to me, because next one is our like surgical skills and post-op complications, I can put that in. I think that was after some, yeah, I was not quite clear what that scenario was, what she wanted to say. I think she said pulse blood pressure were normal or something. Anyway, so all these like post-op, it's structured discussion. It was structured discussion because she kept saying the examiner was asking me repeatedly to look into the notes and the investigations all again, but she couldn't find anything other than raised ALT. So if you all can actually try to think about, and whatever you have got about those post-op complication scenarios, whichever, if you can post those to me, and I can check then which one I have and which one I don't. Let me just see if I can see it here. Because I feel it's important that we do add that into our course as well. Yeah, okay. So yeah. So yeah, so it was like so it was Gynae post-op day 1. She says structured discussion, 36 weeks, twin pregnancy, delivered by elective section because of preeclampsia. And then she has atonic uterus and PPH. And now she has 300 mils blood loss. And now she has been asked to review this patient. Urine output is 20 mils per hour. ALP was 220. So ALP she feels was only raised. Platelets was low. Examiner asked, look into the reports, what is abnormal. And according to her, CRP was raised, yes, 130. Temperature was 38. Blood pressure 140/90, pulse 88. Serum lactate was 2. Oxygen sats 95%. So she was asking what is the reason, what is the cause of the sepsis. Yeah, and she said like only ALP was raised. And the examiner was repeatedly asking, look back into the report. So if anybody is aware of this scenario, please post me the details so we can add it to next. Right, okay. So almost all of you have the recording of this session. To just go through that just makes life a bit easier. But I'm just going to go over these as a reminder again. So this one, breaking bad news, can be tricky, and that probably needs, that's the most important part of the communication with the patients or with the relatives. In these scenarios, whether you're going to pass it or fail it totally depends on how you have interacted with the patient. Now, when we will do these scenarios, you will see there is not a lot of theoretical and clinical details basically you will be discussing here. All you information you give is about just giving really a framework, like we're going to do further testing, we're going to discuss in MTT, and then we will see you. So it's all about communication. And in communication as well, it's very important what phrases you use, and more important than that is what is your body language, what is your tone, the way you're speaking. If you say, on one hand, if you say, I'm really sorry about what happened, or we are also saddened with you or whatever. But then your tone appears to be just the way in the exam our adrenaline is high, and we go enter and say, well, I'm Dr. Chabin so and so, and I'm asked to see you by the midwife. I'm afraid I have this news. And then you say, so the tone appears. I mean, you using all the right phrases maybe, but your tone appear really excited and or maybe adrenaline driven. No, that's not going to work. That's not empathy. Your tone must go down and with pauses as well, which obviously we will practice during the session today. So yeah, so that's about empathy, how you're going to express when we only are saying, and why it is important that our body language and our tone of words and all must also match with our words, because that's empathy. If we are using only the words, I'm sorry this happened to you, and I'm sorry, I can see you, whatever, you're upset, but our tone is not agreeing with that, and our body language is not agreeing with that, that will be called sympathy. That's not empathy. Empathy means I'm also feeling the same. Putting yourself into that person's shoes and try to feel how painful and how awful that news will be if I was in that situation. How my body is gonna really get dropped, and we can't even speak. We get shocked. We speak slow. We speak with pauses. So that must reflect, and that's the main reason people fail in this type of communication. So then obviously just go introduce yourself, just check the patient ID, confirm is that the patient, and then depending upon the scenario, you can say, if there is something to address as immediate well-being, like it was some post-op and then some report has histopathology has confirmed as a cancer, then you will see first establish that how she's recovering from the operation, how she's been doing, and bowels, open bowel, bladder, and all that stuff. After that, you obviously can start like, we did that test and we sent that tissue for detailed examination. I have the, results with me, and I'm afraid results of the report can be quite unexpected and shocking. So at this stage, obviously, you can offer her beforehand, instead of blindly asking, are you alone? Is somebody with you? Tell her why we wanting to, yeah? So the result can be quite shocking, unexpected. So would you like to call somebody with you? Are you okay for me to go ahead? Don't use these artificial phrases. And I can tell you honestly, examiners hate, role player hate hearing these phrases when you guys say, sorry, I'm the bearer of the bad news. I mean, it doesn't matter who is telling that news. You need to, this is not the way to express your empathy either. All you trying to say by that way is like saying, well, I wish somebody else could have told you and I wouldn't have to face this difficult situation to talk to you at the moment. That goes absolutely wrong. So all of you, if anybody uses this phrase, please delete them from your brains. Absolutely delete them. And then obviously I discuss how you express your empathy. Then I mean, these are the phrases and these are the steps you can actually write down and exactly just fill in the blanks whenever there is any scenario. Absolutely these phrases and this thing, and you will pass the station in an excellent manner. And then you give the results. Give the results in straight, short, precise, and very clear, simple words. Okay. So start, say, for example, is cancer of the, so it's endometrial cancer. Just simply say, I'm afraid the report of your result shows that you have the cancer of the lining of the womb. Okay. And then just a little pause of few seconds to see how she take that news. Then depending upon the patient's, how they're going to react, some people obviously go very upset, they will cry, they will go into shock, some go into denial. What are you saying? Are you sure? Are you sure you got my, this is my report, how this can happen? Don't immediately again try to just, slow down again and slow to say, I can see you're very upset. I can see this is very shocking for you. But yes, I have, I have checked your name and hospital number, and I'm afraid that is your result. Okay, and this is exactly the tone you should be using. So again, I mean, in between you can say I understand, but right in the beginning, don't say I understand. Again, the word we say usually say I understand. What are you feeling, and understand how shocking that is. Uh, Again, the word I understand you are is not taken in good ways. It doesn't leave the good impression again either, because it's very natural. Even if you look into real scenario, yes, sometimes if something goes wrong with our dear ones, we get really shaken up as well. We feel very sad and everything, but still we can't feel the same way as that person himself or herself is feeling. Unless we have gone through the similar trauma and that person knows that we have also gone through the similar trauma, okay, then it makes sense to say, I understand exactly what are you going through. Okay, so just recently one of my friend's father has passed away and she's very upset. It was a sudden death, and I have similar kind of experience. My father went suddenly, unexpectedly, and just at age of 60. So yes, I have been using this word with her by saying for everything she says, I acknowledge first to say yes, and I can feel that pain. And yes, I do say that to her because she knows I went through that same trauma in a similar circumstances. So there I can use this phrase. I can understand exactly what you're going through. I'm so sorry that you also going through this. Okay. So we need to understand as well these words and phrases, what is the purpose, where they should be used. So routinely for the patients, they don't know anything about us and our experiences. So instead of saying I understand, the better word is to say I can see you're very upset, you know, and I can say this is very shocking for you, because we can see from that person how the person is behaving, what effect this news has left on that person. So we are only seeing that, okay? So we can acknowledge. So when we say I can see this is very upsetting, that is more reassuring for them, because then they feel we are acknowledging in what amount of pain they are. Okay, and it's honestly, it's not unusual if somebody says I can understand what you are. They say no, you don't. You can't understand what I'm going through. This is not unusual. I mean, patient saying that. So, right. So after that, you can say, again, give her a couple of seconds. If she straight away start asking you, I mean, she's in a denial or she's upset, and then she says, what and why happened? Have I done something wrong? And I'm going to die. Uh, then you can answer those questions straight away, just those specific questions. You know, less, I will encourage you not to feel, so much disappointed at this stage, because we do not have the details of your report yet. It's really difficult for me to answer this question, like how far the disease is, unless it's clearly given. Yeah, this way. Otherwise, if she goes quiet or she's crying, just stay, give silence a few seconds, and then again in a very calmer tone, just ask, would you like me to give you some time to come to terms with the news? Are you rather like me to explain further what to expect from here? And then just wait what she says. So if she says, yeah, okay, and then if somebody is very upset, once again offer them, would you like me to ring your partner or some family member or friend for you? And then, if when she says, okay, tell me why that happens, then again, this is very standard format, and it's not something that this is textbook format I have written. No, this is exactly what I speak to my patients. This is exactly what I have put here. Okay, and then you will start by saying, if she says yes, okay, tell me what's going to happen. Then we see you say, so whatever the type of the cancer it is, it has been, the report shows this cancer has, and then just make a quick picture maybe. Well, if it's online, then you won't be able to have the picture. You can just try to, with your hands, you can try to make it to understand, the womb has, 3 different layers, the lining of the womb muscle, and then the outer layer, we call it. So the cancer starts from the lining of the womb, and then depending upon how advanced it is, it can extend, say, to the muscle and to the outer layer as well. I'm afraid the report shows that your cancer has actually, involved all the 3 layers of the womb. And then you can say, so what we need to do now, we need to do some more tests, and then tell whatever MRI, CT, blood test, whatever you think is the most important next step we need to do. So I will arrange that test to find out if it's just confined to the womb, but it has spread to other organs around, like bladder, bowels, So we'll get that information. I'm also going to arrange chest X-ray for you, because sometimes these cancer cells can spread to other parts of the body, to the lungs, or whatever you feel is the secondaries for, the metastatic sites. Just call those tests as well, and then say, I'm going to discuss this with my consultant. And then once we have their test done as well, we will discuss this case in our team of doctors. We call it a multidisciplinary team, which will have obviously standard team always. There will be your consultant, gynae cancer specialist. Then you can say the radiologists, the people who do your scans, and also the histopathologists we call. These are the people who give the report of the tissue report. So all together, we will discuss these reports, and they will make a plan of management, individualized plan of management, which will be suitable and best for you. Okay. So this is that we will say, okay, that will be entities, and then you can offer us. So as soon I will hear from them, I will make your appointment, so we can discuss and explain you the management plan. Okay. After that, obviously, this is only the little bit of clinical. You can see in whole scenario. This is little bit of clinical, and that's also again very simple and basic things we have informed. Again, it's all about your communication here. Then you say to her, if she obviously in between she's asking any questions, answer. Never ever say to the whether it's breaking bad news or any other scenario. If at any stage the patient asks you any question, or they want to know result from you or anything, they interrupt you and they ask you, can you give me? Please never say, yes, I will tell you this. Let me ask you a few questions first. Unless, again, I have repeatedly said, unless you feel taking the history is going to change the way I may interpret this result. If you think, 10 pages history I take is not going to basically change this result or the way I need to tell this news to her, please always tell that news first. Okay. Or at least when they have asked, never say, let me ask you a few questions first, and then I will tell you, is that okay with you? Well, they will say for the time being it's okay, but they're not happy because they're asking, they're anxious, okay? They have come to get that news. All that history taking has happened. In the real scenario, if you say, see, GP pre-op consultations, operative consultations, they have told their all consultation 100,000 times. That is in their notes as well. Okay, so in real scenario, basically, it will be very stupid if we don't read the notes for this cancer patient. We come in and then we start very basic history again and make her to wait for her results, although she has been clearly told today, we have your result back and the doctor is coming to discuss report with you. And then we start, and she's anxious, she has palpitations, she's really nervous. I'm called earlier than what my, arranged follow plan was. And we start those basic history again by tell me what happened actually. What were tell me about your bleeding, what was happened, and the bladder. Yeah, again, imagine that scenario, put yourself in there, how that will feel. Yeah, in exam as well, that will feel very stupid, that will feel very unprofessional. So it's okay to give report result first and then take focused history. You can take always, yes. Then after that say, okay, so to help me to decide further, I would like to ask you a few more questions. You can ask these questions after breaking bad news, before even you say, I will arrange CT scan or MRI scan. Even at that point is fine. And then you just, closing one will be to offer her some sports to say, this can be very stressful, shocking, difficult for you to cope with, and it can be equally stressful and difficult situation for your family as well. So how you feel about if I arrange a appointment with the counselor? Standard situation again. And if somebody is Macmillan Nurses are the people these are the nurses who go home for advanced basically cancer patients to support really them who are kind of palliative care patients. So if somebody is really advanced cancer diagnosed, then we can offer them Macmillan Nurses as well. So I will, one of our Macmillan Nurses as well, she will come and visit you at home. And they're very well trained nurses. They will be able to help you with your medication, any day-to-day problems with the medicine, and also to answer any questions you have and support for the family and for you. Okay, so that's the Macmillan Nurses role. But for some initial stage cancers or something like that, there you don't need to involve Macmillan Nurses. And then obviously written information, again, don't say I will give you information leaflet. I will give you the written information about this condition, and I'm also going to give the contact detail of a support group. These are the women who have also are dealing with the cancer of the lining of the womb. Talking to them can also help with day-to-day problems. So this is exactly yours. You can just change few words according to the type of the cancer. Otherwise, this is exactly the way you should be saying. Then slightly different type of scenario comes when we have done that initial meeting, we have sent them home, we have MTT, and now we have called them in to discuss the result of the MTT and give them further plan. Okay, so you need to then for a minute imagine that initial consultation which we had just discussed. Yeah, keep in mind that happened at that stage. So again, the way should stay same, because this woman, yes, she's not into the shocking phase now, but she is in a now rather, she has absorbed the news. She's actually in a more miserable situation now because she has understood. She's not hopeless, okay? She's hopeless, she may be depressed a bit, so your empathy needs to continue the same way. And the continuation should continue with the same way as well. So the last consultation, when we sent them home and said we will call you, what we said was, I will arrange your next appointment with my consultant as soon as I will, we will listen from the MTT. And then if you have any questions or anything, we will answer you. So this is the continuation of that now then. Okay, so first of all, again, very human, establish how she has spent all that time when we broke the news until now. So just ask with her how you've been coping with this, how you've been dealing with this. Check the partner as well, how your partner is coping with that. All right. So make just that first, and then go further to ask first off for her. So do you have any questions? Before we discuss your management plan, so that from previous information we gave her, if there is any question in her mind, she can ask. So these are just few again sentences. Understand you were seen by a colleague a week ago or 2 weeks ago, and you are diagnosed with this and this. So just ask how you're dealing with this, how's your partner dealing? Do you have any questions regarding the information which was given to you that time? And then you can say, so as you were told, we will discuss this in our team of doctors. Now I have that information, and then just talk about the options you have. Right? So very important, this last sentence, because they put this type of scenario repeatedly, basically, to judge and assess your capability of how you actually handle this type of situation when patient is not really engaging with you. As I said initially as well, when we give the bad news, everybody is different how they're going to react. Right? Some go in denial, some go angry, some go depressive, some are just crying, and some just accept it. And they come and they say, well, yeah, I'm really sad, I'm dealing, but obviously it's there now, I have to deal with it. They are positive. They can go. These can be very difficult ones. Somebody who's depressed, disappointed, crying and all that stuff, they are okay to deal with because they're expressing what they're going through. The patients who appear angry in this type of situation, don't take them as a like thinking something wrong. Well, there was angry patient, that was right. No, they are difficult to deal with in a way that we don't exactly know what is going on in their mind. Okay, so that's just very important then to explore them and try to ask them what exactly is going on. Yeah. So one of those will see a scenario appears in exam as well repeatedly, where you have called after MTT. And the woman is very angry. Whatever the treatment option the candidate start, she's not happy with that. If you start with radiotherapy, she's not happy. So this is painful. This has so many side effects. My friend has no. I don't want to have this. If you start with the surgical option, then so are you going to remove everything from my body? No, I don't want to have it. So normally, you would expect, obviously, why this patient is angry. I will think, yeah, why the patient is angry. Obviously, it's not me who have given, so I'm not going to take it personal. She's angry on me. I'm not going to be nervous in response. No, I'm going to rather be empathy. I'm going to put everything on the side, lean forward to that woman, and I will say, I can see you appear quite upset, right? So I understand, obviously, this the diagnosis of disease, obviously, is very difficult and stressful for you. But would you like to let me know if there is anything else going on? Yeah. So because sometimes, yes, there are some other things going on, and not everybody is expressive to say things. So, well, this particular scenario which appears in the exam there, then she comes up by saying her partner is also diagnosed with some terminal illness and she has been the only carer. So she's worried, she doesn't want to go for any extensive treatment because she then feels, who is going to look after my partner? So for some people, they're not able to deal with this situation because they feel, well, their patient was not coming towards anything. So we could just not really do what to do with her. Now, if you go back here, in the beginning, when we asked her, how are you coping with this situation? How is your partner dealing with this? Yeah, if we would have asked that very human question right in the beginning, we probably would have not come to that situation. She would just rightly tell us here, well, either she may say, I haven't told him or I haven't told her because she's also diagnosed with this terminal illness and I'm the only person who's looking after her. So I don't want to upset her any further. So then we know exactly what is going on, and then we can, explain her right from the beginning that you don't need to worry about this. We can arrange cater for her as well, for you as well, and it's very important that you get treatment, treated, because if you don't, then your disease is going to progress very quickly. And then obviously you won't be able to look after your partner, and you rather yourself will be very ill and sick. So why these little things are important. Yeah, these questions are not there just for because we want the exam to appear fancy and we want to listen these things from you. No, they are human. They are very natural and human conversation. And if we do that human conversation, things are very clear. Then there's no confusion. I couldn't understand what the actually patient wanted. Yeah. So just try to keep it natural, keep it simple, sink into the situation, think you are on your a clinic, and please start applying those skills in your clinics right from now. Make them part of your consultations on your personality. Don't just keep them for your exams, and then exam won't be difficult for you. If you start applying this all which we are discussing in this to basically to your practice straight away now, it will just become your style. On the exam day, you will just take it another clinic, another theater day. Honestly, believe me. Right. Okay, let's start the cases now. Any question before I go ahead from here? Right, okay. So who was the first one to start, Pramila? Will you let us know, please?
Fatima.
Yeah. Fatima, are you with
Fatima.
us? Is Fatima with us? Okay, no response. Pramila, can you tell the next person?
Lubna.
Right, Lubna, are you there? Hello. Okay, Fatima, thank you. So Fatima has told us she's working. Is Lubna with us? I can't see actually Lubna even being logged in, so she might be on duty as well. Yes, go for the next,
Neelima.
Pramila, please.
Neelima.
Neelima?
Yes, doctor. I'm Neelam.
Okay, Neelam. Neelam, sorry,
Sorry,
Neelam.
sorry. Yeah, sorry.
Okay, Neelam. This one is for you. And please try. If you even don't know anything about it, still try. It's fine. No problem. Sure, that's your first 2 minutes, Neelam.
Yes, doctor. So, hello, I'm Dr. Neelam, one of the doctor in the Gynae clinic today. May I confirm your name and age, please?
Yes, my name is Susan Whitehead, and I'm 65 years old.
How may I address you?
You can call me Susan.
Okay, Susan. So, I can see from your GP letter that you are suffering from some itching problem and some soreness down below. Is that right?
Yes, I have been bothered with this for few months now. And then my GP tried various type of creams, but it wasn't improving. And then he sent me to have the biopsy. So I
Okay.
had the biopsy done. They took some tissue from the area. So and they called me today to discuss their report. So that's why I'm here.
Okay. Okay, Susan. So, how are you coping with your problem?
Well, yeah, obviously, I have been fed up with this, and I just want to obviously get rid of it. So I hope after this report and whatever you got, you will be able to understand better what cream or what to use to get rid of it.
Yes, yes. So, do you know which creams you were applying? Do you remember the
I
names?
was, well, there were a whole lot of those creams.
Yeah.
I think he started from thrush creams, and then
Okay.
he gave some thyroid creams, and yeah, so but I think both of those types didn't work.
Okay, Susan. So I have your tissue biopsy reports with me, and I'm afraid it is not. Uh, it's somewhat unexpected. So this shows. Do you know something about your report?
No, doctor, no, that's why I'm here.
So,
Want to go.
Susan, this report shows that you have non-invasive Paget's disease of vulva. So I think you must not be
What's
knowing
that?
it, what it is. Yes. So it is a rare kind of skin disorder, and it is not known what is the cause of this disease. Maybe because of some autoimmune, that is, some cells of our body start to act against the cells of your skin at the vulva, and that leads to this kind of disease. Sometimes it may be associated with some underlying cancers at other sites, like cancer of your gut, or cancer of your urinary tract or somewhere.
Right,
So
okay.
it can be associated.
So
Yeah.
is this cancer, like, ever got this cancer?
Well, it
What is
is.
this?
It is a condition. Which is a skin disorder. It can lead to cancer. Right now, it is non-invasive, but it can furthermore lead to cancer. And the thing is that it may be associated with cancer at other site. So we'll have to
Right.
do
Sorry,
some
doctor.
more.
Sorry, doctor. I'm really confused. I'm not. quite
Yes.
clear. So, I mean, can you tell me in simple words, this this rash which I had on my skin,
Yes.
are you saying it's a cancer? Is this cancer or not? Please help me to understand.
No, it is not cancer. It is not cancer,
Okay,
but it may be associated with cancer somewhere else.
right, okay, right,
Okay.
okay. Like where?
And in your gut or in your urinary tract. So we'll have to investigate to find out if there is any cancer anywhere else or not. So we'll need to do some more tests to find out that. And regarding this disease which you have, we'll have some medical management and some surgical management. So I'll give you the management options, but before that, I would like to ask you a few more questions. Is that okay
Okay,
with you?
right, yeah, that's okay, doctor.
Okay, so can you tell me since how long you have this problem of itching and soreness?
Yes, I have. It's going on well more than a year.
Okay, and you are postmenopausal, I think, and are you using HRT?
I did
Sure.
HRT for about 4 or 5
Mm,
years, but
okay.
no, I have stopped taking. It's been long.
Mm-hmm. Mm-hmm. Okay. And any problem with your waterworks?
No, I haven't noticed any problems with in passing urine.
Okay. Any problem with your bowel opening or any problem related to your bowel, constipation or anything?
No, I haven't. No, I haven't noticed any change there either.
Okay. Have you seen any change in your weight?
No, not really.
Mm-hmm. So right now, what is your height to weight ratio?
So I have. I think. I mean, I know I'm a bit overweight.
Yeah.
So my BMI is 30.
Okay. And any sort of dryness you feel down below?
No.
Okay. Are you sexually active, Suzanne?
Yes, I am. And I mean, not, we don't do much, but yes, I still,
Is
I'm active, yeah.
okay. Is it painful?
Um,
Is it
yeah, I mean, obviously because of this soreness and this
yes,
rash,
yes.
it's not really something.
So
Mm.
were you updated with your cervical smears?
Yeah, I have always been up to date, yeah.
Okay. Any other condition like any medical illness for which you are seeing your GP?
I have diabetes as well,
Okay.
which is well controlled. I'm taking tablets.
Okay. And any surgery on the tummy or down below?
No, I never had any operations.
Any family history of cancer or clots?
My grandma had cancer of breast,
Okay, I'm so
and I think my granddad has cancer of bowel cancer.
oh,
Yeah.
okay. Oh, I'm so sorry to hear about that. Yeah. So, what do you do for your living?
So I'm retired. I'm just do some charity work 3 times a week.
Okay. So, is everything well at home? Are you well supported?
Yeah. Yeah. I
What?
mean, I live with my husband, and he's very supportive.
Mm-hmm.
Yeah.
Mm-hmm. So, Suzanne, regarding your diagnosis, now I'd like to examine you in the presence of a chaperone. I'll see my nurse will take your pulse and blood pressure. I'll see your tummy to see whether there is any tenderness. I'd like to examine you from down below to see the extent of this soreness and whether there is any dryness in the area or not, and whether the biopsy site has healed well or not, right?
Okay.
Now,
Right. Okay.
coming to the further investigations, I would like to send some investigations like some full blood count, and also I'd like to send your case, talk to my consultant, and your case will be discussed with a team of doctors. We call it as multidisciplinary team that will consist of a surgical doctor and doctors who take chemotherapy, radiotherapy, the radiologist, the pathologist, and the senior nurses, and they'll discuss your case report and the report of your pathology, and then we'll decide whether you need to go for further tests to see whether there is any possible site of cancer anywhere else in your body, like may need to do camera examination from down below in the back passage, camera examination in the front passage, that is from the urinary passage, may need to do some sonography, ultrasound scan, some CT scan. So to rule out anything else is there or not. Are you getting me, Susan?
Yes. Yes, doctor. Okay. So.
Okay. So then
And
there
what
is,
is the treatment of this, doctor? Like how this
yeah,
is
the
treated?
treatment is, there is some creams there are which are called imiquimod cream that can be applied, and sometimes this has good results, and it is a safe treatment. But if you do
Okay.
not
Your time
respond
is
to
over,
this,
so you can
yeah,
complete.
yeah, if you do not have relief with this cream, then the team of doctors may decide further course of action, like they may like to do surgery upon you to remove the affected area. So that will be decided by the team of doctors. Okay.
Okay.
So till
Right.
then,
Okay.
yeah, till then I'll give you some leaflets, information leaflets, and support group links, and I'm giving you my number, and I'll book your further consultation with my consultant. They'll call you once your case will be discussed in the specialized team of doctors, and we'll call you back, right?
All right, doctor. Okay.
Okay.
Right. Okay. Yeah. So how long you think this all can take before I will be able to start the treatment?
Might be 2 weeks, 2 to 4 weeks.
All right, doctor. Okay. Yeah. Okay. Thank you. Okay.
Thank you for your time. Thank you for your time.
Thank you. Right. Thank you, Neelam. You did it really good. Few things we need to just correct it first. No, it's not cancer. It is cancer. Yeah. It's non-invasive, but it is cancer. So it is like how we then explain her, and we will come to that in a minute. Yeah, that was all good. From history taking, your approach was fine. Obviously, there can be other cancers, which, and as a result, then you can have these vulval secondaries as well. So the cancer of obviously what the cancer organs are there. So just give her some idea about as well the cancer. It can be the cancer of in the bladder or bowel. And then ask about the specific histories. I wouldn't just simply say, is your water works okay? Or do you have any problems with your water work? If you are thinking there can be cancer of bladder and bowel, we need to ask very focused questions to exclude malignancy of these organs, right? So I will be asking, do you have any pain in lower part of your abdomen? Have you noticed any blood in your urine? A difficulty in passing urine? And for bowel, I will ask clearly any change in your bowel habits. Not only, that I just ask because sometimes some people it's usual for them to open their bowels after 2 days or something. So it's a change which is more important. And then ask for presence of any blood in their stool. Okay, so that was from a bit of history. The cancer, you did ask about the signs, change in weight and all those. Now you go back. Ask about appetite. Those are the generalized signs. Yeah, loss of appetite and change in weight. The family history you did ask, that was good. Ask about overall general medical and the surgical history as well. smoking, and all those risk factors which can predispose, just if make sure you ask them. So you did ask about the BMI, which is fine, diabetes, she told you. Just ask about the smoking and stuff as well. Okay, so this is the history. Say this woman gave us, she has 3 yeah, she's para 3. You need to ask. Okay, so other thing which you are supposed to ask from this woman was, if we are saying, it could be associated with your bowels and bladder as well. It's very important to ask them any perianal itching, any itching or soreness around their back passage. Yeah. It's also important to ask about their mammograms or any symptoms in their breast, any lumps or any, any itching and soreness in their alveolar area. And then ask about the history of their cervical smears as well. Okay, so these are a few things. So just ask, when you ask about the breast, obviously make sure she's obviously 65. She should be going through the regular mammograms as well. Just ask when was the last one and was it normal, because we want to explore it. Okay, so these were the questions the woman I'm told was asking. So what is it? Okay, so first how we explain the condition. Okay, so in the technical terminology first, it is skin cancer, but it's not invasive. It is confined only to the top layers. Okay, the way you can, it just kind of the way you will explain VIN as well. Basically, you can apply these things to VI if the station was VIN 3 or VIN 2 as well. Okay, so to make it simple, instead of taking a complex name of the disease to start with, and then try to explain, just make simple, just tell. So what happens, the skin of the vulva, the skin have few layers of the cells. Okay, few layers of the cells. And sometimes there are some abnormal changes. We can call them cancerous changes in the top layers of the skin, and that condition is called Paget's disease. Okay, it is type of cancer, but the good thing about this particular type of cancer is that it remains confined to these top layers and it's not gone deeper. So for that reason, it's very easy to treat this one if we can diagnose it at the right time. Okay, and start the treatment at the right time. So this is how you can reassure, and then you can say, so yeah, I'm afraid your the report of your tissue also shows that you have this condition, what we called Paget's disease, and we call it non-invasive, means is confined only to the top layers and it hasn't gone deeper. Okay, this is how you can explain her. And then further you can state, like, how if she says, if she asks you any question, if she's upset and she's getting, this one, have I got cancer, so I'm going to die, or anything like that, obviously you can reassure. It's only confined to the, to the surface of the top layers, and we can take it. And that just is like, it is from your sweat glands. In simple words, you can go tell that. And then you will explain the reasons. Okay, so the cause is usually is not fully understood still. What exactly causes? Sometimes people can actually have this disease or this type of cancer somewhere else in their body, like in their bowel or the bladder. And then it can, they can be, this vulval skin can get affected as well. Okay, or other parts of the body can get affected as well, like it can be in their underarms, or it can be even in their head. So then ask those symptoms as well. Do you have any, just ask about those itching and symptoms in axilla and also on the scalp. So I've just given in here, yeah? So just ask for hematuria, dysuria, perianal area itching, rash in groins or any other areas, flexures, etc. Then you come to, so just go like system-wise, yeah? Each one organ at one time. Any vaginal itching or soreness, such as any superficial dyspareunia, then bowel symptoms, perianal symptoms, rash or soreness in the area, and then bowel-related cancer symptoms, yeah? That's very important to ask about, have they noticed any, any lumps in their groins? Because if it's vulvar cancer, yes, the report tells us non-invasive, but if it's invasive or something, it's involving other regional areas as well, then the lymph nodes are very important. So ask about that. Ask about any symptom as a like in nipple or areolar area, and then ask about have they been going through their mammograms and have they normal cervical screening. And after you have just talked and taken all that history and explained her, it can be because of these days, then what we're going to do now for the treatment point of view. And in the treatment, then first of all, obviously, you will say, I'm going to discuss and inform my consultant, and we will need to arrange a few more tests to beforehand to know if there is any other organ like your bowel or bladder involved. So there will be some scan we might do. And then, we will arrange that meeting with our team of doctors. We call it multidisciplinary team. And then in simple words, explain that would involve like the consultant, my consultant, gynae cancer doctors, and radiologist who will do all these scans, and histopathologist who does give us this tissue report. So then depending upon what symptoms she has given, if she has given some urinary symptoms, then obviously we will talk about, like, we may need to do put a camera inside your bladder as well to see if there is any this disease is present in the bladder as well. And if she give any perianal or rectal symptoms, then you will include proctoscopy. So that will all depend what she is. But these tests you will probably do as a routine anyway, because we want to exclude. So do CEA for bowel cancers. And if she says there is some palpable nodes, then obviously we need to do scan of the nodes as well, and biopsy if they are enlarged. You will need to do, this will be done anyway, pelvic and abdominal ultrasound scan. And then, MRI and CT scan, that can be obviously decided after discussion with the consultant. So you can just all just tell to her like these will be the term, but I'm going to discuss with the consultant, and then we'll arrange these tests for you. And once we have the results, then we're going to have discussion in the MTT. Treatment obviously, so in the examination you need to include them all as well. So in the examination you will say first vulval examination, inguinal lymph nodes palpation, then you're going to do spectrum examination to look into the vagina, then you're going to have a look around in the perianal area as well. Then if she give any type of symptoms of in the nipple or in the alveolar area, then you will obviously examine that as well, and respectively if she has any symptoms, axilla and those stuff. Otherwise, obviously, you don't need to examine them. And then what is the treatment? Okay, so treatment basically is mainly you will be doing surgery. If it's confined small patches and it's only the vulvar one, we can just remove them. So she has the biopsy, so we need to establish, and you did very well in the beginning. I mean, I will start in the beginning. You did ask about the healing of the biopsy. You could start right in the beginning. So when did you have that biopsy, and did that heal properly? And have your symptoms improved? Because sometime if it's a smaller age, it may be the complete excision already and send for the biopsy. So what I will start, the way I will say, okay, so depending upon the area affected, if it's a small part, it can be removed completely, because it's just the top superficial layers of the skin. It can removed easily, and that's all we need. There are some other treatments available as well. And then just talk about the imicamod, talk about the laser and radiotherapy. Radiotherapy will be done, I will explain in a minute, depending on the histopathology. So you will say, so the treatment option in your particular circumstances, first I will ask, has they removed the all affected area? If she says yes, they removed it all, then I will say, okay. So the treatment option will depend very much on the detail of the report of your histopathology, which I haven't got with me. So I will speak to the histopathologist, because it's very important then for us to understand whether all the affected area was removed completely, and then there was some normal margins on the side as well. If that's the case, then that's all we needed to do that. And now from onward, we will just arrange your follow-ups. This disease does require a long-term follow-up, because it can come back. So that will be like, we will explain you in detail afterwards. We will be frequently calling you to examine your skin, and if any stage again, if we have any suspicion, to repeat your biopsy just to make sure that it's not coming back. Other options can be, then obviously you can talk about the imicamod and radiotherapy. You will speak and say that is usually done if the affected area is not completely removed, and at the large areas, there are multiple patches, and particularly if the nodes in that area are involved, then radiotherapy can be a good option. However, this all will be discussed and decided by that MDT. All right. So these are for 5-fluorouracil cream can also be used. Cryotherapy can be used. So these are the few options you will do, and these are the few investigations you will be doing. Yeah. See cervical breast screening, check that one. Pelvic imaging, ultrasound scans will be done. Colonoscopy, cystoscopy, or proctoscopy will depend if she has any signs. Yeah. Vulvoscopy and vaginoscopy can be done. Any questions? So obviously don't forget to offer support counseling to this woman as well, because when we will tell it's a cancer, the video show as well is not, the cancer which penetrate deeply. So that's why it's very easy to treat if it's just localized in this area, not originating from other parts of the body. And still offer counseling, written information, and then just tell her I will contact you to make your appointment after our MDT meeting. So I can take 2 quick questions before we go to the next one.
Dr. Safia, it will be written Paget disease diagnosis, because sometimes we cannot diagnose from the picture.
No, it was given. So the girls have told me it was given. The histology report was given. Basically, the notes were given. So in the notes, it was already written that there was like this woman came in with and it used these creams, and then there were operation biopsy notes given as well. Then histopathology report was given over there. So if for any reason it happens to online exam again this time, so there will be a screen obviously open to you. So read the screen, and then please don't forget to scroll down the screen, okay? Because there will be quite few, the notes or histopathology or things down there. So when you're reading, scroll down the screen to make sure if there is anything else down there as well or not, okay? To find out what has been given there. Right. Any other question? Okay, who is next?
Reena.
Priya? Who?
Rimi,
Sorry?
my
Reena.
number.
Reena.
Okay, Reena. Okay, so so this is VIN. So VIN will be done almost the same way, the way you need to explain again the layers of the skin, and then you can say there are. But in this case, obviously, you will say abnormal changes. Okay. In the cells, depending upon if it's type 1, you will say the top 1/3 layer is affected. If it's VN2, you will say the top 2/3, and if it's VN3, you will say all the layers of the skin are. But the good thing is it has not gone deeper than skin. All right, so then you will go. So if she says, is it cancer? No. In this case, yes, you will say, no, this is not cancer. These are pre-cancerous stages, abnormal changes. However, it's very important that we remove them and treat them, because if we didn't, then there is a very high possibility they can change into cancer. So this is how you explain VIN. Yeah, history taking almost will be similar. You will need to still ask about the, so because it's HPV, ask about any presence of previous genital warts, smoking, and also any rash or itching in the perianal area as well, because they can be AIN as well. Ask about the history of smears is important as well, and are they up to date? Yeah, so the rest history will be same.
We can ask here, are you updating yearly smear, because she's HIV, so she has to repeat the smear. How frequent, or any question we have to ask, like?
So for HIV patient, we do smears every year. All you need to do is, do you go for your teen smear calls? You don't need to go into details for the smear. Don't worry about the ones. They know. So they are on the call system for yearly smears. So just say, are you up to date with your smears? That's enough to us. Are you up to date with your smears? And obviously, if she says, then have they always been normal, or you have any smears been reported abnormal? So that's one. So for this woman, obviously, again, you need to examine the inguinal lymph nodes, and then there will be vulvoscopy, obviously, and then you will just offer the treatments in here will be obviously imicomod, and it can be excision as well. It can be imicomod, it can be laser, it can be, well, cryotherapy is not the option for that particular one. Right, okay, so let's go to the next one.
Which station? I will not do this before one station. Which scenario I have to do?
Sorry? This one is for
Oh,
you.
okay.
That I just went over because that's very similar to Page's
Yeah, no
disease
problem.
scenario, which we have done. So I just gave you guys a little bit of brief about that, how you explain VIN really. So let's do this one.
Doctor, that was CIN. That was cervical, this thing, abnormal cervical.
Yeah,
That previous bit was.
Sorry. Okay, she's severe dyskaryosis. Yeah.
yeah, CN3. I mean, it
Okay. Do
is
you want to?
no
Yeah. Do
problem. I
you?
can do the another, no problem.
So, I mean, severe dyskaryosis are HPV positive. This will be same again. I mean, you need to just say again, the skin of the neck of the womb has these different layers, and then there can be abnormal changes. So, I mean, the treatment theoretically, you know, so you can just tell her like, no, we need to send you for colposcopy. And they will apply that, you know, some mild acid on that to look for the changes, and then they can take biopsy from there. She may decide to, if it's a smaller area, she may decide to remove it all. Otherwise, your further treatment will depend what the result come back. Yeah. I mean, we can't do these as well. What I want to do is the similar stations, if I can give you the idea and you can do them, let's do, if we just do, you know, those ones, then we may not be able to do some other entirely different stations. So let's do post-menopausal bleeding first, and then we will say if we have time at the end, if you wanted to do, if we are left with any cases, we can do them. Okay, so I start your 2 minutes now.
This is a structure discussion. Hello.
So it says you are seeing 55 years old woman, so it's role player.
Because okay, appraisal, this meeting, something it was written.
Yeah, so your consultant is not available to see this woman because he's in the appraisal meeting, so you are asked to see this woman. Okay.
Okay. Can I start?
2 minutes just over. Yeah.
Hello, I'm Dr. Reena Kumari, doctor in Gynae Clinic today. Are you John Smith?
Yes, doctor, my name is John Smith.
How would you like to be? May I confirm your age?
Yes, I'm 55 years old, doctor.
How would you like to be addressed?
You can call me Joe.
Joe, from your first of all, I want to excuse you because our consultant is away due to some meeting. So, is it okay if I ask you a few questions to know about you and continue your consultation?
Yeah, that's okay, doctor. No problem.
Okay, thank you. So, Joe, can you tell me about your problem? So, and how I
Yeah,
can help
so
you?
I'm a bit bothered about this some change in my discharge. I have noticed my discharge has become a little bit excessive than before, and there is some smell in the discharge as well. So yeah, that's why my doctor sent me here.
Since how long you have this problem?
That's going on for well, it's been a few weeks. I did have a little bit of bleeding as well. About first I had about 2 months ago, and then a little bit again after a few weeks. And since then, I have noticed my discharge is not really right.
Can you tell me more about this bleeding?
There was very mild, very little bleeding. I noticed on wiping, and it stopped. There was a bit of staining on the panty liner. It stopped in few hours, and then I have a little bit again, maybe just 2 weeks about. Nothing since then.
Any tummy pain?
No, I haven't noticed any pain in my tummy.
Any problem with the bowel?
No,
Any
no.
water work?
No, I haven't noticed any problem in passing urine, no.
Okay. Did you? How's your appetite?
It's been fine.
Okay. Any weight loss?
No, I haven't noticed any.
You said you have a semi discharge. So do you noted any fever,
No, I
feeling
haven't noticed
unwell?
any feeling or any, no.
So, Joe, from your case notes, I can see you are in the tamoxifen since 5 years for the your breast cancer. I am really sorry about that. Can you tell me, are you regularly following with your breast clinic?
Yes, I have been following. I've been seeing them whenever they send me an appointment.
Okay. Did you receive any treatment or you have seen before to GP with this problem? You said you have a two bout of bleeding.
No, that's why he sent me here. He sounded like I really need to be seen here in this clinic.
Okay, so do you have I can see you are menopause. So when are you updated with your smear?
Yes, I have been up to date with smears, and they have always been normal.
Okay, some personal question I want to ask you. Are you in relation?
Yes, I live with my husband, yeah.
Yeah, so are you sexually active?
Yeah.
Okay, do you have any bleeding after the sex?
No, no bleeding after sex.
Any pain while sex?
No.
Okay, so do you have any health issue for that following to your GP?
Yes, I have been recently diagnosed with high blood pressure as well. He's just been keeping an eye on that at the minute. I also have diabetes. Um, that's well controlled on the tablets I'm taking.
Okay, good to hear that. So, any health issue in your family, like any cancer, bowel, bladder, or womb cancer, any any type?
Yeah, this breast cancer is something which runs in our family. My mom had it, and my mom's sister also had it.
How they are?
Well, they've been doing okay with the treatment.
Okay, good to hear that. What you do for a living?
So I work on a farm.
Okay. Okay. Do you have enough support at home?
Yeah, my partner is very supportive.
Okay. Do you smoke?
Well, I am trying to quit smoking at the moment. I have cut off quite a lot. Currently, I'm on about 2-3 cigarettes a day. I have been trying to cut off it completely.
Do you drink alcohol?
Yes, I do over the weekends.
Okay. Are you aware about height weight ratio?
Yeah, my weight height ratio is 29.
So, Joe, thanks for information. I would like to do your examination in front of the phone in with your permission to check your tummy for any mass, any tender area. Actually, to look at it, vagina to see what is the reason for bleeding. Is it okay for you?
Yeah, that's all right.
Okay. Okay. And thank you, Joe. So, will you give me any finding or anything?
Yeah, this spectrum examination and cervical examination is unremarkable.
Okay. So, Joe, from your examination, I couldn't find what is the reason for bleeding. So, I would like to offer you a investigation to see ultrasound of a womb and to see what is the reason of this bleeding.
Okay.
And I will run some blood investigation as you are complaining. You are saying you have a bleeding to see amount of the blood in your body, as well like to see some investigation other to how your body organs are working, like liver and kidney.
All right. Okay.
Okay, so ultrasound report.
No, we haven't. It's up to this now. So she's just come. So you need to tell us what you want to do.
Yeah, I want to do the ultrasound to do the to check any what could be a reason in ultrasound. Sometime the medication you are taking, tamoxifen, these are their effect on the lining of the womb. It can cause the thinning of the lining of a womb, or can cause the overgrowth of the lining of womb. So we
Okay.
call it endometrial hyperplasia. So, and as well as if we don't find any reason, so we need to do a hysteroscopy, a camera test to check inside the womb
Okay.
to find out the reason.
All right. Okay, doctor. Could it be like something related to cancer?
At a moment from your history, I couldn't find the reason there is any chance of the cancer. But fine, we will do the hysteroscopy, a test. Look at the, this is a womb. Okay, this is the neck of
Okay.
womb. We put the camera through the neck of womb and look at the womb, and we will take some piece of the tissue from the lining of womb, and we will send it to laboratory to see what could be a reason for it.
Right. Okay. Okay.
Okay, do you have any question? And
Um,
tell Joe,
okay.
do
So
you
you
want?
said this medicine I'm taking, tamoxifen, can make this thickening. So should I stop taking this
Yeah, I will
medicine?
contact as you already took the 5 year. So I will contact with your breast doctor, and usually this medication is stopped at a 5 year. So we have this other option. We will confirm with this breast doctor, and other is the option we can. After this biopsy report, we can remove the womb.
You remove my womb. Why, doctor?
Uh, because we will decide after the diagnosis what is our findings.
Okay. Right. The time is over.
Yeah, but after the ultrasound report, we can go for the.
Okay. That's okay.
Yeah.
Anything else you want to add up?
Yeah. So uh, no, you
Okay.
can give us the answer.
All right. That's fine. Then we can stop here then. Okay, good. Thank you for attempting this question. So, yeah, it was okay. Tamoxifen, and I think at the end you got a bit
5 years is we can
into
stop the
trouble.
5 years.
It's
Yeah.
fine. You can just simply say yeah, it was okay just to say usually it is stop, but I would rather leave it for the surgeons to decide. So my answer will be no, do not stop your medication, because what she's saying is she's worried now that this medicine is causing her problems. So shall I stop? So most important here is to basically advise her that she must continue till she's advised by her doctors. Okay, so I will say no, it's important you continue to take your medication. At this stage, however, I'm going to urgently write a letter to your breast cancer team as well to get further advice from them. Okay, so then they can advise you what would they like to do. So that will be the advice about tamoxifen. When she says the breast cancer runs in the family, I would like to ask about, so have they done that one particular test they do to find out some presence of specific gene? So I would just take that information there as well. So to start with, it says your consultant is in the appraisal meeting with your other colleagues, so that's why you're seeing the patient. So you started nicely, Joe. You asked her, and then you said, "Well, my consultant is in the is not able to come and see you," then you need to kind of get permission from her. Will she be okay to see you? Yeah, so I will ask her. So my consultant is actually, I'm not going to obviously give the details, is caught up with some other task at the moment and not available. Will it be okay if I can see you instead of him, and then I can discuss with him about your problem? Yeah, so just you can just say simply, you can say, I would like to apologize, my consultant is not available at the moment, so instead I have come to see you. Will that be okay with you? Okay, so one of these statements you can take. Then you start with the history taking, or with the opening questions. Now just from the feedback point of view, I just added that abnormal discharge as well to add up, because that's very common problem, which the mistake which people make. Are you able to hear me?
Sorry, I didn't hear last sentence. Vaginal discharge, you said something.
Yeah, so I did up vaginal discharge just last minute really. And the reason for that is this is one common mistake, or whatever thing goes wrong in the exam with the candidates. You see the scenario and you feel this scenario is about this particular recall. It's post-menopausal bleeding or blah, blah, blah. And then you completely focus on that and you forget anything else the patient has told. So always keep that in mind as well, yeah? So if I'm saying I have abnormal discharge as well,
I took
uh,
the swab. Take the swabs.
yeah, so offer the swab as well, and do a little bit
Yeah.
of sexual health screen as well, just ask about any of the symptoms and the risk of STI by asking, does she have sex with
So
anybody
one
else?
question here I will ask, because they are saying don't ask 55-year STI.
Oh,
So
who
because
said
they are,
that?
I don't know, I heard from the other mentor.
Okay. No, that's not,
And
that's
I was thinking maybe she has a endometrial polyp or
right,
maybe malignancy.
right.
That's why I
No,
asked the
no, no,
post-menopause
no,
cancer
no,
question.
no. No, 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 no. We don't have to make any false assumptions on our own. And then why not 50 years old? Life doesn't shut up on a 50 years old person. Okay. So, okay, anyway, I'm gonna kind of give you model answer how you could do that, yeah? So you did nicely, you did, I wouldn't say it was not good, okay? So yeah, so open up, introduce yourself after telling consultant is not there, just ask the name and date of birth, ask how would you like to call me? And then just, start with open question just by saying, okay, so your doctor has sent you to us because you have some bleeding. Would you like to tell me more about your bleeding? Yeah. So, so before bleeding, I started talking about my discharge because that is something currently happen, and I'm more worried about it. But that's okay. Just take that history, just take that information as well. Okay. So how long you have noted this abnormal discharge? Have you got any itching and any soreness down there because of this discharge? And did you get, have you noticed any rash down there? Did you have you any, notice so bleeding? Then you can build up on the bleeding. I can see you had some bleeding as well. Would you like to tell me more about when was the first time you had, how much the bleeding was? She sure it was a little bit, then ask the second. And then just check, did you, speak to your doctor about your bleeding at that stage? No, whatever, she obviously delayed a little bit. Go more into now keeping discharge in your mind. Do you have any pain in your tummy, any bleeding after sex, and any pain during sex? Okay. Then if you want to go and want to ask about the sexual history, so please don't get into false assumptions that people are active, and they can have sex with casual partner as well sometime under the effect of a maybe new partner or something. So even at the age of 70s, and the people are at risk of getting STIs. Anybody who's sexually active is risk of STIs. So it's absolutely okay to ask this question, but yes, you can ask that in a sensitive manner so they don't mind it. So you said I want to ask you some social questions, but then you didn't ask me whether I will be okay with that. Yeah. So just then you can say, so I would like to ask you a few questions regarding your social and sexual lifestyle. Will that be okay with you? And after that, it's absolutely fine. If she says yes, then she's not prepared to have that intimate talk. So then you just ask, okay, so are you, how long have you been with your current partner? Do you have sexual contact with anybody else in last 3 months' time? Um, can the mics go off, please? And have you been diagnosed with any sexually transmitted infections in the past? Okay. So, okay, so that will be the questions about sexual, and you can ask about smoking in that section as well, drinking, any drugs, and that's done there. Okay, and then you mics off, please, everybody. Okay. Hmm, let me see who is
Sorry, Dr. Sabine,
Roxana, can you switch off the mic?
can I ask a question here, please?
Yeah.
So,
Yes.
I understand that we have to rule out the risk of STIs in any age group. I mean, you're right that it can be even in 65, 70 years old
Yeah.
women as well. But with
Yeah.
this scenario, with someone who is on tamoxifen with a history of breast cancer and PMB, should we really do some? I mean, if I'm asking about any vaginal discharge, in my mind, I would be more thinking about the possibility of any vaginal cancer or any
Yes.
hematometra, um,
Yes. Yeah.
rather than asking about the sexual partners over the past 3 months. Definitely, if she starts
Yeah.
giving me history of pain and fever and
No,
dyspareunia,
that's
then I
yeah.
would
So that's
hide my
Sadia. Yeah. So that's this thing we get. This is like calling card. We get prejudgmental in the diagnosis. Yeah.
hmm
There's no doubt she has a postmenopausal bleeding. Our main concern is endometrial cancer, and we're going to rule it out. But please do not forget the other parallel signs as well. She might be having some BB going on. Maybe not anything else. Maybe just BB. So
Yeah,
if she is giving that complaint, that means she's bothered about that complaint. Yeah.
yeah,
if
yeah,
if she's
exactly.
not, she won't start, with she will be coming just because of the bleeding. She has been told, GP refer and said, because you have this bleeding, we would like you to get checked, how the GP refer work. Yeah. So she has been
Mm,
sent to us for postmenopausal bleeding. But if she then start with the vaginal discharge, why not
hmm
to ask a couple of these questions, just to do that swabs as well.
Yeah,
And it's not uncommon. I mean, people can have chlamydia going on with their post-menopausal bleeding as well. Yeah, and
Yeah,
who
true.
knows, she might have actually the chlamydia which caused cervicitis, and that's why she had those 2 small episodes of postmenopausal bleeding.
Yeah, true.
So if you
Thank you,
don't
Dr.
check,
Hmm.
we completely, lose that. So just keep things simple. Basics, always stick to your basics and simples. Yeah. Okay. So after that, I mean, I went on that side because she mentioned about 55 years old, so I went in more details about there. Okay, so then coming to the bleeding, you will say, obviously, just take the history. Now, postmenopausal bleeding, obviously, you need to keep these 3 things in your mind. The differential diagnosis can be starting from simple things. Obviously, could be. I mean, obviously, that's less likely cause, but it is there. With the age, advanced age as well, if they are like some 65 or 67 years old or something, could be even atrophic vaginitis. That can also give a little bit of bleeding. Cervicitis, abnormal cervical smear, it could be cervical reason, polyp or any cervical cancer. It can be endometrial cancer. So go in ascending order to think about possible reasons why. And then there's the discharge also. Can be because of all these reasons. Yes, infection is one of the reasons there, or maybe just bacterial vaginosis. And then yes, polyp, endometritis or endometrial hyperplasia. All these can also give the discharge. So, so keep DT in your mind and then ask your questions to exclude those DTs one by one. Okay, so first of all, endometrial, because she's antamoxifen, there's our more strong concern here, endometrial cancer. So just ask history related to that. So I will start with the breast cancer, but I can see you have been on this tamoxifen treatment for this one. So yes, check if she has been attending her breast cancer treatment and how is her disease control and everything. And then also, is there any family history of breast cancer? Was she told this is the type of the cancer which runs in the family, or she had that test and what was the result? Then you ask about, keep other risk factors of this in mind. So ask about obesity, BMI. She told you about diabetes as well. She told you about hypertension. Then you can ask about, I would like to ask about number of children as well. Does she has any children and how many children she has? And then you ask about the cervical screening. Is that up to date? And any abnormal smears in the past. Then you can ask about the signs of malignancy, which you did. So just ask about have you noticed any loss in your appetite, a decreased appetite, any change in your weight, any change in your bowel habits, and are any problem in passing urine or any blood in urine? So these were the few of history. BMI, which is important. And then, yes, you come to the examination. And on the examination, yes, you will say, I mean, pulse blood pressure, if in OPD, if you even don't mention, that doesn't matter, pulse blood pressure, unless she's heavily bleeding or something. So the examination is, I would like to examine you in the presence of chaperone, if that's okay with you. Yeah, instead of saying if you will give me the permission, this is more natural work to say if that's okay with you, or will you be all right with this, or yeah. And then you say, okay, so and then explain what examination. So what I will do then, I will, just examine you down there. I will put a speculum, have a look inside your vagina and the neck of the womb, just like as you do with your smears. And then because you said you have some, you have noticed some change in your discharge as well, I can. So you're going to offer here, I can take a swab to check for any sexually transmitted infections as well, like chlamydia and gonorrhea. Is that okay with you? If she doesn't want to, if she feels she's not a risk, if you say, no, I don't think so, I really need it. Okay. So yes, so just offer that one, and then you say, I will have a look on the neck of the womb to see if the bleeding is happening from there. And then, we will take things accordingly. So then it's important with the postmenopausal bleeding, obviously we're going to send them to postmenopausal bleeding clinic. So we need to talk about 2 weeks fast track referral. Yeah. So then I will say, and I will start explaining to her to say, so when, somebody has bleeding, when they're postmenopause, we always like to do some tests to make sure that there is no abnormal changes or any precancerous or cancerous changes in the lining of the womb. And particularly the people who are taking this medication, tamoxifen, this medication can cause thickening of the lining of the womb. And when the lining of the womb is thickened, there is a risk that some abnormal changes or cancerous changes can happen in that lining. Okay, so she might have that actually information already. So for that reason, I'm going to arrange your urgent referral to our specialist clinic. We call it Post-Menopausal Clinic. You will be seen there within 2 weeks. And in that clinic, you will have internal scan done, in which they will, measure the thickness of your lining of the womb, and they will also, have a look on your ovaries. And then, depending upon the report of that scan, you will be seen by, one of the gynae doctors there in the same clinic after the scan. And then, depending upon the result of your scan report, they may decide to put a camera inside your womb to have a direct look, and then take a sample from the lining of the womb. Okay, so that's about hysteroscopy. We call it hysteroscopy. So that will be done. And then the other important thing obviously you need to tell her is that I'm going to urgently contact your breast cancer team as well to inform them about your this bleeding, and also to get further advice on your use of tamoxifen. So I'm not going to say anything about stopping or anything. All we need to do is just to contact them and tell her we're going to do that. Okay, so that's all. I wouldn't go into hysterectomy and all that stuff at this stage. I'm not going to give her, say, unless she asks me. So I would just mildly tell her that there can't be a risk of, if the lining is thicker, there can be risk of cancer in there. I'm not going to use the words of hyperplasia, endometrial hyperplasia, or any cancer and any treatments after that. At this stage, the important one is for you to actually tell her having fast track referral, scan, hysteroscopy, and biopsy. And then we will, treat it accordingly, taking things from there. And then, yeah, so just check with her as well. Just make sure, just tell her, are you available in these 2 weeks? It's very important that you do attend this appointment. And then just say, I will give you some written information as well. Questions? I mean, say invite her if she wants to ask anything. Yeah, so questions to you guys as well. Yep.
Yeah, and what is like we should not tell about any blood tests or urine tests in this case because she is a known case of hypertension. So we will not check her urine albumin or we will not rule out UTI also and hemoglobin because she has episodes of bleeding and in for TC also. And as she is on tamoxifen, so we should not do her LFT also. All these things we should tell or no.
Okay. So the things in NHS work in slightly different way. There is a lot of story of who is going to pay for those tests and stuff as well. So from a tamoxifen point of view, their breast team is keeping all that follow-up. So they are doing whatever they need to do, LFTs or whatever they require to do. If she hasn't given me any history of dysuria or anything, I don't need to do any test on the urine. Analysis and stuff. Yeah, if she gave me history of dysuria frequency, then yes, I will exclude UTI. So I will just leave then. And that the second thing you need to always ask at this stage, what I need to achieve from these tests. Yeah, so hypertension, yes, that's GP's problem. Yeah, she said, didn't she? I have been recently diagnosed, but my GP is keeping an eye on that. Okay, so it's GP's problem, blood pressure. When it will become my problem will be, I would like to know all these when our biopsy report come back and say she has endometrial hyperplasia with atypia, or she has some endometrial cancer, and now we need to take her for surgery. Now she become my problem. All these tests as well, because now I need to make sure her fitness for her surgical and for anesthesia. Then I need to do LFTs and all that stuff. So at this stage, I don't need to do any LFTs, hemoglobin and stuff. The amount of bleeding she has told is just mild wipe and all that stuff. That's not going to make her hemoglobin fall that badly. So the reason is, I mean, in the textbook, this all is fine. But when you are sitting in OPD, this is your OPD, yeah? You have about 20 minutes maximum slot time to see the patients, yeah? In exam, that's reduced further to 10 minutes. If you will start talking about all these things, which are not really required and relevant at this stage, you're going to miss them. Obviously, your bell is going to go ring in 10 minutes. You have no chance to then, say or do important things, which were really required. So don't get confused into those tests. Always, what examination I need to do, what test I need to do, ask yourself why I need to do it. At this stage, do I need them, right? So don't worry about them.
So,
Excuse
Dr.
me, madam.
Safia, only we will explain the differential diagnosis and investigation and further care according to the cause.
Yeah.
and we will end our
How to
consultation.
ask multiple sexual partners and how to mention about BRCA genes in this scenario, like in a
Okay.
patient's lament.
Okay, so the simple question we will ask when she says I have been diagnosed with the breast cancer or even ovarian cancer, the very simple question that you must ask is like, was you told this is the type of the cancer which runs in the family? Did they do that test which we do for the presence of specific gene to find out? Yeah, that's the question. You don't need to at this stage talk about BRCA1 and BRCA2 and so on, unless obviously you're dealing with the breast cancer case. Then you need to explain. Because she has, again, don't forget, she has been dealing with this cancer for the last 5 years. She's being seen by the breast cancer team. Their team has done all those things, you know, taking history, breaking bad news, treating her, explaining her what all that is. So you just focus on the things and the relevant things which can affect your management plan are, right? Focus to them. These are very
Dr.
basic
Safia,
questions. Yeah.
Dr. Safia, management, hello.
Yes, go on.
Yeah. So Dr. Safia, management plan here means just up to hysteroscopy and not beyond that, right?
Biopsy, up to biopsy, yeah. Because
Okay,
what can we
thank you.
discuss beyond that? Yeah, just give yourself a simple thought as a common sense. Yeah, again, keeping things simple. It just
Okay.
will be, I mean, I can sit for hours otherwise to explain when we do the biopsy results come back in 3 various ways. So just imagine if you actually want to give that, what happens? Obviously, there are 3 possibilities now. The one will be it's normal, nothing wrong. The second is may become as a hyperplasia. Then hyperplasia may be simple hyperplasia, in which we just need to give the Mirena coil. Hyperplasia may be with the atypia. Yeah, okay, if we say atypia, we may need to do the hysterectomy. The biopsy report may become as a endometrial cancer. And if that comes as a cancer, then we need to do surgery. And, you know, sometimes we treat that with the chemotherapy, then sometimes we treat with the radiotherapy. How long you can do? So why to talk about that scenario, which is not there yet?
Okay.
It might
Thank you,
just
ma'am.
come back as a normal. Simply just say, we will send the result. And then once the result is back, then we will make your appointment and discuss further management according to that result. Okay, the rest of the questions you can go on Telegram group and post there. I will answer. And I must say, you girls are still not active, right? Please, and this is a
Madam,
time you need to put the effort. Only one a question or something, you know. There should be loads of questions coming over there, because the way I tell you, okay, you have done this now in this week. Try to do more scenarios, similar scenarios, and this. No, this is the time. You know, these exams, part 3 exam particularly is about the technique of preparation. Okay. And the technique of preparation is that actually these 2 months are very important for you guys to be fully preparing for that. And the people make the mistake they're doing. I know you all are busy, honestly. I have done this exam as well, doing the duties and everything. It's extremely busy time. We have full-time duties and everything. But the situation will become even worse if we actually not, you know, pushing ourselves too much. You will be pushing yourself then. So in the first week of September, you will apply for the seat, then you get the seat. And then imagine you will have to push yourself 4 times harder to prepare for the exam in last those 7 or 8 weeks. Why not add these 4 weeks as well to that, 4, 5 weeks? So please, right from now, go mad with your preparation. This is the time. Every day you must, you know, you should just be in examination mode. Obviously ask your families to help you and facilitate you with that. You know, I absolutely understand it's difficult, but unfortunately this is how these exams needs to be prepared. Okay, so ask maximum questions. At the end you will become, there is a stress, then the duty is going on, stress of not being very much clear about many things, and then all get so much mixed up that reduces your efficiency to 50%. So spread it out. Right.
should we talk like we'll give you the written informations and come with the come with a family member to discuss a report of this hysteroscopy, something like that? How we should end this session?
Okay, so I will end by saying, so you will have that scan, internal scan done, and then you will be seen by a gynae doctor over there, depending upon the report of your scan. I'm not even going into thickness, details and stuff. Depending upon the report of your scan, they may decide to put a camera inside your womb to have a good look and take a sample to send it for biopsy. We call it hysteroscopy. okay? And then that sample will be sent for detailed examination of the tissue and then, depending upon what the result is, we will contact you and offer you an appointment. So we can tell her if it's abnormal result. At that time, bring somebody with you, right? Don't worry about it at this stage. Please keep it simple. The rest of the questions must go on Telegram. So we're moving to the next station because otherwise we will keep sitting there for 3 days. Okay.
Sadia.
Satya,
Yes.
this is for you then. So we go further. So let's see, this lady, your lady has that done now. No, well, this is a young lady. She's 30 years old. 2 minutes starts now.
Okay.
फैज़ खाना है खा ले अम्मी ना बने अब अम्मी की तरह
Okay. So Sadia, your first 2 minutes are over. Let's start.
Okay. Hello, my name is Dr. Khatwani and I'm the registrar covering this clinic. May I take your name and date of birth, please?
Yes, doctor. My name is Susanna Harrison. I'm 30 years old.
Okay. And how would you like me to call you?
Yeah, you can call me Susanna.
Okay, Susanna. So, Susanna, I understand that you were having some irregular periods which have been ongoing for the past 6 months. Is
That's
that
right,
right?
doctor. Yeah.
Yeah. And you came, had a scan, and then a biopsy was taken in the clinic?
Yeah, that's right. I had that done last week.
Yeah, okay. So, did anyone discuss with you the scan, the biopsy report?
No, I was supposed to come back in 4 weeks, but they rang me yesterday and offered this appointment. So I'm really worried, about the report. No, I don't know obviously about the report yet.
Okay, so I will tell you about the report, which has come back a bit unexpected, and that's why we called you earlier to discuss it with you. So before
No.
I can tell you the report,
Mm-hmm.
do you have anyone accompanying you, or would you want anyone to come and have this appointment with yourself in the clinic today with me?
Well, no, my partner been on work today, so I've just come on my own. I will be all right. You can just give me the results, whatever they are.
Okay, so Susanna, the biopsy report shows that the inner lining of the womb, I will keep drawing as I'm telling you. So this is womb and this is the inner lining, which usually sheds and we get the periods. So this inner lining of your womb has got thick, and that might be the cause of your symptoms that you're having irregular bleeding. Now,
Yeah,
when
okay.
it becomes thick, it can sometimes be associated with some changes, which can be associated with cancer if not treated.
Right, okay.
Yeah. So I'm not saying that at the moment it has come back as cancer, but it
Mm-hmm.
is something which, if left untreated, can go on to become cancer over the
Okay.
over a certain time period.
Right, okay. So, how can I treat this then?
Mhm. So, in order to discuss the treatment option with you, I would like some more information because I'm seeing you for the first time and I can see your notes, but I want to confirm some symptoms with you. Is that all right?
Yeah, that's fine, doctor. Yeah.
Okay. So, you are 30 years of age, and do you have any children?
No, we haven't. And actually, we are, we want to start family
Mhm.
soon. So, no, I have never been pregnant before.
Okay. And how are your periods before these 6 months' time? Now, for the 6 months, I can see they are irregular. Your
Yeah.
previous cycle was normal.
Yeah, that was normal, pretty regular. I had been taking combined pill, and then my period just started. In spite of being in the pill, they started being irregular, and that's why I
Okay.
had these tests done.
Okay. Are you currently taking the combined pill as well?
No, so we have stopped. I stopped it about 2 months ago. We've been using condoms at the moment.
Okay. And are you up to date with the cervical smears?
Yeah, I have two smears done so far, and they've been normal. Yeah,
And how is your general health otherwise?
I'm fine. I'm pretty fit and healthy person.
No previous surgeries?
No, not at all.
Okay. And have you noticed any change in your appetite or any unintentional weight loss?
No, no, I haven't noticed anything like that.
Okay. And do you smoke at all?
I just smoke. I've been trying to cut off, but yeah, I still smoke. Yeah.
Okay. And how many cigarettes do you smoke a day?
Well, I'm smoking still about 15 cigarettes. I was quite heavy smoker. I've cut it off from about 30 a day.
Susanna, it's good that you're trying to cut down on your own, which is a good thing. But as I told that your report has come back as thickening of inner lining of the womb, which can turn into cancer in coming few years. So if we smoke, our immune system becomes quite underactive and it does not clear that normal cells. So I would recommend you to stop smoking completely. Okay.
Okay.
And if you need help in this regard, I can definitely arrange some smoking cessation clinics referral for you as well. Okay.
Okay, doctor. Yeah, I can see my GP for that. Yeah.
Okay, thank you. Now, do you any alcohol use at all?
Just on occasions.
Okay. Um, and what do you do for a living?
I work as a medical secretary.
Okay, that's fine. So Susanna, do you have any family history of cancers in close family?
No, I can't. I don't know. I'm not aware of anything. No.
Hmm. Okay, now I have taken all the details that I needed. Thanks for providing me. Now I can discuss the management options with you.
Yeah.
So I can understand that you are planning for pregnancy in near future. However, the best management recommended for women in your situation is to remove both the tubes, ovaries, and womb. So to take
Oh.
everything out. Um, and
Oh.
it is
Oh, yeah. Okay. Well, I wouldn't really like to do that because I want to have children.
Yes, I can understand you just discussed with me. So in that case, we have we have the option of delaying this treatment, this management by removing the womb, both tubes and ovaries, till actually we can help you in getting pregnant.
Okay.
Okay.
Right.
We can
Yeah.
delay for a few years time.
Okay.
Are you crying, Susanna?
No, no, I'm all right. I'm just a bit worried, obviously, but yeah, it's okay. Please do keep going.
Okay, thank you. So, what we can do is that we can first, we want to see that the inner lining of the womb does not have any abnormalities, which has already started to appear. So
Yeah.
we do a camera test for that. And
Okay.
then we can give you some hormones, which you don't have to eat. We would rather do it in the form of a coil. We'll place it inside your womb. Okay.
Yeah.
There is
Okay.
management of eating the hormonal medication like by mouth as well, but the best results are when with the coil, the hormone is released locally to so it can affect directly on the neck or on the lining of the womb.
Yeah.
Okay,
Okay.
so that will start reverting the thickened inner lining and thinning it out. Um,
Yeah.
and we will again take a biopsy in further 3 months.
Okay.
Okay.
Right.
One thing to understand is that when we are placing that coil, you wouldn't be getting pregnant. So our first aim would be to revert these changes back to your normal thin lining of the womb. And once that is
Yeah.
achieved, then we will have that small window where we can help you with um, with getting pregnant earlier by sending you to a
Okay.
fertility clinic. Okay.
Okay. Yeah. 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 That's fine. Yeah, that makes sense. Yeah.
Yeah, the idea behind that is basically to remove the time for natural conception. So you can get pregnant quickly while the inner lining is still normal. And
Yeah.
once you have achieved the number of children that you want to, if you are planning one or
Mm.
two children or whatever, so after that, we can then offer you again, I mean, depending upon how the biopsy is, but the ultimate
Mm.
recommended treatment would be to remove the womb, tubes, and ovaries once we have achieved the pregnancies and the successful outcome.
Okay. Yeah.
Okay.
Yeah. That's fine. Yeah.
The importance in this situation is that it is really important that you understand that you have to
Yeah.
come regularly for your follow-up every
Yeah.
three
So
months
your
and
time is
not
over. Yeah. Okay. Yeah.
the
Keep going.
importance is not to miss any appointment for the follow-up, and that is based
Yeah.
on that we want to keep a continuous eye and surveillance on the inner lining of the womb. Okay.
All right. Okay, doctor. Yeah.
So I can leave you with some information leaflet and some contact numbers for the support group, as well as my consultant secretary, in case you have any further information that you want. And
Yeah.
otherwise, we will see you back in a clinic where we do the camera test um,
Okay.
within the next couple of weeks.
Yeah. Okay, doctor. Thank you. Thank
Thank
you.
you.
Yeah. Right then. That's fine. Thank you. Okay. So that was good, Sadia. Thank you. You did include all important points. A couple of things I feel will be important to do here. So the one is to assess our ovaries as well, and hysteroscopy, and then maybe do MRI or CT scan to make sure, sometimes there can be estrogen producing tumors from the ovaries. So we need to do the assessment of ovaries as well here. And the second very important point is we're going to involve MDT here as well. So
Okay.
the MDT obviously is not only for cancer and all that stuff. Any complex issue where we are going to basically alter our management from our standard gold standard management plans, we like to obviously take other colleagues on board as well. So it will be MDT. The rest was fine. So
Okay.
yeah, absolutely okay. So when you read this type of scenario again in your preparatory time, so this woman, we're thinking about obviously she has endometrial hyperplasia with atypia. Then the second point we need to note is that she's obviously young and she might still have not have the children and she would like to preserve her fertility. So these are the two main issues we need to keep in mind. So your history point of view, obviously one will be to just, briefly touch her fertility wishes, desires, and then obviously talk about how we're going to facilitate her from that point of view. And then the second one is about endometrial hyperplasia. So obviously that's PIPL sample. So she might already have some invasive disease. So we need to include that as well. So we need to just keep again those malignancy symptoms, the malignancy related question in your mind. Yeah. So again, you did nice. I'm just summarizing again for other people. So just three categories of that. One is when we do malignancy risk assessment is about the sign and symptoms of that. So irregular bleeding, okay, any postcoital bleeding, any pain in your tummy, any change in appetite, any change in weight loss, just talk about the bowel habit change or any problem in passing urine or anything, just keeping, that in mind. And then yes, family history of breast cancer. So always do talk about the name, which particular cancers we particularly want. So cancer of breast, bowel, lining of the womb. So that's the malignancy risk assessment. And then yes, your generalized questions, any other medical health conditions she had, is she taking any regular medication? What is her BMI? Smoking. Smoking, I wouldn't go into detail of that, how immuno compression and all that story, because that will take my time, and you realize you ran slightly out of time at the end. Unless it's particularly those HPV related things, then I will talk about. Smoking actually have rather, we understand that has actually protective effect in endometrial cancer. But yes, still we need to advise her about stopping smoking. I will just touch smoking. Do you smoke? Yes. How many cigarettes a day? And I will say, the smoking does have, a lot of effects on health and other stuff. So we strongly recommend to stop smoking. And then, yes, guide her to either contact GP or we can refer you to that service. BMI, and after that you can start explaining the report. So for the report, yes, you can say there is a lining inside the womb which grows up every month, and then we shed it out as a period if we don't get pregnant. So I'm just going to keep it as a generalized first, and then I will say, so what happens sometimes this lining of the womb become over thickened, and as a result it can give the irregular bleeding and heavy bleeding, the type of symptoms you were having. So when it becomes thickened, then there is a risk that there can be abnormal changes in these cells, which either can be cancerous or precancerous, and that's why we always take that sample to check for the presence. Now, I'm afraid, and you can offer at this stage by saying, I have your histology report, and there is, there may be unexpected, that is unexpected, I will say, is an expected report, it may be stressful for you, so would you like to call somebody? That was fine, nicely done. And then start explaining and say, I'm afraid your report shows that the lining of the womb is quite thickened, and there are some abnormal changes in those cells as well. So this is simply, I will say, we call it, now I will tell her the original terminology as well, we call it endometrial hyperplasia with atypia. And then see how she takes it. If she asks any question about that, just answer what that is, and then continue with that and just say, so what I'm not, again, I'm not going to say to her that, I won't start related to her that although you want the children, you have told me, but the treatment of this is this, because she's going to get really scared and terrified. Instead, the way I explain, I will say, so the standard treatment, I'm still not relating it to her. I have given the result. Do you have this condition? The standard treatment for this condition is removal of the womb with both ovaries. Because even if we treat this condition, there's a high risk that it can come back or it can change into cancer. So for that reason, this is where the treatment is. If she interrupt me at that stage herself and say, well, no, I can't have that treatment, I want the children, that's fine. I will say yes. So in your particular circumstances, and I will continue. If she doesn't interrupt me, she's just listening, I will continue after saying that the standard treatment is this. However, in your particular circumstances at a young age, obviously, you still don't have children and you're planning for the family. So the possible treatment, I'm not certainly going to say we are going to defer it or we can delay it. All I'm going to say is we what we can't do, we can try to treat this condition with some hormone, we call it progesterone. However, we will need to discuss that with my consultant and also in a team of our specialist doctors, which involve the gynae cancer doctors and the radiologist, histopathologist, to just to understand what can be the better management option for you. So we possibly, for the women who wants to preserve their uterus, the recommended treatment for them we start is to give them a hormone called progesterone. This hormone can cause the thinning of the lining of the womb, and it can reverse these abnormal changes as well. So this hormone can be taken in two forms. One is in the form of a pill, and the other one is in the form of a coil, which we put inside the womb, and that releases the hormone and causes the thinning of the lining of the womb. However, as I said, like there is high risk this condition can change into cancer at any stage. We will keep a close eye. So after every 3 months, we will be, taking a sample from the lining and send it for the test to see if it's improving. Okay, so once we get normal sample, then at that stage, obviously, will be the time when we would like you to get pregnant in that time period. And to save that was fine to say, just to help you to get your pregnancy quicker, we can facilitate your pregnancy with our, assistance from the fertility clinic. And we will discuss that in detail with you after at that stage. Then you need to also say, so at that stage, then at this stage you will come up by saying, so what we need to do at this stage is because this thickening of the lining of the womb can be because of the action of one hormone, we call it estrogen. Sometimes there might be some cyst or some growth on the ovaries, and they are producing a lot of estrogen hormone, and because of that the lining of the womb goes thickened. So for that reason, it's very important that we do some more tests to make sure that your ovaries are okay, and also to do some more tests to make sure that these changes are only limited to the lining of the womb and they're not gone deeper. Okay, so for that, then you can say the next thing we will do will be to do a hysteroscopy, to put a camera inside, to have a good look to say, and then might take sample again from all parts of the lining of the womb to make sure all is sampled. And then we will put the Medina coil at the same time. And then we can arrange, after discussion with my consultant, we will arrange a specialist scan, we call it CT scan, to check that the ovaries are normal, or maybe another scan called MRI. Just mention, just because you have said I will discuss with the consultant. We will discuss with the consultant and then discuss in that team, and then we'll take it. Now, it is very important that during that time period when we are keeping you under follow-up, if you notice any irregular and heavy bleeding returns, and any loss, changes in your weight, a loss of appetite, this could be a sign of that, condition progressing into cancer or something like that. So please, at that stage, immediately contact us. You don't need to wait for your routine appointment. So this is always, and then you also need to say, however, when we are, leaving and delaying the definitive treatment, which is removal of womb, there will be that small risk will stay there, that it can change into cancer. So I would like you to be aware of that risk before you make a decision. How would you like to proceed us? Yeah. And then yes, I'll give you some written information, ask if she has any questions, and then just offer her that after discussion with my consultant and arranging these tests, we will get you. Okay. Any questions before go further from here?
Her ultrasound doesn't show any ovarian pathology. Still, we advise CT. Is it, Dr. Safia?
Yeah. So what we are saying is, all here is we are saying that I will discuss with my consultant, and then what we're saying is we may need to. Yeah, we're not certainly telling her. We're saying we may need to do them. Because the guideline says, for these one we might be doing this, so you just need to mention, but use the word maybe. We may need to do these to exclude the pathology. Okay. Okay, let's go to the next one now. So who is next?
Selena.
Selena. Just give me 1 second. Okay. Rather. Okay, that's for you, Selena.
Okay. Should I start?
Yeah, your 2 minutes are over now. Yeah, start.
Okay. Hi, Rachel.
Hello, doctor.
Yes, my name is Selina Chaudhary. I am one of the doctor on call today in the clinic. So, can I please again confirm your name and age, please?
Yes, doctor. My name is Rachel Smith, and I'm 62 years old.
Okay. Is it okay if I call you Rachel?
Yeah, it's all right. Yeah.
Okay. So I understand that you had a scan done because you have some complaint of abdominal pain and pain during sex, and you have come here to discuss your scan finding and also discuss the management option. Is that right?
Yeah, that's right, doctor.
Okay. Is it okay before explaining the scan result if I ask you a few questions?
Yeah, that's absolutely fine, doctor. Yeah.
Okay. So do you have any pain at present?
No, not at the moment. But I mean, the pain I get is like that's the vague abdominal pain and discomfort.
Okay.
I feel most of the time. I mean, I feel more bloated rather than painful, I will say.
So is it okay just if I continue?
Yeah, yeah.
Okay. So when did the pain started?
So this all is going on for last about 6 months, I will say.
Okay. And is the pain continuous or coming and going?
Yeah, I mean, it comes and goes, I will say.
Okay. And the type of the pain?
It's yeah, like when I feel it's like I feel quite bloated, dull
Okay.
ache, discomfort. Yeah.
Okay, and what is the site of the exact site of the pain in your tummy? Is on the right side or it's generalized?
It's more in the lower part of the tummy.
Okay. Do you have any recent loss of weight or any feeling of fullness?
Yeah, I feel as I bloated and full. I mean, my clothes are getting tighter.
Okay.
Yeah.
And do you feel that your tummy is swollen?
Yeah, I do feel. Yeah.
Okay. Any problem passing urine, like urgency of going to pass urine or any increased frequency of urine?
Yeah, I do feel sometimes I need to go. I feel urge to go more frequent than usual, and I pass only small amounts of urine. But
Okay.
my GP has checked for any infections, and he said I don't have any urine infection.
Okay. Do you have any problem opening your bowel?
No, I don't have any problems with the bowel.
Okay. So you are menopausal. How long are you menopausal? Your stoppage of period?
Oh, I think that's well about 10 years or even more than that.
Okay. Have you ever used any HRT, that is hormone replacement therapy?
No, I didn't.
Okay. So have you ever been pregnant?
Yes, I have 4 children.
Okay. All of them are normal vaginal delivery?
Yeah, normal deliveries, yeah.
Okay.
Hiroshima is talking.
Okay. And are you up to date with your cervical smear? Was the last smear normal?
Yeah, I have been fine. Yeah, the last one was about 4 years ago, and that was normal.
Okay. Do you have any family history of like cancer of the breast or any cancer of the womb or colon?
Yes, my mom had a cancer of ovaries, and that's why I was really worried, and I went for these, tests to the GP.
Okay. Did your mom had the cancer when she has stopped her period, or did she had it before that?
No, I don't exactly remember when, but she did have
Well,
the.
okay, sorry to ask you. Okay, do you have any medical disease like diabetes, hypertension, or any other disease?
No, I don't have any health conditions.
Okay, do you have any personal history of cancer, like breast or anywhere?
No.
Okay, are you taking any medication?
No, I'm not taking any.
Okay, are you allergic to anything?
No, as far I'm aware of, no.
Okay, do you smoke, drink, or take any recreational drug?
I do smoke, but not much. Just a social drinking, 1, 2 cigarettes when I go out with my friends. And drinking, yes, I do over the weekends.
Okay, do you have any operation in your tummy or down below anytime in your life?
No, I haven't.
Okay, and are you in a stable relationship?
Yes, I am. Yeah, yeah, I'm
Okay,
married.
okay. If you don't mind, can I just ask you about the pain during sex? Do you feel it after sex?
I feel uncomfortable. Yes.
Okay,
Yeah, it's quite uncomfortable.
okay. Are you well supported at home?
Yeah.
Okay. You retired or are you still in work? Are you?
I'm retired, but I do work as a volunteer in hospice.
Okay. So thank you for sharing the information. So regarding your ultrasound, you have a cyst in your right ovary, and that seems to be complex. And do you know what ovarian cyst is?
No, doctor, I have no idea what that is.
Basically, it's a fluid filled cyst, fluid filled sac, and it's measuring. It's quite big in your right ovary, 10 by 12 centimeter. And complex means that the cyst has got some solid area and some fluid. And also you have some blood test done, and that is CA125. That is a protein that is usually secreted from the ovarian tumor, and that seems it's quite high. That is 700. Is that make any sense?
Oh, Yeah. Does that mean I might have a cancer of ovaries?
Sorry, Rachel, I can't confirm that because we have to just do further investigation and we have to review your case. But do you want anybody to be you? Because I'm giving you a lot of information and I think you need my support, or should I?
No, it's okay. It's okay. Yeah,
Okay.
just yeah, continue. I would like to know what to do from here now then.
Okay. So what I'm aiming to do now is that I will discuss your case with my consultant, but I will do further investigation, that I will ask for a few of other tumor markers so that I can make sure that you are not having any other cancer, or it has not spread, just to make sure that it is just from the ovary. And also I will do x-ray, that is a CT scan of the abdomen and pelvis, and I will just um, make another calculation, just taking in consideration your ultrasound finding and in your protein marker and your age. And it seems that it will be more than 200 because your this protein marker is quite high. Then I have to refer you to gynecological oncology team. That is the team that is comprised of like we gynecologists and also cancer doctor, so that we can plan the management. Is that
All right.
making any sense?
Yeah, okay. So, right.
Okay. So that at the moment I will calculate your cancer risk, and then I'll book you for a specialized x-ray, that is the CT scan of abdomen and pelvis. And I will also make a referral to the gynecology cancer team, just to assess your mode of management, because depending on the discussion and also the CT scan finding, we will make the operating, which we will decide which type of operation you need, whether it can be done by us or you have to need a more expensive operation. But that will be discussed later on when we will discuss it in the MDT meeting.
Okay, right.
Okay. And so I will inform my consultant, discuss my consultant, and then get back to you. But at the moment I will give you an information leaflet so that you can read through it, because I have given you so much lots of information. And also I'm booking the x-ray for you and making you a urgent referral. Do you have any other
Okay,
questions?
doctor. Yeah, so from this scan and this blood test you told me that, so what you think, doctor, does it look like quite likely that I may have a cancer?
At the moment I can't definitely tell, but the finding is showing that you might have some ovarian malignancy. So, but we will treat it and we'll make a plan for that.
Okay.
Is it okay?
And how long will that take then to get these tests done and, start
Okay,
treatment?
I will do everything urgently, and I think within 2 weeks everything will be ready, but I am doing everything urgently. So your scan will be done most probably today or tomorrow, and then we will just put you in our next week disciplinary team meeting, because we have a weekly meeting. So most probably everything will be done by 2 weeks.
All right, okay. Yeah, all right.
Is that okay?
Yeah,
Okay.
yeah, that's all right,
And
doctor.
okay. Thank you.
Thank you. Okay, so I'm really worried, yeah? I appear worried, anxious, so
Yes.
you can offer counseling.
Oh, sorry.
Yeah, it's okay.
Yeah.
And the written information, yeah, you did offer written information. Yeah, that was fine. So that basically is very simple. Basically, should be easy. It should fit exactly into this initial template we discussed here, and just kind of really fill in the blanks. That's all you need to say here in this particular scenario. So let's go back and then we discuss this. But that was yeah, okay. So yeah, so she's 62 years old, woman, obviously with that high CA 1 to 5 and, you know, complex right away. So obviously she's really at high risk of ovarian cancer. She gave quite positive family history as well. Again, from the family history, when she said my mom had the cancer, I would like to extend it further to say, did she have any test done at that stage to find out did she have the type of the cancer which runs in the family? Yeah. So just ask that question. Otherwise, yes, it was fine. So by looking, obviously, you can think of is high risk of malignancy, highly likely to be malignancy. So same 3 bullet points. Number 1, ask about any obviously the current symptoms and all that history, sign and symptoms of malignancy, history of, you know, family history of this cancer, and then generalized history of any of the medical condition stuff, and then it comes to the matter of explaining the report. In this particular scenario, it's really up to you. You can explain the report to start with, or it's fine if she's okay and doesn't appear to be very anxious. You can take history first and then discuss the report. So history taking, yes, just start with by saying, okay, so you're 62 and you have 4 children, and so tell me about your pain and these symptoms when they started, and what has your GP given you any treatment for that already, and what GP has done. So she will tell you, he arranged this scan and he arranged me this blood test as well, which I have done. And then you can say, okay, so I have the results with me, which I will discuss after just getting some more information from you. And then take the history, asking about, have you, did you notice any bleeding, vaginal bleeding? And have you noticed any bleeding after sex? Get some information of the abdominal pain. Is it there all the time? I felt you repeated a few times about that. Some history, I just volunteered straight away about the abdominal pain nature, that it's, I feel like bloated, full, and dullness. So you can save your time by not asking repeatedly. Yeah, so they can save you some time. And dyspareunia, and then if she says I feel bloated and all that stuff as well, just ask about history of any nausea or vomiting with that, because when we're asking about the signs of malignancy, we know there can be obviously metastases or secondaries as well. So just ask about the weight loss history, change in appetite, any change in bowel habits, any blood in the stool, any difficulty in passing urine, any frequency she has from the pressure symptoms, or any presence of urine, blood in the urine. You did ask about the family history. Be clear again by asking breast cancer, cancer of ovary, lining of the womb or neck of this, and the bowel cancer, which gave obviously positive family history. Overall medical history, any medicine she's on, allergies, BMI, because that's the information you will require to put into your MDT referral as well. Then, because we know ovarian cancer, there can be metastasis in the lung disease as well. So just simply ask about those signs and symptoms as well. Do you have any cough, any, and any blood in cough, and anything, difficulty in breathing, or and any of those symptoms? Then you come to explain her the report, and then you will say, okay, so your doctor arranged a scan to, see your womb and your ovaries, and then he also did a blood test. We call it CA125. This is a chemical which is produced in the body in various conditions. I will actually start from the simple reasons first, so that she doesn't get too much worried and alarmed. Although, yes, we know it's highly likely. So I will say in different conditions, like a condition we call endometriosis, but that's not, that's unlikely in a woman whose periods have stopped, and some other, if there is some inflammation and infection. This particular protein is also produced by if there are any growth or tumors in the ovaries, and that's why your doctor booked that report, that blood test for you. No, I'm afraid the results of this scan and the blood test may be quite unexpected and stressful for you. So would you like somebody to be with you? Yes, we're just filling in the blank in initial performer. And if she says, no, my partner is not here, is there, then you can say, okay, so your scan shows you have a large cyst on your right ovary. Cyst is simply fluid-filled sacs, okay? But sometimes these cysts can have, if they are simple cysts, then, if they're just simple fluid-filled cysts, then we don't worry too much about them. But if the cysts do have some, solid tissue in them, or there are any partitions between the cyst, then we call them as a complex cyst. And in that case, we like to remove them and remove them, and just to check that there is no cancer in them. because in this case there can be a risk of cancer. Okay, and then you will say, so what do we do from the appearance of the cyst on the scan, and also from the levels of this typical protein we have done. We do some calculations to assess the risk of cancer in that particular woman. Now, you being postmenopausal and with the appearance of the cyst and the CA1 to 5 level, it appears it comes as, you know, quite high risk of possibility of cancer, right? So I will be saying high risk of possibility of cancer. I will be clear. I would like to tell her that information because that's clear from us, the one we have. Yeah. So what I'm going to do, then obviously depending between what her response is, and if she's upset, then we're going to let me see who is talking here. Somebody forgot to put their so then you will ask her about yeah, so then you will tell her, so what we need to do now then, obviously we need to also make sure in case, you know, that if it is cancer, then we also need to make sure that it's not the disease, or at this stage you can say we also need to make sure the disease is confined only to this one ovary, or it has spread to other ovary and to your womb or to your bowels as well, or sometime it can spread even up to the lungs. So we will need to do some more tests. And then we will discuss within our team of specialist doctors. We got a multidisciplinary team that will have the consultant and, you know, the cancer doctors and radiologists who do these scans. And then we will discuss what can be the best treatment option for you. So I will be, after discussion with my consultant, I will arrange one special type of scan. We call it CT scan, and also chest X-ray. And then this will be discussed in that team. Yes, you can give her time of 2 weeks, MDT 2 to 4 weeks. And then I will make your appointment to discuss with you. When she says like, what is a treatment, then obviously, you know, we have some idea about at this stage. Obviously, this will, you know, involve removal. So obviously, you know, it's important we do remove the cyst and the ovary, both sides of the ovary. But that will all depend once we have the CT scan done, and also the discussion in the team, like what type of surgery and what will be the extent of surgery we would like to do at that stage. So we will explain to you that in more detail, the possible options of the treatment and everything after we have our MDT meeting done. Okay, so I wouldn't go and say whether we will be doing surgery at our place or where, because wherever obviously we will have if do have gynae oncologist, we can treat, you know, in the hospital as well. So instead, just simply say, well, that will depend, you know, after that meeting, there will be a plan like what type of surgery. More important is to tell her, like, are we going to only remove both ovaries and the womb, or are we going to do even more extensive surgery? That will all depend once we have the results of that scan and also the meeting. Okay. So then obviously offer her, because we're telling her there is a possibility of high risk of cancer. I just say, you can say, obviously I can understand it can be quite stressful for you. So how you feel about if I arrange your appointment to see one of our counselors meanwhile, so you can deal it in a better way. And then just check this vote at home as well. Ask her if she has any questions. Give her the offer again. This one is about that initial breaking bad news where, yes, we haven't given the report of cancer, but we have told her, you know, there is a high risk. So just tell her to give that option to say, you know, I'm going to give you the contact number as well to contact early if you need to ask any questions, if you have any concerns. Yeah, and you can, yes, offer in this particular scenario, you can offer, you know, you can in next appointment, if you would like to, you can bring some family member, your partner with you, if you would like to. Right then, just
Ma'am,
two questions.
shouldn't we include the examination thing also, that we will be doing abdominal and internal examination?
No, at this stage, we don't need to repeat the abdominal examination stuff. We got ultrasound scan report in front of us, and then we're going to do CT scan. So we don't need to repeat abdominal examination and stuff. Again, if we are thinking of doing examination, let's ask ourselves why we want to do that. Yeah, we do that examination at the first appointment or so because we want to see if there is any obviously mass or anything. And then we have gone further now. An ultrasound scan has given us more better picture from what we can actually now get from bimanual examination. So there is no purpose to do that examination. They are uncomfortable examinations anyway, yeah? So we don't need to just talk about further scans on MDT. Okay, who is next?
Madam, what about she can have even breast, all those I mean, cancers of the breast or family history is there? Should we ask about the BRCA gene tested or something for the mother?
So she said the mother has, she didn't say mother has breast cancer. She said mother has ovarian cancer, right? And for the ovarian cancer, I said like whenever they tell breast or the ovarian cancer, always ask next question is, so when she had the cancer, was she told it's a type of the cancer which run in the family, or she was given that particular test to check the presence of that particular gene? Okay.
For her, we need not offer
Right.
comfort
Who
testing,
is
no?
next?
Sorry, Dr. Shibbi,
Yeah, sorry.
there was a station in May this time, which was an increased RMI risk
There's
about
a lot
2.
of echoing and the noise. I can't hear you. So before I take your question, Sadia, can I go back to the question of the previous person? Somebody was trying to ask something.
Okay, so.
And for this patient, so we need not offer any testing for the genes, ma'am. Ovarian.
No, not at this stage. We haven't even done
At this
the
stage.
surgery, yeah?
Okay.
So we will do the surgery, then we send for the histopathology, and then yes, if it come back, then we will do those genes. At this stage, you don't need to worry about testing of genes for her again. Yeah?
Okay.
Yeah, yes, Sadia?
So this time in May, there was a station about a 16 years old girl who had crazily high CA125 with a
Okay,
complex
that's
cyst.
our next station,
Okay.
Sadia. So hopefully you will get the answer there. If not, then you can discuss after.
Okay, thank
Okay,
you,
who is
Dr.
the next one? You're welcome.
Shazia.
Me, Dr.
Shazia.
Safia.
Sorry, okay. Da, 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 da. So there we go. Oh, I'm giving you the patient instructions. Oh, 1 second, what's happening here? Where did my scenario go? Yeah, okay.
This is the question, Dr. Safia.
Give me 1 second, I need to rearrange the slide. Yes, this is a question. Yeah. Yeah, okay. Yeah.
Yes, Dr. Safia, we can start. Hello. Dr. Safia, we can start. Anybody hear me?
Yes.
Yes, we can hear you, Shazia. I think Dr. Safia is a bit away, so we have to just wait.
Okay. Dr. Sophia, we can start.
Yeah, you have 3 seconds still, but yes, fine, you can start. Yep.
Okay, hi Heli. It's Dr. Shazia. I'm one of the doctors in the clinic today. May you confirm me your name and age, please?
Yes, doctor, my name is Haley Wood, and I'm 16 years old.
How would you like me to address you?
You can call me Haley.
Okay, Heli. So I just came to know about the notes that I have came to me that 2 weeks before you went to the emergency with the tummy pain. So how about your pain right now?
Well, it's better now, but it's not like this pain is not there all the time. It's something which comes and goes.
Are you still on the medications?
No, I'm not. I'm not. They just told me to take paracetamol if I feel any pain.
Okay, can you tell me more about this pain? Since long you are suffering from this?
Yeah, so this pain I started having about 3-4 months ago, and it just comes and goes. And then 2 weeks ago, I had really bad pain. It was really bad crampy pain. So I ended up in A&E. They they gave me some painkiller, pain relief, and then they did blood test, and they booked me for a scan, and then sent home, and they made this appointment for me to come back to have the results. So this I'm here.
That's fine. Okay, Heli, is this pain is associated with your periods?
Well, my periods are painful, but this pain can come anytime. It's just not only with the periods, but my
Okay.
periods are also painful, yes.
Is it regular?
But my pain,
Are your period? Is
my
your periods
periods,
are regular?
yeah, my periods are regular, yeah.
Okay. Before I will discuss your results, I will ask some social and sexual questions also, if you not mind, and I will tell you we will keep this information confidential, and it will remain with me. Heli, are you sexually active right now?
No, I'm not sexually active yet.
Okay. So whom you are living with?
Hello?
So whom you are living with, Heli? Hello, Heli. Hello.
Can you hear us?
Hello. Yes, Dr. Sophia, I hear you.
We can't hear you, Shazia. Hello? Okay, I think Shazia is trying to relog. Let's give her a few minutes. Hello? Okay. Hello, Shazia. Hello? Can you guys hear me?
Yes.
Okay. Yeah, I
Yes,
just
Dr.
wanted to make sure,
Sophia.
is it my audio or is Shazia's audio? Okay.
Yeah, we can hear you.
Hello, are you with us, Shazia, and can you hear us? Right. So Shazia, let her work with her internet or whatever the issues she has, so we can give her another scenario. So who is the next one? That person can do this, and Shazia can do after the break.
Anilasri. Anilasri.
Anila, okay.
Excuse me, Dr. Safia, can I ask one question before we start the new scenario?
Okay, yeah.
Yeah, when there is given a complex on ultrasound finding, it's a complex ovarian cyst, whether it's a postmenopausal or it's a premenopausal. So when it is a complex word, so how we will just do the, you know, that, what to say, that scoring which we are doing?
इसको हटाओ इसका फोन आ रहा है इसको उधर ले जा
Like if
How
the
we do the
findings are not
scoring?
given.
Yeah.
Yeah.
Okay,
So
so
like
the complex, okay, so complex cyst means, you know, it can have septa, it can have solid areas. So it's not simple cyst, right? So you can still take the scoring of 1 or 2. Yeah. So
because
Shazia,
otherwise we
yeah.
have to, otherwise we should have the complete report, septa or solid
Yeah,
or
I hope in the
injections.
exam when they give you the notes should have the yeah, they should have the that was just so
Okay.
we can make it okay. You can say some solid cystic areas.
Okay.
It says sorry, Sajida. It says 16 centimeter with multiple septa and solid cystic areas.
No, it's okay. Yeah, now, right now it's given.
Okay, if
But
it's
in the
not given,
post-menopausal,
okay, right. The complex
yeah, if it's
basically
not
means
given.
septa and solid cystic areas. Yeah, that's what they mean by that.
Mm.
Right,
Okay.
Shazia.
Yes, Dr. Sophia.
Okay, is your system working now then? Okay.
Yes, Dr. Sophia, it was working.
Okay, start. Continue from
Hi,
where
it's
you
Dr.
left. No,
Okay.
just continue from where you left.
Okay, Heli, I want to ask some social and personal questions if you will not mind, and I will promise you that I will keep it confidential. So can you please just tell me, do you have a partner?
Well, I have a boyfriend, but we're not having sex. I haven't had sex yet.
And whom you are living with?
I live with my mom.
And do you have support at home?
Yeah, my mom, yeah.
Are you going to school?
Yes, I do. I'm about to take my GCSE exams this year.
So, okay, Heli, the results that have been in front of me, it's showing that ultrasound, there is some fluid-filled area that is about to be 16 centimeter size. It's quite big, and it is complete containing of some compartments also, and there is some solid area in it.
Okay.
And your doctor also have done one blood test that is called CA125. That is some protein being secreted from the ovary and some other areas also. All these reports we can use to calculate the risk. These results are being complicated. Do you want someone to be with you to discuss the management further?
Yeah, I mean, tell me what that is. I don't know. Yeah.
Okay, it's better that we will discuss this management in front of your mom. But right now I am telling you something about it. The rest of the ovary and tubes and the womb is looking normal. These things are being compelled us that we will remove this cyst as soon as possible because this is quite big and it's ended up in some complications. Are you getting my point, Heli?
Yeah. Ruxana, can you please push your mic off? Okay. Yes.
And for this removal of the cyst, we will go through the some introduction of the camera inside your tummy from the buttonhole, and we will try to remove that cyst as possible as we can, and we will try to save your ovary.
Oh, so I need to have this operation and stuff.
Yes, Ellie, unfortunately, you have to go through this operation as soon as possible in the next 2 weeks' time, and I will make your urgent referral so that we can arrange and book an appointment for your surgery.
Why, doctor? Do I have cancer? I mean, what is this? I'm really scared.
Yes, really, It can be, but I cannot tell anything right now at this moment because there is the cyst fluid filled area is not being simple. It's having compartment with the solid areas. But we will remove that cyst, and there is chances that we can uh, save the remaining ovary, and you will be fine after that.
That's quite scary, doctor. I have my exams coming up just in 6 weeks' time. So can I delay it for after, because I really don't want to affect my exams.
Harry, I understand that you are quite young to discuss these things right now, and but to delay the surgery is not a good option for you because the size of the cyst is quite big, and if we will left it like this, there is chances that we will might end up in the complications of the cyst like torsion. We can have bleeding inside the tummy, and sometimes this fluid-filled area or cyst can rupture. So in that case, we will end up in the emergency surgery that is not quite good. So we have to go for the planned surgery that is better. And for regarding your exam, just don't worry about it. We will talk to the school also, and sometime this surgery is just a day care, and you will come up in the morning and you can discharge next day. So it might be there is no delay in the exam also.
I don't know. I'm really stressed and worried.
Helly, if you are not okay, then we can have another appointment to discuss all this management in front of your mom, and that is better. And we strongly encourage you to bring your mom in the next appointment.
Yeah, I will do. But are you so? So is this cancer? Do I have cancer?
And clearly, we cannot say anything right now. Everything will be discussed and
Yeah, but
being
does it look like
completely.
cancer then?
There
Does it
is
look like
still
cancer?
there is chance. So the solid areas and the compartments, it can resist the suspicion of cancer more. And although the hormone CA125 is also raised, but it can be secreted from other areas. It can be raised because of many other reasons. It raises the suspicion, but right now we cannot say you 100%.
Okay. Okay.
Helly, are you okay?
Well, I'm really, scared. Yeah, so I don't know what to do with this. I think if you make my appointment with my mom, I would rather like my mom to be with me.
Yes, that's better. I will provide you written information also, and we can have a counseling session also, so that everything will be clearly understood by you, and we will have discussion with your mom and in front of you, and the management will be planned finally.
Okay.
Any
Okay,
more
doctor.
questions, Helly, you want to know?
No, that's all.
I know it's upsetting for you, but the things will be under control once we will get the surgery and the biopsy report will come to us. So you are quite young, and we can even preserve your fertility later on. Your fertility will not be hampered even if we remove the one ovary. The life will be quite okay even after that surgery. I
Yeah,
will also
okay.
provide some contact numbers of the support groups also, who are suffering from the same problem. So you will be discussed with your problem and you can feel better.
Yeah. Okay, your time is over. So sport
Thank
groups,
you,
which
Helly.
sport group? Yeah, thank you, Shaz, yeah, for doing this. So let's just start retrospectively. So sport group, which sport group contact details we will give to this girl?
Support groups of the people who are suffering from the same problem.
So what is this problem? So what's no, we are just doing
The,
our discussion now. So
yes,
so you have to pull out the leaflet now. So what leaflet are you going to pull out for this girl?
the premenopausal ovarian cyst.
Yeah. There are not particularly any support groups for premenopausal ovarian cysts, yeah? There can be simple cysts and stuff. At this stage, because the support groups and stuff are usually, you need to give them like when there is some serious diagnosis and stuff like, or some very chronic conditions, like there are support groups of cystic fibrosis, yes, cancer groups, and these type of things, yeah? Stillbirth, miscarriages, these type of things. At this stage, we haven't reached the diagnosis at all about this girl, so don't worry about this support group. You can
Dr.
just
Sophia,
check about this. Yeah.
but the patient is asking me again and again. She is disturbed. So how I will
Yeah.
counsel her?
She's upset. Yeah. She says, I'm upset, I'm scared, and all that stuff. So just offer her like the counseling, and just address first, what are you so worried about? She's mentioned about one thing about that, and then she say about the cancer. And she's worried about this one because we are telling her, we're talking about, yes, there is a possibility of cancer here, Shazia, but the possibility of cancer for this girl, young girl, with C125, even with this CA250 is very low. That's what we know. Okay, so we need to reassure her that there is a small possibility, but it's very small. The risk is very low in this age. And the other thing you need to do is, obviously, you need to, even if she has the cancer, obviously CA125 can be raised in various conditions. Yes, inflammation, it can raise in endometriosis. In this young age, any inflammation and infections, so many reasons. C125 basically is not the right test for this girl, even if we want to do any tumor screening, because the germ cell tumors are more common in young girls. So that was another thing we need to arrange for this girl. So we need to do levels of LDH, alpha fetoproteins, and those ones, yeah. So to exclude that, and then we need to reassure in a slightly. I missed a lot. What you mean, Shazia? You missed? No, you didn't miss a lot. Don't worry about it. It's just like I felt you get overwhelmed more towards cancer, and that's why the young person actually got really scared about that as well. What that is. So another important thing now, although from the reports we feel, yes, obviously there can be small possibility. She might have some tumor going on. However, because this possibility is not, I'm still going to offer this woman to have mother or somebody with her before I discuss. And my main reason for that is because it's quite a lot of complex information we are going to give her. Yeah, so that's why we want to make sure. So for this girl, yes, after introduction, and one thing, always when you initially enter into the room for the patient, you will always call them by their full name. Okay, Haley Wood. Hello, Haley Wood. My name is Dr. Jameen. I'm one of the doctors on duty here. Can I confirm your full name and date of birth? So she then repeated, then don't again ask, is that okay if I call you Haley? No. This is again leading question. You have chosen already, you would like to call her Haley. No, give her the choice. How would you like me to call you? And then she says, okay, call me as a Haley. And then you start, okay, Haley, I understand you've been having some pain in your tummy going on for some time, and you attended A&E 2 weeks ago. Would you like to please tell me more about your pain, like when it started and what type of pain that is? So that was fine to start with. So ask how long that pain is, where it is, lower part of the tummy, does it radiate? Is there anything which make it better or worse? So when you say that, then she may be able to relate it with the period by saying, yes, I have found that, when I'm on my periods, my pain get really worse. Could that be endometriosis? Yeah, going towards our side. And then, or anything else, she will tell you more details about it. And then take more history, yeah? So if we are keeping small chance of there's malignancy in our mind, then ask those questions. Has she noticed, any change in weight, appetite, change in bowel habits, or anything? Is there any so continue with further personal history. Ask about her menstrual history. When was your last period? How are your periods? Did you get any irregular bleeding in between your periods? Amount of the bleeding, any bleeding after sex? Yeah, so take that detailed history. Because that's going to give you a lot of information. Again, heavy periods, and then if she give a lot of family heavy periods and stuff, painful periods, ask her about, is there any family history of conditions called endometriosis? and then this from the sexual and social history, the way it's not like I would like to ask you social and sexual questions. No, I would like to ask you a few questions regarding your social and sexual lifestyle. Yeah. So she excluded the sexual thing by saying I'm not sexually active, so that's fine. I was really pleased that you did said you need to do basic safeguarding assessment here by asking who she's living with. Although she's not sexually active, so we don't need to worry about that side. So who she's living with, and has she got some support? Is there anybody she can talk to? And then after all that history, then I will ask about the family history. Is she aware of any family history of breast cancer, cancer of ovaries, or cancer of lining of the womb or cervix? Check about her BMI, what her weight, that is does she have any other medical problems, or she's taking any medication, surgeries, and all that stuff. Yeah, allergies. Then you come to know, before I will say to her, like, okay, so when you attend A&E, they did some blood tests on you, and they also booked a scan for you, which you have done. Now the results and the discussion can be a bit complex. So is anybody with you? Would you like your is your mom with you, or anybody with you who can be here when we discuss these reports? So just ask that. And if there is nobody, obviously, and in the exam point of view, obviously there won't be anybody. Then you can say, okay, so I'm going to give you these results, but some information may be a bit complex for you. So please do not hesitate to ask me if you don't understand something or you find it a bit complex or I'm not clear. So please ask me that. I will try to explain. And then we can also arrange you another appointment when your mom or anybody you would like to bring with you. Okay, and then I will start. I will say, okay, so they booked you for a scan to find out, what is causing you the pain. The scan shows, you got your womb and then you got your ovaries. The scan shows that there is a cyst, quite large cyst on your ovaries. Okay, cyst is just a fluid-filled sacs. So if these cysts are only simply fluid-filled sacs, we call them simple cysts. Okay, and then if they are just the fluid-filled sacs, we don't worry much about them because these fluid-filled sacs can come and go. However, obviously, if they are quite large in size, then we like to either aspirate, remove the fluid from them, or remove the cyst. However, if the cyst shows some partition in them, just like as we discussed in the last scenario as well, like show some compartments, or they show any solid areas in them as well, then we like to remove them. Then we certainly like to remove them to exactly do the detailed examination of those cysts to try to find out what they are. Because sometimes the cyst of disappearance, there can be a risk of cancer in them as well. So I'm going to use word risk, risk of cancer in these cysts as well. However, the chances of cancer in somebody of your age are extremely low. They're very low. Okay. So there can be other reasons of this type of appearance of the cyst as well. Sometimes the girls who have very heavy bleeding, they can have a condition called endometriosis. In them, their blood can flow backwards through the tube into their tummy, and they can make these type of appearance of complex cysts as well. Then they also do a blood test to check for a specific protein that is called CA125. This chemical is produced in the body in various conditions. Again, if somebody has this particular condition we call endometriosis, the level of this can be raised in that particular condition as well. And if there is some inflammation going on in the body, that can also raise. So, but that level can also be raised if there are some tumors or some specific type of cancers in the ovary. However, this particular test is not the right test to do to find out the cancer, or this is not specific, or that test doesn't give us really good information from cancer's point of view in girls of your age. Okay, we need to reassure her. So what I would like to do, I would like to book another blood test to check a couple of other proteins. We call them alpha-fetoprotein, just name them, and LDH and those ones, because if there are any tumors in girls of your age, they are called slightly different type of tumors. They are called germ cell tumors. So we can do this, the blood test just to check for those levels. All right. Then if she goes upset, or she goes again, she says, do I have a cancer? I will say, so I'm not straight away going to say yes, there's a high risk, or it's likely or not. I'm going to say, the information we have at the moment, is not very clear. Okay, and as I said you already, don't get alarmed. The chances of cancer in girls of your age are very low. Okay, so we need to actually do some more tests now at this stage to try to find out exactly what that cyst is, and we definitely need to remove this cyst as well, because it's quite large size, and it can twist at any stage, and it can cause bleeding, or it can cause those complications, right? Before I arrange for any of the surgery or anything, I'm going to discuss that with my consultant, and then we may decide actually to discuss that in a team of specialist doctors, we call this MDT, to find out what exactly and what will be the better option. Okay, so to remove this cyst, we will be the standard way, a most common way to do that is with a very simple procedure. We call it a keyhole surgery, in which we will be putting camera inside your tummy, just below the tummy button, and then this cyst will be removed from there. So that's most likely the way we will be removing this cyst. However, if my consultant or the team of, if we took it to the team of doctors, they felt that we should do some specialist scan before we remove it, called CT scan, and if that give us any different information, then there may be a small chance that they decide to remove this tube by opening up the tummy. We call it laparotomy. However, this will be decided after discussion with my consultant. Yeah. So at this stage, we're not certainly going to say to our CT scan or MDT, you're going to discuss with your consultant, and then a visit consultant can decide whether he would like to get the opinion of other colleagues on board as well before deciding, or he want to go straight for just to remove this and send for biopsy. Okay, so you need to give that information in that way. Then she brings up her examination, so for exam point of view, we can say, well, I can see obviously your exams are fast approaching and you're worried about the exams. However, if this cyst is important to be removed because of the size. Okay, so I will tell her clearly that we're stressing that because of the size, because 16 centimeter is really big size, and the ovaries are very small structure, right? So if this cyst is actually hanging with the ovary with that big, it can twist at any time, and if it does twist, it can cause a lot of bleeding, and then we will need to rush and remove it in emergency situation. Yeah, and that can obviously then cause a complication. We may then need to open up the tummy to remove this and control the bleeding, and then the risk of harm and damage to the ovary will be quite high as well. So if we rather remove it by a planned procedure, then we can't save the ovary. If she asks, is that going to, are you going to remove my ovaries? Is that going to affect my fertility? This will all depend when we put the camera in, where that is that cyst separate from the ovary, or it has involved a lot, of the ovary. We are aware of this, and the way it will be removed, we will try to save your ovary. Okay. However, let's assume if the whole ovary is involved already and it's not really possible to save the ovary, removal of one ovary will not affect your fertility. Your other ovary will still be able to produce the egg. All right. So reassure her from fertility point of view. This one, for examination point of view, you can say, so any student, if they have to go under some unexpected surgeries or hospitalization just around their exam time or thing, then they can be considered as extraordinary special circumstances, and then your scale can arrange, they can take your previous result, your mock test results, they can be taken into account instead of your exam. So do not worry about that. We will give you a letter for your school as well. So there is a system here for that anyway. So if they have these circumstances, then the previous results usually are taken for their grading. That's what can be done. Do not promise them that your school can arrange, unless it was internal school exam and it's not her proper final GCSE exam. There is no provision of resitting the exam or arranging the exam again. So all they do is just consider their previous performance, and particularly the mock exams they do, usually around March time. They take that result as the final result, whatever. So that's what it is. And because she's quite stressed and worried, you will say, okay, so I'm aware I've given you a lot of information, and most of the information is quite complex information as well. I'm going to give you some written information, just general written information about the cyst in young girls. And then if you feel so, I can make your appointment with your mother to come and discuss this all again. And meanwhile, obviously, I can discuss with my consultant as well. And then, I can tell you how we are going ahead and we are going to proceed. Leave that girl with the contact details of the secretary as well to ring us to contact if she or her mom, obviously, when she go home and going to tell the mom is going to be worried and jumping. So then you can say, you can give that, we will give you the number so you can ring and we can arrange your appointment to see you with your mom. If there are any questions or any concerns beforehand, before we arrange your next appointment to explain to you the management. All right. Right. I can take 2 questions before. So Sadia, you did have some question to start. So do you want to tell me?
Yes, thank you, Dr. Javi. My question was that I understand that the risk of cancer in this particular scenario is low. So what
Yeah.
is the cutoff limit for applying the RMI? Because if we apply RMI, it is in the range of above 200, which is 75% risk of cancer. So just wanted to clarify the RMI in this particular scenario in a teenager, which is a low risk.
No, we won't be applying RMI in this case. Okay, so that's why we said like they have done this particular test. However, the result of that test actually is not, doesn't give us much information about the cyst in the girls of your age. So we basically are just going to ignore the CA1 to 5. And instead, we are going to do the test for alpha-fetoprotein, LDH, and beta-HCG. And further, yes, at the same time, you're not completely excluding. Yeah, so that's why we have a couple of times repeated by saying that I'm going to discuss with my consultant, and then we may, after the discussion, so it will be up to the consultant whether he, looking at the scan report or discussing with the sonographer or the radiologist, do they both together, as an MTT, do they want to do any MRI or CT scan beforehand? So that's why we are saying that we may discuss in MTT as well. So we are giving the possibilities that this needs to be done, but actually as a ST5, I'm not going to take that as CN at this stage. Yeah, that this is not very clear, that cancer pathway. But yes, we know it's a complex cyst and it's a bit slightly different circumstances as well. So it's likely to be involved to be discussed in MTT. And MTT is like, if I, say, for example, if I am the consultant who's looking after this girl and booked under my, if I just ring even the radiologist to get further information from there, that's MDT. Yeah, it's multidisciplinary team decision. So, and that those scans, if we need to do or anything, that I'm just gonna, just the way I'm going to tell, if the consultant felt we need to do, then we will do these special scans as well. But then I will, arrange your appointment to discuss with you again. So we are actually going to see this girl, at 16 years old girl, we're giving this all information on her own. Before even we book for any procedures, she's not able to give us any idea whether she's happy to go ahead with this or not, even if she's GILEC competent. With all the complex information in first appointment, she's not able to make any decision at this stage where we are going. So I'm going to make her another appointment in a couple of weeks' time after discussion with the consultant. Our mom is going to be worried really as well. She won't be clear what the hell is happening. So we might even call them earlier. We don't want to just leave them, this young person and the mother or whatever, the family, to worry about things. So that's why I'm offering her to give the contact number, that if they're worried, contact, we can make an urgent earlier appointment as well to explain. All right.
Okay. Thank you,
So
Dr.
Anila, you're welcome. Anila, you asked about the MRI and CT, so I hope your question is also answered in this. One more question before we take a break.
Should we offer sick leave, Dr. Safia, or how does that work?
Yeah, so that's what exactly I have answered, sweetheart, in Sadia's answer. Yeah, I will discuss with the consultant, and he may, after discussion with the radiologist or sonographer, you may, decide to take a specialist scan. We call MRI or CT scan. I will let you know about that. Okay, so that's what we will say. I'm not definitely going to say I'm going to arrange. The previous, where we were quite clear because of the postmenopausal status and all that stuff, we were clear there. We clearly said I'm going to arrange that specialist scan and chest X-ray. Here, I'm going to leave that my consultant to decide. But yes, I will say we may need to do these. Right, so any further questions on the group? Are we going to take a break? About half an hour. I know I keep saying 20 minutes, but then it never, we're not really able to eat and drink within 20 minutes. So take 30 minutes break. So it is 2:15. Yeah, just 2:15. So we will be coming back 2:45. So 2:45 from my UK time and UK obviously. So 30-minute break, simple. All right. Okay. Okay, so way back. Okay, so who is next person?
Anila.
Okay. Right, Anila, are you there?
Yes, ma'am.
Okay, so this is for you then. Your first 2 minutes starts now. Okay, this is your first 2 minutes.
Hello, I'm Dr. Anila, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, doctor. My name is Susan Taylor. I'm 54 years old.
How can I address you?
You can call me Susan.
Okay, Susan. I've seen the letter your GP has written, and I understand you've been having some problem with your waterworks, and you've been given some options of treatment, been trying and did not find it much useful. Is it so?
Anila, we can't quite hear you. Can you raise your volume? Yes.
Ma'am, can you hear me now?
It's better,
Hello.
yeah.
Uh, Susan, I understand that from the letter your GP have written that you had some problem with your waterworks and you have been treated with some options and you didn't find it useful. Is it so?
Yeah, that's right, doctor. I'm really fed up with this. My leakage is really frustrating, and I really want to get it sorted.
I'm sorry for what you are going through, Taylor. But can I know more about it before discussing the result that you have got, the test you have gone through, and also
Yeah,
the options that are available for you?
yeah. So I started having this problem of leakage when I cough and sneeze. That started about 3, 4 years ago. And my GP, sent me to have some physio and some exercises, which I started doing, but they didn't really make any difference. I'm not really bothered to do them anymore. And then recently, for last 3, 4 months time, I'm really trouble with the control of urine as well. Like when I feel I need to go to the toilet, I have to really rush, otherwise I can have accidents. And obviously this is quite embarrassing, and because of this, I'm not really able to do my routine things, unable to go out because I'm just worried I might just have the accidents while I'm out. Yeah.
Yeah, I understand that you are getting really trouble with this, and you. How are you coping with this? Are you using anything for to prevent these accidents also?
I mean, obviously I have to use panty liner all the time. My doctor started me on some tablets, um, and he said it will help with the control. But I took them for a week, maybe more than a week, about 10 days. But those tablets were really awful. I was having nausea and vomiting, dry mouth all the time. And they too didn't make any difference. So I have stopped taking them. I just can't take them. They have horrible side effects.
Okay, I understand, Suzanne. Uh, did you notice any pain when you were passing urine also?
No, there is no burning pain when I pass urine. I mean, my doctor has done few tests in the past as well to check if there is any infection in my urine, but that's not the case.
Any problem with your opening bowels?
No, I don't have any problems with that.
What about your, did you maintain any diary to see the type of drink you're taking, the volume you're avoiding, something like that has been advised by your GP?
Yes, I have done that. So in the scenario, you can see she drinks a lot of water and cigarettes and
Yeah,
smoking. Yeah,
yeah,
so
yeah,
it's
yeah.
given there. Yeah.
So we need not ask now.
No, no, it's okay to ask. Yeah, you can say you can just relate by saying, "So I can see your diary," but that's
Okay,
fine. Yeah.
okay, okay. Uh, can you say, have you ever, you, I have seen that you have 4 children, and can you say me how your pregnancies went on and deliveries, how did they?
Well, they were like those all four straightforward pregnancies, and I have vaginal births with four of them. Um, they were quite healthy babies, though. But yeah, everything was fine otherwise. Yeah.
Okay, no instruments were used for you to
No,
deliver.
no, no,
Okay, that's fine. Are you following with your GP for any other condition apart from this?
no. I don't have any other health issues now.
Okay. When did you attain your menopause, Suzanne?
I started my periods about, I would say about 4 years ago, maybe 3, 4 years ago.
How are you feeling using the hormone replacement therapy?
No, I didn't use. I didn't want to use that because of the many side effects.
Okay. Okay. Do you feel any vaginal dryness or something?
No, not really. Not
Are
much.
you regular? Are you regular with your smears?
Yes, I am regular with my smears.
Any surgeries in the past in the tummy or down below?
No, I haven't had any surgeries. No.
Any history of something coming down or similar complaints in your family?
No, I'm not aware of. Nobody mentioned me anything.
Okay. What do you do for a living?
So I work in a shop
Okay. How is support at
as a
home?
cleaner. Yeah, I have a good spot. Yeah, I live with my husband and my two younger children.
Oh, that's fine. Thank you for giving this information, Susan. From the history you gave and from the information your GP has sent me, uh, they have done a test what is called as urodynamic study, which shows that how your bladder is working, what is the cause for the uh, waterworks to leak, all these things. From that, I understand that you have
hmm
both problem in the bladder muscle and also the support for your bladder. Does it make sense for
Okay.
you?
No.
Okay. The thing is, the
Yeah,
bladder
I
is
mean, yeah.
yeah, what we call it as overactive bladder. That means the muscle is contracting before the bladder is full. The other thing is
hmm
because of your menopause and also your deliveries, they would have the support from the which is supporting the bladder. The muscles have become weak, and this is causing you leak when you are having a cough or you are putting some pressure onto your tummy.
Okay.
Okay, so we these are the two things that we need to address. For this, as your GP has advised, the bladder exercises, that is a training, what he has said to regularly empty the bladder with increasing space in between is one thing which we try for everyone who has this
Well,
problem.
okay.
Okay, along with that, we can. Ask you to use some drugs. Generally, we ask if you are not doing well with this exercise, we generally prescribe medicines for that, for which your doctor has already done and you were not happy with it.
Yeah.
But I can say you one thing, Susan, that this medicine generally takes 4 weeks for its efficiency to start off, and the side effects what you are feeling generally implies that the medicine has started to work.
All right. Okay.
Okay.
But they
If
are
you're not
just like, they were just too terrible, doctor. I don't think I can do without medicine.
okay, I understand. But other thing you can do is you can use some other medication. We can change the medicine and use one option you have, or otherwise we can use it when you're using this as a pill. You can use it as a patch or something and try it. And we will give you
Okay.
some support, some medicine which can support yours. I mean the side effects. Can I know what did you feel the side effects? I mean the
So
when
I
you're
was
using
having
this.
like really bad nausea, vomiting, and I was just feeling it was causing me really bad dry mouth as well.
Okay. If you are okay with this option, we can change the medication and give for you. Or otherwise, if you are not happy to use the medicine for further, I can ask you. We will be discussing your case in a group of multidisciplinary team. What we call it, my consultant and the urogynecologist and some incontinence nurse will be there, who will be discussing which one will be a better option for you. Like we have small options like injecting a small Botox, what we call it.
Okay.
That is same. That is same as what we do for the face to tighten the muscles. Same thing we do for the bladder, fill it, and we can do that one option. But the thing with this is you need to go for a repeated injections, and we are not sure how long it will work. And some people may need to put a catheter to empty the bladder.
Okay.
The other options we have is a
Your time is over, but yeah, you can tell me. Yeah.
the other options we have is we need to we can do
You go and
some
complete.
stimulate to the send some stimulate to your bladder, same like a pacemaker what we do for the heart, so that the muscle will be under control. Apart from this, I would suggest you to
Okay.
go continue with your pelvic floor exercises under the supervision of a physiotherapist, which will be much useful for you in long run. If you do it for 3 to 4 months, only then you can find some difference with this exercises. Apart from this,
Okay.
I would suggest you to have some lifestyle changes like uh, decreasing, I mean, not to have around 1.5 liters of water, and just restrict your fluid in the 4 hours before you go to sleep. And also would suggest you to recommend you to decrease the smoking, I mean to stop smoking, because you will feel better uh, once you try out this. If you are okay with it, I can help you out by sending with the NHS with smoking services. And
Okay,
also
doctor.
decrease your alcohol wine intake, especially in the night, which may sometimes
Mm-hmm.
cause
Okay.
irritation to your bladder. And this one. And also work out with your weight. If if you are ready, I mean,
Okay.
if you are having any idea about this, we can help you out by referring you to a dietitian, and also for the exercises.
Okay, doctor. Right. Okay. I will stop you here
This
now,
is
Anila.
okay.
Fine. Absolutely lovely. You have included everything important we needs to be. Now, obviously, time management, and then with incontinence situations, and particularly if it appears as a mixed incontinence, the time management can really be an issue. So for this particular scenario, I will just ask you, all of you, to basically practice the way we will try to, do in this model answer, so that you can,
Okay.
try to fix all that stuff within the given time. Hopefully, most of the time they give one type to you. Either they give overactive bladder or they give stress incontinence. Then we see it can save a little bit of time. But if they both are there like this, and it has come like this as well, then how you can do it? So in this, obviously, that's why there's a lot of information given to you already over there. So that can save your time. And I'm glad you did use that information instead of asking those questions again from her. So yes, introduce yourself, ask what you would like to call, and after that you can say, I can see that you have been trouble with, some problem with your urine incontinence or urine leakage for some time. And yes, just ask her to start and tell. So tell me more about when you started having this trouble and this problem. And then she tells you, and again, she gives you a lot of information over there as well. Like, I started with stress incontinence, GP sent me for exercises. I did not do those exercises because they were not working. And then I started having this, and then she told everything about urge incontinence, and about, how is that affecting. If not, then obviously you can acknowledge first as well. I can see, yes, it must be quite troubling issue, and yes, I can say it affects your routine activities as well. Then you can just take some history, although a lot history is given over there as well. So I usually, again, because I know from the information given here and from the history, if I ask the questions beforehand, that's not going to change the way I'm going to explain her the report. Yeah. So you have given the result that it shows that you got both type of incontinence or whatever. But I feel I would like to know more about how and what basically is wrong with the muscle, which you have done later on. But you can relate with the management at the same time. So I will start telling her from the from the urodynamic result, and I will say, okay, so I can see your doctor did book you for this test to try to find out exactly what is the reason for your leakage. So I have the report with me. To help you to understand, obviously, if it's a face-to-face one, then you can always make a quick picture of bladder balloon. If not, you're just doing what you can see, you can say. So what happens, the bladder is made up of a muscle. So when the urine get collected into the bladder bag, once this is filled, the bladder bag is filled up to a certain level, then this muscle start contracting, and that contraction give a signal that we need to go and pass urine. Okay. Sometimes this muscle become, and this muscle is called the retroser muscle, you can say. If you even don't say that, doesn't matter. And then you can say, but what happens sometimes, this muscle become quite irritated and overactive. And as a result, this muscle start doing, the contraction even with the small amount of urine into the bladder. And and it also it also contracts very strongly. And as a result, you feel that urge to go to the toilet more frequently, and then you find it difficult to control till you get to the toilet as well. Now, I'm going to relate her smoking and stuff and part of management straight away here now. There are various reasons why this bladder muscle become more active. Smoking, taking a lot of caffeine, like in the form of coffee and tea, if the weight is towards higher side as well, these all are the different reasons which can, cause that irritation. I can see from the detail, from the information given in your letter that you do smoke, and I can see from your bladder ID as well that you do take whatever the amount of drinks is given over there. You can just relay that this much of tea and this much of coffee. And I note your BMI is towards higher side is 32. So these seem to be the likely reason for your problem of having, the difficulty and control of holding your urine. This is very important because leave smoking every consultation. They listen, stop smoking. Every consultation, they listen, reduce the weight. So she's again going to just take it as a general health advice. Unless we clearly say these are actually the reason for your problem, then she will, emphasize more on that. Okay, yes, that is really related and I need to do something about it. So it's very important that you stop smoking and also reduce the amount of this tea and coffee you're taking. Try not to take any, these drinks after 4 p.m. particularly, and reduce the amount of, these tea and coffee during the day. So regarding smoking, you can ask, we can arrange your appointment in our smoking cessation clinics who can help you to actively stop smoking. How you feel about this, right? To just involve her there, invite her to be involved there. Then you can say, and regarding the weight as well, obviously, reducing weight can be quite challenging as well. So what I can do, I can make an appointment to see our nutritionist. They can help you to make a proper diet plan for you. And it's very important that you do join a regular gym and also some active weight losing program. So that you can have a motivation, because the reduction in weight is actually very important in the management of your symptoms. Because in case in future, if we needed to do some, some small operations to help you to remove your symptoms, they won't be successful if your weight is above certain level. Okay, or it's towards higher side. So now we have clearly related it and we have given the advice as well at the same time. Then you come and say, no, continue with the rest of the urodynamic report and say, and then what happens with the bladder? The bladder neck is supported by some muscles. We call them as the perineal muscles. So these muscles actually stay quite strongly contracted and keep the opening of the bladder tightly closed. But for somebody when we are in post-menopausal stage, the lack of the estrogen hormone, and also I can see you have 4 children, and you can ask what the normal deliveries and weight of the babies. And if you say that during the labor as well, because of the bearing down, these muscles become, they lose their tone and their strength. As a result, their hold on the neck of the womb also goes weaker. And as a result, when you cough and sneeze, and that increases the pressure inside the bladder, it gives way, or you can leak, because these muscles are not able to tightly close, keep the neck of the bladder tightly closed. Okay, so now I'm going to relate the physiotherapy here, and to improve that tone and the strength of these muscles, it's very important then we restart your those, these pelvic floor muscle exercises are very important to help to improve and at that stage she might then volunteer that one before you telling, but I did the physiotherapy, didn't work. Yes, this physiotherapy will not actually show any results within 4 or 5 weeks. They need to be done continuously and regularly, and about after 6 to 8 weeks time they start showing a difference, and then they have to be continued anyway to maintain that turn and the strength. Yeah, so we're done with that and explain the result as well. We explain what that is. We explain the general measures as well. Then you can say, no, you can ask, I would like to ask you a few more questions. If you think there is anything else, I mean, I don't feel any, to be honest, more. I can just simply ask, do you have any other health problems, any medicine you're taking, any allergies or any surgeries? Yeah. And then I can see from the, given the notes letter already, I can see your doctor actually started you on some tablets as well to help you to control with your their frequency and the difficulty in control of urine. So are you still taking them? Or she says, no, but I didn't take them quite regularly because they cause me a lot of side effects and stuff. You can say, yes, that's right. These medicine actually can have really troublesome side effects, but that actually is the way this medication work. And again, this medicine also is not going to show difference within 2, 3, a week or so. This needs to be continued, and once you will continue to take them, slowly and gradually your body becomes used to, and you won't have that much side effects. So how you feel about restarting them? If she says, well, no, that was really bad, I can't go, then you can offer her to say, okay, so we do have some, similar type of medicine, slightly different, which have, a slightly lower side effects. So we can try that. Okay, how you feel about that? So, if she say, yes, start me on that, then you can just start her on that tablet. At this stage, because they haven't still properly taken the pills, she hasn't properly done the physio at this stage. This is all we're going to do. Okay, again, we're just going to restart her on this stage, and I will say, okay, so we're going to, I arrange this physio appointment for you as well and put you on these tablets. And then we will leave you for 3 to 4 months so that your muscles can regain their strength and tone during that time, and also to see the effect of these tablets on your bladder muscle. And then we will review you at that stage. So it's very important that when I arrange your appointment in about 4 months time, you just maintain the bladder diary again as you have done already. So just write down, I will give you that, the diary. You can just write on the amount of water drinks you're taking, and then your accident and the amount of urine you're passing. That will help us to see and compare to see if there is any improvement. Now, once you will start taking these tablets and have the exercise, after a few weeks, you will feel, when you start feeling better control, that you can control in a better way on your urgency and the leakage, then I will encourage you to start doing your bladder retraining as well. So all you need to do is, when you feel you need to go to the toilet, try to hold on a little bit longer, and that can be just like from a couple of minutes to slowly increase the time. And that will help you to learn your bladder again and the bladder muscle again to hold on a bit more longer. Okay, so and then after 4 months time, I'll make your appointment to see our specialist doctor, the urogynae doctors, to review you. And if your symptoms are not completely gone by then obviously there are different other management options we can discuss with you. Now at this stage, if you still have a time, then you can give some idea about those options. If not, then don't worry. As long as you say there are different other options, you can quickly just say, like, we can put some medicine or some Botox into the neck of the womb that can increase the tightening of the neck of the, sorry, I keep saying the neck of the womb, neck of the bladder, to improve your control. And then there are some certain other small operations which we can do. As long as you just mention this one, that's fine. You don't need to go into the details. Your time won't allow you to go into the details of, what type of operations are available or what. So at this stage, give this guidance 4 months sleep, because earlier than then, obviously, we done weight reduction. All these are going to take time. And for all other type of, the surgical, particularly the surgical options, obviously it's very important that she has done the physiotherapy and she's reducing the weight. Otherwise, the success chances of those surgical procedures are very low as well. So this is how I will suggest you guys to listen this recording again and then make your notes and try to do that way. If it's one type of given incontinence, then it's going to stay almost same. Yeah. So if it's a stress incontinence even, The only thing you can save some time if you don't need to talk about what the doctors are doing, yeah. So and this medication bit, you can remove that, and that will the full scenario will remain same for the stress incontinence. And if it's just the urge incontinence and there's no stress incontinence, then still you need to talk about the pelvic floor muscle exercise in the sport and everything to some extent, yeah. So yeah, so I will say particularly this type of scenario, this incontinence, just rehearse them few times. Any quick question?
Doctor, please, as
Okay, who
regard
is next now? Yeah.
as regard oxybutynin, so we'll give her like batch, or we'll change it to another one, and which one will give?
You don't need to tell the name of the patient at that stage, yeah. So you can just simply say there are some other medicine available, we can switch you to those, okay, and then that should be enough for the patient, and you can just then start them another alternative option. Okay, who is next?
Ma'am, next is actually Dr. Deepthi. And after that, it's my turn. So if it's okay with her, can I do this one? Because I might have to leave by 8:30.
Okay, yeah.
If it is okay with Deepthi only.
Yeah, that's okay. Deepthi, is that all right with you? Yeah, okay, that's fine. Pramila, you can do the next one. And let me see, which one is yours?
Ma'am, I'm anyway not well, let her do, ma'am.
Sorry? Okay. So, well, I haven't put the slide on there. So, Pramila, can everybody else put their mics off? Okay, Pramila, so I'm going to just dictate this scenario. You all can write down it, and then I will add it to the slide. So let me see. What exactly was that scenario? I haven't still put that on the slide. Sorry, just 1 minute. Sorry, I just lost that station somewhere. Okay, so the station is, you're going to say 47 years old. Yeah, so 47-year-old Rebecca Wood, and who has presented with some lump in the vagina, and she also has complained of leakage and cough and sneeze, and whatever the name I have given, Rebecca Wood. She's transgender. Okay, so Rebecca Wood, a transgender, has attended with a history of lump in the vagina and some history of leakage and cough and sneeze. And if anybody has more details on this scenario than this, please give it to me so I can add up this. You know, the one with which appear in the exam, transgender coming with lump in the vagina. Hello. Can you guys hear me?
Ma'am, in the exam they said that she's having some Bartholin cyst. Hello?
Yeah.
Yeah,
They say
ma'am,
what?
the exam.
Yeah, the Bartholin cyst. Okay.
Yeah, that's what they said in the exam. I'm having a problem in my throat. Is my voice audible?
No, it's fine. We can hear. So tell me, so the letter said she has a Bartholin cyst. It said already.
Yeah, she said that I have a Bartholin cyst.
Okay. And what was her name? Was the name given as a female or male or what?
The name was given as a female.
Okay, so let's keep it Rebecca Wood. Okay. Right. And when, okay, whoever you knew this or you try yourself. So when you asked about, did she use the word vagina? Did she say I have a lump in the vagina, or she just said I have a lump down there?
Down there.
Down there. Yeah, that's okay. Anything else? Is there anything
Not
else?
that I,
Did she have yeah, so that
not that I,
person had any children before or anything?
no, she didn't say anything of that sort.
All right,
Her only complaint was that she has a Bartholin cyst, that's what she said.
was it a GP referral?
Yes.
So there was a letter from the GP which says she has a Bartholin cyst. Okay.
Yes.
All right, there you go, Pramila then. So, okay, we still keep it at like about 47 years old. Rebecca Wood, she has a Bartholin cyst. She's transgender. Take 2 minutes.
And is there leaking with coughing and sneezing?
No, forget the leaking and sneezing. Keep it as a Bartholin cyst.
Okay.
And one more thing, ma'am. It was not
Yeah.
mentioned that it was not mentioned in the letter that she was a transgender.
Okay.
So, only history would reveal that she's a transgender.
All right. Okay. Okay. Okay, Pramila, you don't know she's transgender. Was it Dipti who was telling me this scenario? Can you please just send me this in WhatsApp, please? I add that slide.
Ma'am, I don't have it in the form of a slide. This is what I'm telling you from my recall memory.
Okay, so whatever you remember, just write down on the WhatsApp in the group, yeah.
Lump in the vagina and that it's a Bartholin cyst. That's it. And she's come with that complaint. She's presented in the.
All right. Okay, this is your first 2 minutes, Pramila.
Hello, good morning. I'm Dr. Pramila, the doctor in the clinic. May I confirm your name and age, please?
Yes, my name is Rebecca Wood, and I'm 47 years old.
How should I address you?
You can call me Becky.
Becky. Okay, Becky. So your GP has sent you here saying that you have got some lump in the lump lower down in the vulval area. Can you tell me more about it? How long was it there?
Yes, I have this lump on and off going on for some time, but it never grew this big. You know, it appears and it disappeared itself. But now, you know, for last 3 days, been there, and then it became really swollen and painful.
Yeah,
So that's
I
why
can
my
understand.
seen me.
Yeah.
Mm-hmm.
Is it? Are you able to sit properly because of this pain?
Well, this is quite uncomfortable, so I feel quite a lot of pain, so can't really sit properly.
Is there any discharge from that swelling?
No, I haven't noticed any discharge.
Okay, okay. And do you have any associated fever?
No.
No. Okay. And may I know what you do for living?
I'm working in a factory.
Okay. And what about your partner?
I'm not in a relationship at the moment. I'm actually transgender.
Okay. So have you done any surgeries for that?
No, I haven't gone through any surgeries. It just you know, the hormones and those treatment I had.
Okay. So how long you have been receiving these treatments?
Well, I you know, decided to change my gender when I was 30 years old. So since then, yeah.
So it might have been quite difficult for you in that transition period. I hope now you are settled down and you are coping up with the situation.
Yeah, that's okay. No, my you know, my family, friends, and everybody around me has been quite supportive.
Okay, okay. So regarding this swelling, in the earlier times, have you taken any treatment for the swelling when it appeared?
No, I never needed to take medicine or anything before because it comes as a swelling and then it used to just resolve itself.
Okay, okay. So it looks like it might be a swelling from one of the glands there, but from what your GP has written. So this is, if you can say this is the what we called as the introitus or the opening of your vagina. So at that area, we have got a gland called as Bartholin's gland, which actually gives lubrication during our sexual activity. So sometimes what happens is this opening of this gland can get blocked. And once this opening gets blocked, then the secretions inside the gland will accumulate there. And sometimes the secretions can be accumulated so much that it will grow in huge size, like this time what happened. And it might also get infected sometimes. So that might be the reason for your severe pain you are having because of its size and it getting infected.
Right. Okay.
Am I clear?
Okay. So yeah. So how can I treat it now then?
Yeah, so I would like to do a examination once again in the presence of a chaperone, if it is okay with you, to see whether it is just enlarged or whether it is actually got infected. Because then the management part will be slightly different. If it is just enlarged without infection, what we usually do is we do a surgery called as marsupialization, where we actually drain the contents and try to create a new opening, remove the lining of the cyst and then try to create a new opening for you. Whereas if it is already too much infected, we might not be able to do that, like in like other pus collected swellings which you might have in other areas. We might have to just put a nick on that and relieve that pus only and treat you with antibiotics for the time being. And then later on, if it recurs, we might have to think about doing this procedure. Is it clear?
Right. Okay. Yeah, it is. Yeah, it is. So if I have that done, is it something, will that come back after that operation, or it just will go completely?
If we are doing that, only we are draining it. As I said, if it is infected, in that case, since that opening we are not recreating, it might recur back. But otherwise, if we are doing the other procedure, that is marsupialization, where we are creating that new opening, in that situation, the chances of recurrence is very low. But still, very rarely, it might again, the new opening can also get blocked. And again, this can happen. And if it recurs again, then we might have to think about removing that gland fully. Why we don't think about removing this at this point of time is, even though you said you are not in a relationship and you are a transgender, and but still, if you want to have a sexual function later on, this lubrication might help you. So if you are thinking about that, we might have to keep the gland there itself. But if it is recurring again and again, or if you would like to do away with it, we can also remove the gland fully so that it won't recur again. And there are actually 2 glands on either side of this opening. So this is only one gland that we are dealing with. On the other side also, it can happen if that gland also gets blocked. So that possibility is also there.
Mm-hmm. Okay.
Do you have any further questions to ask me?
No, not really. No.
Okay.
So
we will be.
What do I need to have at this stage?
So at present, since you are in severe pain, I can give you some analgesics and some soothing jelly for the pain to get relieved. While I am examining you, I can apply it there and give you some pain relief. Due to this pain, are you having any difficulty in passing urine or anything?
No, not really. No problem in passing urine.
Okay. So I can give you analgesics and I can give some local applications to soothe that area. And I will also start you on antibiotics so that if there is some infection, it can be taken care of. And I will discuss your case with my consultant, and we can decide to do the surgery if you are willing. That will be done under anesthesia, because it will be a lot of pain will be there. So you will be given either some form of anesthesia will be given to you so that you won't have any pain while we are doing the procedure. Is that okay?
Okay. Yeah, that's okay. Yeah, I would like to have some, just some pain, whatever. I will think about this surgery.
Yeah, that I will anyway arrange. Yeah. And if you would like to discuss it with your family members, you can discuss with them and get back to us. We can give you some written information regarding these swellings which happen. So you can go through that, and any doubts you can always get back to us. And if you have decided to go ahead with the surgery, I can arrange for that also. I can arrange the anesthetist also to see you. And do you have any, if we are proceeding with surgery, I would also like to know, is there have you undergone any previous surgeries in the past?
No, I haven't had any surgeries in the past.
Okay. Do you have any long-standing diseases like high blood pressure, sugar, or anything?
Yes, I have diabetes.
Okay, so we'll have to make sure that having diabetes might be another reason why you are getting recurrently infected like this. So we'll have to check your blood sugar levels, and we will do a test called as HbA1c, which will tell us for the last 3 months how your blood sugars were. And your blood sugars also has to be well controlled during and after the surgery. And do you smoke?
No, I don't smoke, doctor.
Okay, that's good. And are you on any medications?
So just for my diabetes, I'm taking 2 different type of tablets.
Okay, that's all. Okay. And do you have any personal or family history of any clot formation in your legs, lungs, etc.?
No.
Okay. Because if it is there, then we will have to take care of that also while we are doing the surgery. That's why I am asking. And okay, do you have any allergy to any drugs?
No, as far as I'm aware of, no allergies.
Okay. So once you have decided to go ahead with the surgery, a detailed evaluation will be done by us, and all the relevant investigations before doing the surgery will be done. And you will be seen by our consultant and also by the anesthesiologist. And we will proceed with the surgery if you are okay.
Yeah, your time is
Anything
over.
else you want to discuss? Thank you.
No,
Thank
not
you.
really. Thank you. Okay. So sorry, I might have missed and didn't hear you properly. So what treatment are you giving her today?
Antibiotics and analgesics and local application for soothing agents.
Yeah. Okay. Yeah, that's fine. Great. Okay, so I don't know how we did it because I didn't have the details of that person either, how and what she said. So again, if anybody knows what the role player was giving during history, please tell us so I can explain them, keeping that in mind.
I was really worried about how to bring in this transgender into this scenario. What
You actually
difference
did
will
very
it
well.
make?
You did very well, and I'll come to that point in a minute. There were a few things probably. Yeah.
Yeah, I heard that that lady, the person said, I don't get periods, and that's how the history of transgender was brought out. Something, somebody, something like that much only I know, but I
All
don't know
right.
the.
Okay. So on menstrual history, she said, I don't get periods.
Yeah.
Okay.
So
and then
we have to check the history, whether she's on any medication to suppress. I don't know how it went.
And she said then because I'm transgender. Okay. Was there any other element like she was upset about anything, or when whoever was doing the anybody else knows anything? It's strange that you guys don't know. You might have the friends appear in the exam or somebody like, so you guys would have had some information on the scenario.
Dr. Jabi, I did not have any information about this scenario, but what I am, because we don't have full information. So might it be that she actually was a transgender from a male gender to a female role now, and now instead of the Bartholin cyst, these swellings are the gonades which are appearing there. It might be, I mean, something which I was thinking throughout the scenario.
It can be one of the possibilities.
Yes, Dr. Jalil, because how it will be a Bartholin cyst and she was a male? How is the anatomy here?
No, the transgender doesn't mean that she was male to female now. She might be female, and now she has, she take herself as a male. So she says I'm transgender. So not having periods means she obviously is using, she might have the coil. So I'll go into the detail of that transgender bit. I just need more information about the role player because it's very important how this station will be done. We have some information. So if you guys, all of you can please put some effort in and just, your friends or links or whoever player are from any other groups, try to get more information on this scenario, what exactly this patient was saying, this role player was saying. Okay, now regarding whether, when we say whether it was a male or a female, it depends as well, like from the name, how they appear. So I will come into a minute for you guys to help to understand why that. So if it's a male to female, then you will know from the appearance of the person as well. In the role player, they will make somebody like that, sitting like that. So they won't be sitting a normal female appearing woman who has the breast and everything. Although, yes, they can have from the surgery, but still, obviously, you can make some difference the way from the voice and everything. So that will, and the name will do as well. So anyway, obviously, if it's just a Bartholin cyst, it's very easy and simple management. So putting this in the exam is mostly to how you actually access, how you approach these people. So anyway, so on the introduction, when you go, is very important, and that's why we say it's okay. Whatever the name is written in the scenario, right? You go and call from that name first, whatever is given. If no name is given, then obviously, you can. And sometimes it may be the name is given as a male, and when the screen opens up, there is a female appearance, female person sitting in front of you. So don't get confused. Call from the name what is given outside from the GP letter or whatever. And don't appear confused or anybody. It's not, there's nothing extraordinary to speak to transgender people. So that is one thing to keep in mind. Maybe in the scenario it says a male name and you start confusing what this male is doing here actually in our gynae. And then scenario open up, it's a female. Or it may say the female name outside, and when the scenario opens up and you enter the cubicle or the screen opens, this is actually a male appearing person sitting next to you. So then we can keep that in background, it might be transgender, right? But whatever, the name, whatever is written outside, you can just start talking from that name as we do for the other people, Rebecca would. So you can go in, or you can do the neutral way as well, as like Pramila did, by asking, can I take your name and date of birth? And that person can give you the name. But as a like otherwise, the name, whatever is given, go in, talk, okay, Rebecca Wood, my name is this and this, one of the doctors on duty, and can I take your name? And always, even in routine scenario, be careful to listen the name, okay? It may be sometimes the name is given in the paper as a female Rebecca Wood, but when you go in, that person gives you a male name. And the reason for that is why it appears a female outside is that they're still going through the gender assignment process. So their name in the records may not have been changed. So we need to listen what name that person is wrote. So in even routine one, make it a habit to listen. Don't just be, preoccupied from the names you know it is, and I'm good. So that's the reason, one of the reasons as well, why we ask the patients, how would you like us to call you? So if, say, for example, that person goes as so call from the name, obviously, that person says, okay? And that will also help you to how you actually going to, do the word and dealing this person as a male or a female, the way you will address that person. So let's assume this started as a female. Obviously, this person would have given the name of female and must be appearing as a female. That's why people won't pick up straight away till they get to the menstrual history. And then, yes, so just start by open way by saying, okay, so I have a letter from your doctor, and I can see it's written you got some swelling down there. Okay, so down below, use always the word down below. And then you proceed with further. Tell me more about when you started having this, just like as any normal history. When you started, what type of pain is this the first time you had it? Is there something which keep coming? And then listen carefully as well, what words this person is going to use for the genital organs, okay? If that person is using the word vulva or, vagina or opening my vagina or something like that means we are also okay to use that word, all right? If that person is not using any of these words, just saying down below, then be careful. Do not use the word of introitus, opening of vagina or the vulva, because these words can be quite upsetting for them, and they are upsetting for them. So that's another thing very important. So initial, focus on the conversation. What words are they using? That will help you to pick up how I'm going to say these things. So just ask, okay, so then it start, okay, so we go what we know at the moment. So, okay, if that person says, I got that swelling down there and it's going on for some long time, and then, is pain, you just take the details of the history. Has there been any discharge? Is it quite swollen and tense? Ask about the signs and symptoms of the abscess to make a difference, whether it's just an infected cyst or it's an abscess. So ask about, obviously, how bad the pain is, how much is it affecting, there, and what have they taken already? Have GP given anything? If it's a recurrent one, what previously has been done about it? And then obviously the history of fever is also important to check for abscess point of view. So once you are done with the swelling related history, then we take the normal general history. So if there was nothing to start with the period, then you can start just the normal history. Okay, tell me about your periods, when was your last period, and I hope at that stage, if the person says, well, I don't get the periods, or I don't have the periods, and if the person appears female, that's okay. Just say, okay, so your periods are stopped. So would you like to, are you using some contraception, some contraceptive method, and due to the contraception periods are stopped? So, I mean, if that person is transgender, obviously that person will relieve here then to say no, because I have changed my gender. I'm transgender, and I have been taking the hormones, and that's why my periods are stopped. And that's fine. Just normally take it, say, okay, right, okay. So would you please give me some more information about the process of your transgender? So when did you started to having this hormonal support or any further transformation. So take that history when it started, and then what type of, so then you will say, check by saying, okay, so are you taking some hormones, for this one? What has been given to you to stop your periods? And they usually volunteer that information straight away. We are having depot, or we have an implant, or we have a coil maybe for the periods. Then the next question is to say, so have you gone through any surgeries for your genital organs? And this question is very important. Okay, that question will help you to understand then what type of genital organs they got down there. So, and then you can ask, when you talk about the hormones, just ask them what hormones you are on. They know very clearly what are they taking. So then ask about the surgeries of this hormone, and then you can just simply, I wouldn't straightway say that it must have been very difficult. Because when we say that, I know it is difficult. Most of these people do go through a lot of stress around them. But if we say, start with by saying already prejudgmental to say it must have been very difficult, we associate a little bit of taboo to that situation and they don't like it. Just simply ask, so how your experience has been, with your transgender process. So if they have any problem, obviously they will tell you, yeah. If not, they will say, no, that's okay. And then, yes, you can ask, like, who are you living with, and have you got a good sport? And then just simply ask about the relationship. Are you in a relationship? Are you seeing somebody? Your partner, if they have a partner, obviously, at this stage, we're not suspecting any sexually transmitted infection and stuff. We don't need to go into the details of the type of sex they're having. So we can leave that for the time being. Just for that one. And then, yes, ask about the medical history, ask about their surgical history, just like the routine history, any other medications you are on any allergies you are. And then you can simply start. So if, again, as well, like, if this person have used the word when started, like, I got this swelling, just right at the opening of my vagina, then I will start by explaining by, in the vagina we got these glands and down there. And if not, then I'm just going to start with the, just say down there as well. So let's suppose that person is using the word down there. And that person also tells us that, this person hasn't gone through the surgery for the genital organs. The way then I will speak to then explain is, I will say from the letters, from the GP's letter, I can see the GC has written, you got this lump, which is called Bartholin cyst. So to help you to understand, let me explain you what happens, in the lower part of your opening down there. And then the word vagina, you can just maybe use, the lower part of the vagina, the lower part of your opening. You can just say in the, in this canal, there are some glands on the side, on the both sides, and the function of these glands is to secrete, provide lubrication and secretions to provide lubrication during sex. I'm just simply going to say word sex. I'm not going to use word intercourse, okay? Because we don't know, she might, if that person might be taking him as a, as a male and having only anal penetration and not vaginal penetration. So just simply say they provide those secretions which provide lubrication during sex. So these are glands are just funnel-like structures. And what happens sometimes they can block at the neck, and as a result, those secretions keep collecting inside, and then these glands swell up and they appear as a lump. And because of the stretch of these glands, obviously they become painful. And then sometimes they can even get infected, and that obviously make them very painful and uncomfortable. And from the symptoms you are telling, it appears like, there is some infection going on in there as well. It's very important that we do give you, some treatment to relieve this. And then you can ask about, if she says recurrent, is keep and going, come and coming. Then you can say, so what happens sometimes these, glands, then when they get filled up, sometimes they just open itself and resolve themselves, and sometimes they just not. And if they don't, then we have to, treat them either with antibiotics. But if they are filled with pus and they're quite tense, sometimes then we have to, give a small cut on the surface and drain that pus and then treat. after the examination, and once I will examine you, if that confirms to be Bartholin cyst, then depending upon again how bad that is, if it's quite dense and I feel it's full of pus, then I will start you on antibiotics. But then it will be also important to just give local anesthetic, give small cut and drain that pus, because otherwise it's not going to heal. And then a procedure later on can be arranged for you, and then you can explain muscularization. Yeah, that you can be open in this one. And then we see muscularization will be done not now. We can do it, later if it's sepsis at the moment. Then the treatment obviously is yes, offer the examination. Now, if that person hasn't clearly used the verbal verbiage and all that, so they find it quite stressful, this examination as well. So then you need to just ask like, okay, so I would like to examine you down there just to get an idea about the size and how much tense that swelling is, if that's okay with you. Yeah. So then you will say like, I can apply some numbing gel, local anesthetic at the same time, that will help you to relieve with the pain as well to some extent, and then you can take paracetamol. For that, are you, if you're okay and you don't have any problem with ibuprofen, like if from the history you picked up she's not asthmatic in anything, then ibuprofen obviously will be better option than paracetamol. And then you can say like, I will start you some antibiotics. We call that flucloxacillin, or we decide it accordingly. And then we see yeah, so that will be about the standard Bartholin cyst examination. Now, regarding marsupialization, then you can say, so that is something which can, appear again. So, Pramila, you did explain that nicely to say it can either appear into the same side or it can appear in the other side as well. But you can also explore at that stage if she has any, what are her plans? Is she planning any surgery for her genital transformation? Particularly the external one. Yeah. So sometime when you ask about the history, they might say, I don't have the periods. Okay, so why your periods? So you're not having periods. I have a hysterectomy. So what happens now? So this is what obviously best we can do about this scenario from the information. Now, what is the pathway? What is the process? How this transgender transformation and everything, what is the pathway here in this country, how it works? So the people, boy or girl, whoever at any age, if they feel they obviously recognize themselves in a different gender from when they are born, then the first thing for them to do is they will see their GP to go and tell them. It's not unusual for them to appear and present in sexual health clinics as well as the first done, but then obviously they are the GPs are taken on board as well. So when that happens, then obviously in the beginning they are given some time, so they don't go any surgical treatments and stuff pretty soon, even if they are very clear about their mind. For two reasons. Number one, obviously they need to have a really good time to reflect on their decisions, think about, and then go for those type of surgery. Then the second very simple reason, it is a very long waiting list for these transgender or gender transformation surgical list, because there are not many people who are doing these surgeries. There are only few. So that's what it is. So anyway, they get registered at the GP, and then there are gender transformation clinics. Then they get referred over there, and those clinics themselves has a long list, waiting list. So meanwhile, there are few issues, particularly if it's a female and want to be identified as a male, then the periods is the most important issue they have. And that's very stressful for them, and they want it to stop as well. So what we usually do for them is taking pill. I mean, we can offer them combined pill to take and continuously stop, but they don't really like it, and we don't really like to go on the pill either, because of the estrogen content in them, and they obviously don't want to. They rather want to go the testosterone and other therapies so they can start have a male appearance. So, but anyway, still the pill is an option for the temporary amenorrhea. To induce temporary amenorrhea, implant, they can have implant as well. They can have Depo-Provera. They can have Mirena coil as well. The coil again is not very much like, but it's not unusual for these girls to have a Mirena coil to induce amenorrhea. Mostly they start with Depo-Provera. Because that's done once and then they forget. They don't have to take it every day kind of thing, or just feel like they have implant as a being recognized as a contraceptive method. They are just like other girls because they don't want to feel like girls. So Depo is quite favorite one for them to start as a temporary thing, and then they go maybe on Marina coil till they are waiting for the surgery, or some go on implant as well. So that's the one aspect we need to cover. Then we'll see the psychosexual is very important. So when they come in, it's very important to check them. So how is their experience, and ask them in an open, neutral way, just how is their experience of going through this change, how they find about the sport around them, sport at home, how their friends are taking their, have they informed their friends that they are actually planning to do so, and what is the reaction of the, and what's the response of the friends. And it's very important because usually they are young people, and even if they're not young people, it's very, I mean, it's still, although there's a lot of awareness campaigns and everything, still it's not, you know, uncommon that these people get quite bullied. So their mental health assessment and this pressure is very important. So just open question, how is your experience? You know, what type of sport you have of the people around you, about your family, your friends? Have you discussed with them and how they find it? And then the next one for you is to start. So have you started taking some hormonal support for your appearance, change of the appearance? And then the third question is to ask about, have you had any surgeries done regarding the obviously transformation of your internal genital organs and the external ones? Okay, both, because sometimes they just have, they're different. Some people just have the hysterectomy done and oophorectomy, and then, you know, they don't want to, or they, sorry, not oophorectomy, hysterectomy usually, and then keep them on testosterone. And then some are, they want to have their external genitalia revert as well. Now that take quite long time. Okay, so that's basically is, and it's okay. Just as I said, like very simple. Don't get stressed by seeing, you know, if there is a scenario where the patient does this. Just take it as a normal. Just focus what words that they're using to identify themselves. Just use that name, that word, and the same word they use for their genital organs. That's it. Right. Any quick questions before we go to the next scenario? But please, all of you, try to get more information on this scenario. This can be quite, because it depends very much on that, what the role player actually do and say. And this scenario can go into any of the sides. Okay, we never know. She starts with the bathroom cyst and then end up having some abuse, domestic abuse or something else. Because these people are quite vulnerable to be to have domestic or sexual relationship abuses, and also bullying and harassment. Right. Who is next?
Dr. Safia,
Yeah.
if she is male and transformed to female, and this is lump, so what is the possible, how to deal with it? Because I heard it's a male transformed to female.
It was a male transformed to female.
Yeah.
That will be quite unlikely because then the GP won't use the word Bartholin cyst clearly. Okay, number one. And second, as I said, like, you need to ask, you know, as soon as you come to know this person is transgender, when you ask the question, have you gone through the surgery, then you will know. Okay. What it is, and if it is, then it's fine. You can simply just say, I need to have a look on that and see what it is, you know, the swelling. And then glands, I mean, if it's a cyst with some kind of gland blocked anyway, it may be sebaceous cyst then, which has converted into infected sebaceous cyst or into abscess. But if the GP letter says Bartholin cyst, I will take as a Bartholin cyst. Okay.
Doctor, is it possible that she had undergone surgery and vagina was created, new vagina was created, and that had prolapsed? Is it possible, sir?
Okay, the prolapse one, because I didn't quite remember it was Bartholin cyst or what. I just thought of the lump, and then I thought it probably was that one. That's why you said. But if somebody is, yeah, so if somebody is from male has transformed to female and they have created the vagina, no, they won't have that typical prolapse. Yeah, because their anatomy is different to start with. Okay, so their vaginal and the pelvic, and then the factors as well, which lead towards the perineal muscles weakness. Those factors are different as well. So the male person wouldn't have gone through. So they wouldn't. There will be other way around if they want to put as a prolapsing, but there will be a female who now identifies herself as a male, but she still have those organs, right? And then she might, when you take the history, she says, so for example, if it comes as a lump and stress incontinence symptoms, again, just focus what that person call herself or himself, then what words she uses for herself, and then obviously then there will be either that person will give you, or when you ask, have you had any surgeries done internal? So that person might have hysterectomy done, and now that person is a walled prolapse. They didn't go the external organs transformation, because that's very complex surgery. So not many of them go to the external transformation. But the hysterectomy is very common. Most of them have hysterectomy, just a matter of the waiting list when they get to be on that waiting list. And then they can have a walled prolapse. So the treatment, the options, everything will remain same, exactly, which you would discuss with any female. Okay, next patient, next patient, next person.
I think it's Rabab.
Rabab. Hello,
Deepthi.
Rabab.
Deepthi.
Deepthi, yeah, it was Deepthi.
No, Deepthi, madam.
Yeah, it's Deepthi. Right, Deepthi. Let's see what we can give you.
Deepthi is slept off. Actually, she is having severe stomachache.
Oh, bless her.
She applied leave only to attend this course, but I don't know. Unfortunately, she's not keeping well. Any assignment for her?
Sorry, just look after her. I will get in touch with her, and then I'll help her with that. Don't worry. Just look after her, and I hope she get better soon.
Thank you, doctor. Thank you.
Then next is Rabab.
Rabab. I don't know this. Right. Too much of overlapping of scenarios. Rabab, are you here and are you ready?
Hello? गैस बहुत लगती थी
Is it hello, Rabab, are you there?
Yes, doctor, I'm there.
You are there. Right, okay. Let's get back to where we were. Okay, this is for you, Rabab.
Okay. Yeah, okay, doctor, ready. Ready, doctor.
Yeah, you can start.
Okay. Hello, I'm Dr. Rabab, one of the doctors in the clinic today. May I confirm your name and age, please? Sorry.
Yes, my name is Cheryl Robert. I'm 31 years old.
Okay. Sorry, doctor, this is a structured discussion, right?
No, it's a patient.
Okay.
You're asked to see Cheryl Robert.
Okay, sorry. Okay. May I confirm your name and age, please?
Yes, I'm Cheryl Robert, doctor, and I'm 31 years old.
How you want me to call you?
You can call me Cheryl.
Okay.
I understood that you delivered recently and you had difficulty in passing urine. Am I correct?
Yeah, that's right, doctor. I had forceps delivery, and then I'm not able to pass urine, and I'm feeling really bad pain in lower part of my tummy as well.
Yeah, sorry for what you went through. Do you want me to provide you with the painkiller?
The midwife has given me some paracetamol. I'm okay.
Okay, so can we continue the consultation?
Yes, please.
Okay. I would like to ask you a few questions just to outline your management and treatment plan. And at any time you feel anything not clear, don't hesitate to ask me.
Okay.
Okay. So I understood that you delivered and it was a difficult delivery. It was by the spoon and that was in theater and you had a pain relief during labor, which was by the epidural. And then we removed the catheter and you are not able to pass urine. Is this correct?
Yes, that's right, doctor. Yes.
Uh-huh. How is the baby weight?
Baby is 8 pounds.
Okay. And do you have a stitch from down below?
Yes, I had. The midwife told me they had to do episiotomy.
Yeah. So do you feel you still feel too much pain at that time, at that point, right?
Yes, that's my stitches are painful as well, but I'm more in trouble because of the pain in my tummy.
Mm-hmm. Sorry for what you are going through. How is your baby doing?
Baby's doing okay. Yeah.
What did you call the baby?
The baby is called Emily.
Okay, nice name. Congratulations.
Thank you.
Okay. Can you tell me about this labor? Is it induced or spontaneous?
No, it was natural labor, doctor.
Okay. Otherwise, you don't have any problem, any health issue, you are visiting your doctor?
No, I don't have any health problems.
Okay. Do you have any surgeries from before?
No, doctor.
Okay. What about, are you on a special medicine?
No.
And do you have any allergy to any medicine?
No, I'm not taking any medicine. No, I'm not aware of any allergies, no.
Okay. Do you smoke?
I used to, but I stopped smoking during pregnancy.
Okay. Do you drink alcohol?
No, I didn't drink during pregnancy.
Do you use any recreational drugs?
No, doctor, not at all.
Okay. What do you do for a living?
I am a school teacher.
And do you have support at home?
Yeah, I have my partner. Yeah, good support.
Mm-hmm. Okay. Okay. Tell me, in the last 4 weeks, did you feel depressed?
No, not really.
Okay. Or did you feel losing interest in things that you were doing before?
No.
Okay. Do you have any family history of concern? You want to share it with me?
No, I can't think of anything.
Okay. Have you ever got pregnant before, or this is your first delivery?
No, this is my second child.
So after the first delivery, did you have a similar condition?
No, I never had any problems. I didn't have any problems.
And it was a normal delivery?
Yeah, there was natural birth, yeah.
Okay. What was the baby weight?
That baby was 7 pounds.
Okay. Okay, thank you for sharing information with me. Would like to examine you after your permission in the presence of chaperone. I'll check your blood pressure, heart rate, and temperature, plus your height to weight ratio. Is this okay for you?
Yeah.
Okay. I would like to tell you that after childbirth, some ladies can start having some form of urine retention, as already happened with you. So we are going to put a catheter, which is a rubber tube, inserted in your water pipe, and we'll see the amount of the how much you drain the urine. If it is too, if you are draining like special amount of urine, which is less than 500 ml, we will give you a chance that you might pass urine by yourself, and then we'll reassess you by means of ultrasound.
Okay.
To see again the amount of urine which is still remaining after that. If it is less than like special amount, like less than one, if it is less than 150, will give you a chance that this might happen. This problem might happen after giving childbirth. But if it is less, more than 150 ml, we will give you, will put you the catheter for like 24 hours, and will observe you for that. Sometimes after the 24 hours, we'll reassess you again, and we'll see if you pass urine. This is well and good. If not, then we will put you the catheter for like a week, and we'll assess you for that, and we'll involve the urology doctor in your care.
Okay, right. Yeah, okay.
Yeah. Am I clear to you?
Yeah, so will I be able to, you know, have a normal function on my bladder, doctor? I'm really worried.
Yeah, I'm sorry to what you are going through, but this might happen quite often after childbirth, especially if in such conditions like prolonged delivery, or using the spoon or the cup, or giving birth to a good sized baby. But with the time, it will improve, and you will go back to your normal water work function like before.
All right, okay, right.
But would like to send some urine test for culture to rule out any form of infection if it is there. And if there is an infection, we give you the proper treatment with antibiotic.
Yes, okay, doctor. So you said like, you know, I may need to put a catheter again for 1 day or so. And what if I not able to pass urine second time as well, doctor?
Yeah, this we will give you the catheter again, and we'll keep it for another 1 week, and this will give rest to your water bag, so it can return its function later on. After 1 week, we'll reassess you, and if you still are not passing, we'll refer you to a multi-specialist team of doctors, including the urology doctor.
Okay.
He will
Right.
share in your plan.
Right. Okay. Thank you.
Do you have any more concerns? Thank you.
No, that's okay, doctor. Thank you. Right. Okay. I'm good. Great. That was pretty good. The only thing I would like to add into this one at the closing is because we start like in the postnatal, you know, during antenatal time, exclude any existing depression. In postnatal women, you did ask questions to exclude any postnatal depression at the moment, but then this woman is particularly at risk, yeah, of developing the postnatal depression or postnatal blues or whatever. So just offer her that support by saying, it's not unusual after the birth of the baby because of the hormone reshuffling, and particularly if you have any problem in recovering as well, not to feel, it's not unusual to feel low in mood or even depressed. But at any stage, if you start feeling any of these symptoms, please immediately contact us. We do have a specialist team to assess and provide you help and support. Okay, so this woman, I would really like to give that advice as well. Right, so yeah, that was okay, fine otherwise. So yes, take the name, ask about the delivery, just ask her from, okay, tell me about your delivery. So difficult delivery. She has, just ask her how long the labor was, and she had epidural been taken 6 hours ago. Just establish again a bit of immediate well-being about her bleeding, vaginal bleeding. Does she have the bleeding? How is she doing? Has she been able to be up and about and she's moving around? So from urine, we know she's not able to pass urine. Just check about has she opened her bowels, or has she been able to pass some flatus? Has she been eating and drinking? Has she been able to take proper sleep in the night, or and how the baby doing? You did that nicely. You did assess about the depression signs. Have you been feeling any low or depressed? So that was fine. Any problems in the pregnancy? Just few questions about what there any problems during the pregnancy, and is that first pregnancy? Yes, she tells you about one more. Were there any issues, any problems with that? Yes, baby weight was important to us. That's good. And then you can start explaining. Just for yourself, for your own self first, you need to think about, okay, what possible reasons can be when you're preparing for your points to go inside the cubicle. So basically, the possible most likely reason is it can be the voiding disturbance problem. It can be because of the epidural, someone that are because of the prolonged labor, but there could be sometime hematoma, vaginal hematoma, and particularly they have theater being saying the forceps delivery in theater means this would have been a difficult forceps delivery as well, like head must have been high. That's why we did a trial in theater. So keep that in mind as well. Sometimes if they have a hematoma, that can also, because of the pain or pressure on the bladder, that can also make it, on the urethra, can also make it difficult for them to pass urine. So so to start with, in the immediate well-being, again, you can ask about particularly about the pain. The stitches are inside the vagina at the tummy. Try to make a difference there. And then ask, does she ever had this type of problems in the past? Like, have she ever felt any difficulty in passing urine in the past? Like, there might be some already ongoing reasons for that. So ask that question as well, and then you can start explaining to reassure first by saying, okay, it's not uncommon to have this difficulty in passing urine after having this difficult forceps delivery, and when if the labor is long, and then because you had an epidural anesthesia, sometime that can the sensations of your bladder can take time to return, which make the function of the bladder to return normal as well. So this can be, but however, you will also discuss, I would like to have a look down there as well on your stitches to see if they are healing, and then to get an idea inside of your bleeding, and also to examine you to see if there is any collection of blood inside, because sometimes there might be some tear inside, and you keep bleeding continuously, and that can collect inside, and that can also make it difficult for you to pass urine. But they obviously she will give really bad. I mean, she's giving vague symptoms, saying I have a pain in lower part of the tummy. This pain in the lower part of the tummy, yes, we know if the bladder is full, that will cause the pain, but it could be UTI, it could be hematoma basically as well, because the upper vaginal hematoma will also give more, perineal and low tummy. It's difficult to differentiate. It's tummy pain, perineal pain, where it is. So just keep that possibility in your mind as well. Yeah. So then, yeah, just ask about how she's feeling overall. Is she feeling well overall, or she's feeling unwell, or any fever or anything like that? Then you will explain to say, okay, because you're in a lot of discomfort. So in the beginning, obviously, pain, ask always about the pain relief, which you did ask. You said paracetamol. Now, first of all, you will say, so what we will do, I will empty your bladder with the help of an plastic tube, just in and out, and then and that will give you relief of this pain. We will send the urine sample then and there, talk about sending the urine sample to check for any infections in the urine. Sometimes that can be a reason. And then we will observe you for a few hours here to see if you're able to pass urine. And once we have emptied the bladder, then we will measure the amount of the urine passed, and then we will do a scan immediately after of your bladder to see if the bladder is completely emptied or if there is any urine left behind in the bladder. And then depending upon the amount, you will tell if it's like, we will encourage to pass urine. The first time you will pass the urine, we will give you some pot to keep it, because we would like to measure the amount of the urine passed, and then do the scan to check if it is emptied completely or not. And then obviously you will tell that cutoff is if it's less than 150. Then it's okay. We will just, like to pass you urine a couple of more times, and then you should be able to go home. But if the amount of the urine is more than 150, then or the drain bladder volume is more than 500, then we will like to put this catheter again, because then most likely reason can be that the sensations of the bladder have now returned completely. And because of the pressure of sometimes because of the instruments that the baby had, or because of the epidural. So in that case, we will put the catheter again and leave it there for 24 hours. And after 24 hours, what we will do then, we will start clamping your, that catheter. So that the urine can get collected in your bladder, and then we will see if your sensation has returned, and and if you start feeling the urge of the stage, you will start feeling the urge of passing urine. We can open the bladder, and we can repeat that a couple of times before we remove that catheter, just to make sure, yes, your bladder sensation has returned. So that's, you will say. But then again, if you're not able to after that again, you do not feel the sensations, then obviously we're gonna ask our the bladder incontinence that nurse to come down and see you as well, and then we will send you home with a catheter in for 7 days, and then just give her a couple of obviously red flag symptoms as well. The moment you have the catheter, and there can be a risk of getting infection in your urine or in the bladder. So if you feel any low tummy pain and any burning sensation, that will be time to contact us immediately, so we can check your urine for any infections. And then yes, just check what support she has at home, and then if she asks further, after 7 days, yes, we will assess you again and give and make your appointment with our urogynecologist and or with the urology doctors. Right. Is it clear? Any questions?
Thank you.
Yeah, Dr. Safia, please.
Yeah.
Yeah, you're always telling us to start by the immediate well-being of the patient. So shall we start by telling her we'll insert a small tube to relieve your pain, to relieve the urine, then we'll take the history as usual?
Yeah, so whenever it says that there is a lot of pain, always you first need to make sure to go and say, well, I can, I have been asked to come and see you, and I understand you're in a lot of pain because you've not been able to pass urine. Would you like me to give you some pain relief first before we talk? Are you okay? And then obviously they usually say, no, I have it, or I'm okay. And then you can proceed. And then the immediate well-being is obviously, it's very natural to ask about the amount of the bleeding down there. That also helps us to understand what exactly is going on. How is your bleeding? How are the stitches? And then type of the pain and fever. Is that your question?
So we'll start by passing the urine first, then we'll take the history examination investigation for this.
You can get some information before explaining her the management plan. It's okay. You can even say that, like, I'm gonna empty your bladder first.
Because
and
it is
then
written she
we'll
is in
start.
severe pain. How she will answer my question if she is in
Yeah,
severe pain?
you can do. You say, let me empty your bladder first, and then we get some information. Okay. Right. Who is next now then?
Myself, Dr. Safia.
Okay. 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 This is for you then. Your 2 minutes start now. Okay, that's your first 2 minutes.
Hello, I'm Dr. Reena, one of the doctors in the clinic today. May I confirm your name and age?
Hello, doctor.
May I confirm your name and age? Hello?
Yes, my name is Sarah Harrison, and I'm 58 years old, doctor.
How would you like me to address you?
You can call me Sarah.
Thank you, Sarah. So, Sarah, as I've gathered from your GP's letter, that you have something coming down from below. Am I right?
Yes, I have been feeling this really some large lump down there, and I'm having this, dragging feeling as well, and that's going on for a few months.
Okay. So, Sarah, is it okay if I just asked you a few questions so that I could know a little more about you, and then together we could address
Yes,
this issue?
doctor, of course.
So,
Yeah,
Sarah,
that's
can you?
absolutely fine, doctor.
So, Sarah, can you please update me regarding this lump?
Yeah, so this, so like I have been feeling this for a few months, and it's becoming like a bit more prominent now, and it feels like dragging down, and I'm having some lower backache as well. And the other thing I'm having is I leak urine when I cough and sneeze, so that's really embarrassing and bothering me. So I just really want something done about it.
Surely. So in a couple of minutes, we will be addressing that. So has this increased in size?
Yeah, I would say it has become more prominent. Yeah, it has.
Okay. And does it interfere with your waterworks and your bowel habits?
So I mean, it's really embarrassing. Yeah, I do feel sometime I have to kind of, push it back to empty my bowels, and I leak urine when I cough and sneeze as well.
Okay. And this must be affecting your quality of life, right, Sarah?
This has, yes, absolutely.
So, Sarah, just to ask you that, are you sexually active?
Yes, I am, but to be honest, we've not been doing much because I'm just been really anxious about this, that that I might just leak during sex. So I'm really trying to put it off.
So I understand, Sarah. So, Sarah, have you ever been pregnant?
Yes, I have 3 children.
Okay, and what about the mode of delivery?
They were vaginal births.
And do you remember the weight of your babies?
I don't exactly remember, but they were healthy babies.
Okay, and how was your recovery?
It was fine. There was no problems.
Okay, so Sarah, have you gone through the change?
Well, I had my womb removed when I was 45. So,
okay.
Yeah.
So, can you tell me why you had the surgery?
I was having very heavy periods, and they didn't really respond to Marina coil, and then they had to remove my womb.
Okay, I understand. So, Sarah, are you having any other medical concerns for which you're visiting the GP regularly, like any chronic cough or something?
No, I don't have any that type of health issues.
And apart from this surgery that you spoke about, any other surgeries you've had in your tummy or down below?
I had my appendix taken out. That's all.
Okay, okay. And are you allergic to any medicines or any substance?
No, as far as I'm aware of, no.
Okay, and what about your weight to height ratio?
There's 26.
Okay, and do you smoke or drink alcohol?
Yes, I do, doctor.
How many cigarettes a day?
It really depends how I feel. When I'm really stressed, I can smoke up to 20 cigarettes. But on average, maybe 12 to 15 a day.
Okay. So, Sarah, have you ever thought of quitting smoking?
Well, I tried a couple of times, but it just couldn't.
Sarah, just to give a suggestion that if you ever decide to quit smoking, then there's a very good program with the NHS of stopping smoking, and this would be very beneficial for your health. So you can just give it a thought.
Yeah,
and if possible, you can also cut down a bit on your alcohol consumption as well. And Sarah, can you tell me about your support at home?
So, I mean, I have family and friends around. My children are in out of house now. Yeah, I have. I mean, I have family support.
Okay. And Sarah, how have you been feeling in the last few weeks?
Well, obviously, I'm a bit stressed because of this. Because it's really interrupting my activity. I don't feel like going out as well, so it's been affecting really, causing some stress really now.
So Sarah, would you like me to connect you to a counselor who can be of immense help at this time? Just by talking, you could feel a little less stressed.
No, I'm okay. I mean, it's not that bad really.
Okay. So Sarah, the complaints that you told me about, have you tried any treatment for the same?
Sorry, for what?
Regarding the lump that you're having down below, have you tried any treatment for?
Yeah, my GP told me to do some exercises, and I have tried. They don't seem to do anything.
Okay. So, Sarah, thank you for sharing the information. From what you have told me so far, from the history that I've gathered, that you had a operation, and following this operation, you're having some laxity in the vaginal wall. If I can draw for you, this is the womb, and this is the vagina. So once the womb has been removed, what we have at the top is the vagina, and we call it the vaginal vault. Am I clear so far?
Yeah, yeah.
So normally this structure is supported by the pelvic muscles and the ligaments. So when this is removed, what happens? There is a laxity in the upper part of the vagina. Am I clear so far? So what happens? This may come down, and this protrusion of the vault into the vagina is known as vaginal vault prolapse.
Okay.
And in your case, the vault is a little less than 1 centimeter outside your vaginal opening, and this we call as grade 2 vaginal vault prolapse.
Okay. Right. Okay.
But Sarah, there are management options. So would you like me to talk about them?
Yes, of course, doctor. That's why I'm
yeah.
here.
So Sarah, we'll be taking up your case with my consultant and a group of specialists who deal with surgeries around this part of the body, whom we call as the urogynecologists. And also we will, in our team, there will be the specialist nurse. So we would definitely suggest you the lifestyle modifications, like, cutting down on your smoking and having a healthy lifestyle. And along with this, we would also suggest you some pelvic floor muscle exercises, and this will be done under supervision. So you'll have to practice like some 8 contractions 3 times a day, and this will continue for a period of around 16 weeks. That's around 4 months.
Right. Okay.
Okay, and along with this, there are also certain surgeries that we can do, but at this stage,
Your
it is
time
a
is
lifestyle
over,
modification.
but you can tell me.
Yeah,
Okay.
at this point in time, it is the lifestyle modification and the pelvic floor exercises, but there are some surgeries as well. And would you just like me to talk about them, or should we discuss them when the time comes?
Well, I want to get some idea about what
Okay,
treatment
sure.
is available, doctor.
Yes. So in terms of surgery, there is one surgery which can be done from the tummy end, and this can be done by a keyhole surgery, or it can be an open surgery. And we call this as abdominal sacral colpopexy, where we fix this vault of the vagina to a bone in the lower part of our backbone.
Okay. Right.
I know I'm giving you a lot of information, and then there are certain associated injuries along with this. However, an expert team will be doing the surgery so that all kinds of complications can be minimized. And then we have surgery from the vaginal end as well, which we call as the sacrospinous fixation. And the advantage of that involves fixing up the vault to a spine on the lower aspect, which we call as sacrospinous fixation.
All right. Okay. And what's the difference between both, doctor?
Yes, if you're sexually active, then as you said that you're sexually active. So, however, you do not, you feel a discomfort. That is why you do not go into it. So if you do it from the vaginal end, there may be shortening of the vagina. So if one is keen on vaginal sexual activity, then we would advise the surgery from the abdominal end, which helps to maintain the vaginal length.
All right. Okay. Yeah, I think I will probably consider that one then.
And the exercise that I've suggested to you, this will also help you in preventing the leaks that you have. And at the same time, I would also like to check for any infection in the urine. If there is any, then we shall give you medicines accordingly. So as of now, today I will ask you to suggest the lifestyle modification and also tell you about the pelvic floor muscle exercises, connect you to the physiotherapist, and I will give you the written information and arrange a meeting in 1 week's time. So if you have any queries, I'll be happy to answer them.
Okay, so I heard about some pessaries to use as well, doctor. So what are they? Can I use the pessary and not have the operation?
Yes, pessary is another form of management in this situation. However, it is not a permanent form of management. And however, if one is not keen on surgery, or if in the interim period awaiting surgery, one can use pessary. And this is a plastic device. We have to try a number of them. And the one that fits you best will be given to you. You have to change it every 2 to 3 months. And if you have any problem, we will be there to support you.
All right, okay. So is that something I can use while I'm waiting for the operation being done?
Definitely, definitely. So we will arrange for that as well. We'll get quite a couple of pessaries and we'll see which is the best fit for you.
All right, doctor. Okay, thank you.
Thank you for your time, Sarah.
Yes, thank you. Right, okay, so we went well above the time, but that's okay. I did ask you some more extended questions. The pessary option, I mean, there's a different thing, like what the patient will choose, so give them that option as well.
Yes, ma'am.
It's not unusual to offer them this option while they're waiting for the surgery to be done anyway, because if somebody's so much symptomatic that is affecting the routine, activities and everything, then they can obviously use temporarily for the pessaries. Don't forget to talk about that. So I think you took quite a long time in the history taking, and that's why you ran out of the time. So yeah, just review that, maybe how you can shorten on your history. Although I think you did ask all the things we should have been asked. But anyway, so yes, so start with the name, just like as we did with the previous stress incontinence one, name, age, and then just give me more information about the lump, when it started, and has it been growing in size, and then she told about the dragging sensation. Ask about sometime, instead of asking the patient repeatedly, tell me more about this, more about this, to start with the first one, we call usually it a golden 1 minute or golden 2 minutes. At the beginning you can give them open questions, like tell me more about this lump, and about this, the pain or the dragging sensations you're having. After that, maybe for exam point of view, it's better to ask them specific focused questions. So yeah, so after that, just ask about the stress incontinence. If she hasn't volunteered that information already, talk about, do you feel any problem in emptying your bowels? Instead of saying any problem with the waterworks, just ask again very clear, like, do you feel any leakage when you cough and sneeze, or how is your control when you need to go to the toilet? Feel any problem in emptying your bowels? And then yeah, so then go for other questions. Smoking, ask about the weight, any health problems, surgeries. She told you she has a hysterectomy done. Children, I know the weight of the children is also contributive factor, but to be honest, I mean, for somebody 58 years old, she has it, and I wouldn't be bothered about the weight of the babies. That is one of the predisposing factors, but once she had it, she had it. So maybe you guys can save some time from, by not asking the weight of the babies. But if you feel you can accommodate in a time, that's fine. Nature of the work, you said I work in a shop or factory or whatever. Probably it's a good idea to ask her what exactly you do there, yeah? So if you ask her, will tell you I'm a cleaner over there and I have been dragging around the furnitures and all that stuff. So for this particular one, where we know exactly the work nature can affect the condition, it may be okay to ask them a bit more. So then yes, sexual history was fine. You asked about any problems with that, and then yeah, and then you start explaining. So to explain then, so she said I have an operation done. I will include the perineal pelvic muscle weakness as well, as a part contributing part. So one obviously is yes for the wall prolapse. It is because you when we remove the uterus, there is a sport at the upper part of the vagina. From the moment we remove it, then the sport is obviously gone. And as a result, the part of the vagina can become weaker and it can sink down. But then the pelvic floor muscle support is very important as well. So don't forget to talk about that as well. And the other thing is these muscles which support these vaginal walls and the upper part of the vagina, we call them pelvic floor muscles. When you're postmenopausal because of the lack of estrogen hormone and after your 3-4 vaginal births and bearing during the birth procedure, these muscles lose their strength and tone as well. And as a result, they become loose and dragging down, and they pull back your bladder and your bowels as well, because we have to give her explanation about why she's finding difficult to empty her bowels, why she have to push it back and that one. Yeah, so they just pull down the bladder and the bowels as well, and that's why you're having problem on that leakage. Because the support around the neck of the bladder has gone weaker. So it's very important again. So try not to use the word lifestyle changes. These come, you know, even if we apply it to ourselves, it's very generic word. Yeah, we hear it all the time. Like if we have our weight is towards heavier side, our friends or family members might tell us. We also ourselves even keep saying, well, I need to really reduce my weight, but we're not really doing much about it. Yeah, we may not. But if you will clearly relate that to me by saying, well, this is one of the factors, this, you know, which is causing you the problem, this really to be, then I'm going to focus it. You know, if I'm overweight and I get diagnosed with hypertension or diabetes today, then, you know, although now at the moment I might feel I don't really get time to get to the gym. Yeah, I know I need to reduce the weight, but I don't really. But the moment I get diagnosed with hypertension or diabetes or anything, then I know this weight is not going to play a major role. And then, you know, even with this busy life, I will manage time for gym and everything. So that's why if instead of saying lifestyle changes or general lifestyle changes, just relate the weight, smoking and stuff to this, and then tell them, like, you know, doing this is going to really make a huge difference to your issues. So yes, so tell her, like, so because of this, that's why these pelvic floor muscle exercises are very important. I know you told me you have been already trying them. What I'm going to do now, I'm going to make an appointment to our physiotherapy so they can, you know, train you in proper supervised, because these exercises will help your pelvic floor muscles to regain their strength and tone, and this is going to make a huge difference in your this prolapse. Okay, and then same with the smoking. The smoking basically also causes, you know, certain changes in the tissue, which increases this weakness in the muscle. So it's very important that you do consult your GP to start some help with the smoking cessation. And then you will say, so I wouldn't go into detail to explain these many contractions per day or kind of thing, simply because of the time. And then when we're sending to the physio, they will train her about that anyway. So you know, take your time from there, and then just say, just give some idea about the pastries as well, to say, then come to the treatment options, to say, the, you know, the definitive and long-term treatment management of these ones is obviously the first is very important, that you do these exercises and then regain the tone and the strength of the muscles back. And then if you're still you're having problems and the symptoms, then there are some you know, simple operations available which we can do. And then just simply say, one of them is called this sacroplexy, one is called sacrospinal. Just simply you explain that nicely by saying, we were the top of the vagina, we can, you know, fix it with the backbone to the lower part of this. However, you know, but you are sexually active, then you can explain that, you know, this particular procedure will be more beneficial. We will explain in more detail when we come to that stage. So you can leave it there. And then now you can ask about the pastry as well. And you just for the temporary relief of your symptom, as you start, like you're having this problem of leaking and coughing and sneeze, and then difficulty in passing. If you want to, we can actually put you we call it as a pastry, and you can tell serving pastry plus take one, and that will, by putting that, will just, you know, lift up the walls and the upper part of your vagina, and that will just, you know, make you feel better from this feeling, that will reduce that feeling of lump and dragging sensation, and that will also reduce you know, the problem in your emptying the bowel and stuff. How you feel about it, just ask. If she wants to have that for the time being, then it's fine, we can do it, and if not, then it's okay, we can leave it. So ask her how you feel about it. So I'm gonna do this. If she's overweight, I try not to go towards the heavy. I mean, 26 still is a bit overweight. You can still ask her to work actively through the gym and the program to reduce her weight. And then give her this time for 4 months, because if simply, if you will say, you know, do these exercises and do these lifestyle changes and we will see after four months, that's not really going to motivate me. For me, it will be just like you have left me just for another 4 months. But if you will clearly tell me why these exercises and why they are important, then yes, I'm going to take as a treatment, beginning of my treatment, really management, and that's going to really make, you know, then I'm going to really work hard on those exercises and stuff. Right,
Thank you, ma'am.
next and the last. You did really well, Rina, I will say. Just retry it to see how you can fix it within.
Ma'am, can I ask a question? Just one question.
Yeah.
Ma'am, regarding this, at which body weight should we talk about this reduction in the, I mean, since you said 26, that's why I did not say anything, because then she might think that, giving a over advice. So I really don't know at which cutoff we are supposed to say that you can work a little on your weight.
No, that's okay. I just said, like, if they are overweight, I mean, even
So,
after 26
if
as
she's
well,
30,
you can say, like, you can
okay.
just, but if it's
Ma'am,
more than, I mean, no, not like 30 is like too much, you know. So the normal BMI range is up to 25. If it goes up, it's fine to take, say, to introducing some weight is also going to play a major role.
Okay, thank you, ma'am.
Yeah.
Hello, can I ask two questions?
Let me just complete. And if somebody get offended on that, even, I mean, don't be afraid that we don't want to touch this word because the person might go offended. As long as we know clinically that this particular thing is related, even if they get offended, it's absolutely okay. Just say if they go offended and angry, just say, I'm sorry that you, feel this way. But this actually has really important role, and doing this is going to do otherwise, other management options, other management, or the treatments may not be as effective. And then they understand. Yes, please. Next person, what were you asking?
Ma'am, I have two questions, ma'am. First one, when can we advise urodynamics in this case? Is it before surgery? And second question, ma'am, if the patient asks whether my leakage will be improved after prolapse surgery, what should we tell the patient?
Okay, so the first is obviously we were going to send her with these measurements, which we have said after four months time. When she come in, then there will be a separate obviously consultation, and at that stage, depending upon what has improved and how much has improved, and if not, then yes, we may consider to do urodynamic. The urodynamic will be done before surgery. And the other thing, sorry, what you said, if it did not improve after surgery, will it really improve?
If she is going for surgery, prolapse surgery, wall prolapse surgery, and the patient asks if my leakage with cough, these symptoms will improve after surgery or not.
Yes, you can say it's highly likely there will be significant improvement. However, and then you can just tell, like, it's not, it may not improve 100%. So we obviously can't, they may improve and then they come back again.
Okay. Yes. Okay, ma'am. Thank you, ma'am.
You're welcome. Okay, so the last one. Are we done all 10? It's not coming to end today. Are we done with all cases? Post-general wall prolapse, we have done retention, mixed incontinence, and Bartholin. Any other scenario from urogynae you want to do? Let me see what I have got other than these. I think I just got these mixed stress incontinence and these. Yes, that's the stress incontinence. Okay, let's do this one. This is the last one. Who is next now?
I think it's me.
Yeah.
Sujata.
Yes, Sujata. This is for you then. Okay, Sujata, that's your first 2 minutes.
Hello, I'm Dr. Sujata, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, doctor. My name is Kathy Brown, and I'm 47 years old.
And how do I address you?
You can call me Kathy.
Yeah, Kathy, I see from your notes that you're having some problems with your waterworks and you have come for the management of the same. Is that right?
Yes, doctor, that's right.
Can you tell me more about your problem with the waterworks?
So I am having, I'm leaking when I cough and sneeze, and I have also noticed that I need to go more frequent to the toilet. And I just pass small amounts of urine. So obviously, I'm really troubled with this. So I went to my GP because I have really heavy periods as well. And he examined me and done some scan, and then he arranged this appointment for me to come here. So that's why I'm here.
Oh, okay. And how long has this problem been going on?
So it's about more than a year now, really.
Okay. And have you tried any treatment for the same for your leaking?
Yes, my doctor asked me to, to do some exercises. He told me how to do, and I'm trying to do them, but to be honest, I haven't seen any difference.
Did you go to the physiotherapist for the exercises or you did at home?
No, he didn't send me to physio. He just told me how to do it, and then I have been trying to do them.
Okay. And did the GPs send any blood urine investigations?
Yes, he did. He checked a few times, but it's always clear there's no infection or anything.
Okay. What about your fluid? Meaning, what type of fluids do you take? Do you take more water or?
Yeah, I drink plain water, and I take in a whole day I take only 2 cups of tea, 2 or 3 cup of tea. That's it.
Okay. What do you do for a living, Kathy?
I'm a school teacher.
School teacher. Are you well supported at home?
Yeah, I am. Yeah.
Yeah, and I see that you smoke 10 cigarettes per day. Have you thought of quitting it?
Well, I know I shouldn't be smoking, but no, I haven't particularly tried to quit smoking.
Kathy, smoking can irritate your bladder and cause you to pee often. So it will be good if you can reduce it completely. And we have a stop smoking cessation program with the NHS. Would you like to be referred to that?
It's okay. My GP told me he can, arrange that for me when I feel to do so. So I will contact him.
Okay. And Kathy, coming to your problem of this heavy menstrual bleeding, how long have you been suffering with that?
So my period's been heavy for around the same time as well, like for one year or 18 months, really, something like that.
Okay. And has he given any treatment for the same?
Yes, in the beginning he gave me that contraceptive pill, the combined pill, but I couldn't continue with them because I started having really bad headaches. So I had to stop, and now we use condoms.
Okay. And this ultrasound is also done when?
This scan is done 2-3 weeks ago. It's quite recent scan.
Do you know about the report?
No, the sonographer said the doctor will explain, so I don't know.
Sure, sure. I'll come to that. And have you been pregnant before?
Yes, I have 3 children.
How were the deliveries?
There were vaginal births, first two were vaginal, and the last one was cesarean section.
Okay, and what about the weight of the babies? Were they big babies?
No, they were okay. The weight was okay.
Sure. And what about you? Have you been feeling low or depressed for the last 4 weeks?
No.
Okay. Okay. Thank you, Kathy, for the information. Is there anything else you would like to add?
No, that's all. I just want to know how it can be treated, really.
Okay. And so, if you, with your permission, can I examine you in the presence of a chaperone?
Yeah, if you need to, yeah.
Yeah, because you were complaining of heavy menstrual bleeding and you were complaining of peeing when you're coughing. So I'd like to, other than your blood pressure and your height for weight ratio, I would like to examine your tummy to see if there are any masses, and I would like to examine from down below whether whether your vagina has and the uterus has dropped down, and yeah, and now coming to your result, I have confirmed that it belongs to you with your name and NHS number, and it's showing that the uterus is big and there is a growth in your womb.
Growth?
Growth.
What's that?
Yeah, it's a tumor of the wall of your womb. We call it fibroid. Have you heard of it?
No, I don't know about the fibroids.
Yeah, fibroids. See, I'm drawing the picture of your womb. The fibroids can either come from the wall of your womb, or it can arise from the outer surface of the womb, or it can form from the wall. It can grow into the inner lining of the womb.
Okay.
Yeah, so that can cause heavy bleeding. In your case, it's a big growth. It is 12 into 10 centimeters, and
right.
it doesn't mention where it is, but it is a 12 into 10 centimeters growth. So this fibroid can cause the heavy menstrual bleeding that you are having,
Oh,
and
right. Okay.
you are also peeing when you're coughing. So we would like to offer you a surgery to remove this growth of the womb. If you do not need more children, then the option is we can remove the womb, and meanwhile we would encourage you to visit the physiotherapist and continue exercises for at least 4 months under
So
supervision, so that
this fibroid, you're saying this growth, is it cancer, doctor? This, growth, or something? I read these growths.
this is not a cancer. It's a non-cancerous
Okay.
the wall of the womb. We call it fibroid.
Okay.
So since you do not need more children, the one option is we can remove the womb itself. Otherwise, if you do not want the womb to be removed, we can remove only the fibroid from your womb. That is
Who said
also
I
another.
don't want children, doctor?
Kathy?
Who said I don't want children?
Sorry, I didn't ask you. Would you be interested in having more children?
Sorry, it's okay. Keep going. Keep
Yeah.
going.
Yeah. If you don't have more fertility uh, wishes, then we can offer you removal of the womb. Or if you don't want the womb to be removed, we can remove only the growth. And along with these exercises, it should help you in this problem of the water leaking when you cough. Is that right?
Yeah, doctor, that's okay.
And I can fix you an appointment with my consultant, and you can I'll give you written information as well, so that you can go through this option of the surgery, which can be done if you're interested. It can be done either through a keyhole surgery or through a cut on your womb. And I'll also give you an appointment with a physiotherapist, and I'll encourage you to cut down on your smoking as well. Is there any more doubts that you have?
Okay. No, that's okay, doctor. So I need to have an operation. I need to have a surgery for this.
Yeah, because your heavy bleeding has not been controlled with the pills, and you could not continue it because of your migraine. And if you are not, that is a option.
Yeah, that's fine. Your time is over now. So we will stop here. So there are some names of the stations girls have sent in the group. Albuvijana Fista. Yeah, that was a good one we could do. Why didn't you tell us, Sajila, before we started this case? Okay. Right. These ones now we can do as a discussion in the group. Yeah, here on the WhatsApp, you can just do them. Right. So yes, it was fine, Sujata. The reason why I just, I was a little bit naughty to ask who said I don't want more children, because we can't assume. So we can't say.
I didn't ask,
I know.
sorry.
Yeah, it's all right. It's okay. I just wanted to emphasize in it. So being
Yeah.
47 years age and she, 3 children, again, as I said, like as we were talking about for some 55 years old sexual history, we can't assume. People have different lifestyle and different, and it's not unusual. That's why there is a college guideline about advanced pedantry guidelines as well. I literally had one patient, 48 years old woman, and she came other day to discuss about if she wants she wants to have a child. She doesn't have any, and she never tried for pregnancy before.
Okay.
So the lifestyle and things has changed hugely. So we don't need to assume anything. Just open, simple questions. Yeah, so that's one is the history taking was fine. 47 years old. Yes, asked about the symptoms, urinary leakage. She said, and cough and sneeze, how long that is going on, what she has tried. And then about her, she said, I go more frequent by a small amount of the urine. Obviously, there's pressure symptoms basically she's having from this fibroid. But yes, we have to exclude UTI, which you did by asking, and she said GP has done and they've been clear. Parity is really important, yes, about how many children you have, sport, and then the routine history, whatever you require. So from the management point of view, yes, you will start by asking, okay, so obviously there are two problems here. One is that you are leaking urine when you cough and sneeze, and you feel that you need to go more frequent and you have to rush as well when you need to pass urine, and the other one is you have heavy periods. So then says, I can see your doctor has done this scan. So the scan, the fibroid, the way you described, if we use the word of growth state away or the mass, the patients get worried. Because from Google search, from Google thing and everywhere, the growth and the mass, they get a bit where tumor growth mass, they do worry a little bit more with the cancer. So the way of the fibroids I describe to the women is I just simply say to them, okay, so you have the scan done and your scan shows that you have a fibroid. Fibroid is simply an overgrowth of the muscle.
Okay.
Say that in one sentence so she doesn't struggle, but most of the people know about the fibroids, but it's okay. I mean, you can ask, do you know anything about the fibroid, and she might know already anyway, but it's better when you say, just explain it straight away. So, and that is about 12 to 10 centimeter. And your hand, obviously, you can, this is about tennis ball size, even bigger than that. I would say cricket ball size. So you can say, that's obviously quite big. So your bladder is right in front of your womb, and then your womb and the back is your bowel. So obviously, if there is, that cricket ball side fibroid there, that's putting pressure on your bladder. So that looks likely reason of the problem that you feel more frequent to go to pass urine, and also finding that you have to rush. It can be likely reason of your leakage and cough and sneeze as well, because we see when you cough and sneeze, that just increases the pressure on your bladder, and that probably makes you to leak as well. However, another possible reason for urine leakage and cough and sneeze can be the weakness of the pelvic floor muscles. And then again, you can, tell, like, when we are approaching towards our menopause because of the lack of the estrogen hormone, and when you have 3 children deliver vaginally, they can contribute towards the weakness of the muscle. They lose their tone and all that strength, and that's why they don't contract and keep the neck of the bladder tightly closed when you cough and sneeze, and that's why you're leaking. Regarding cigarette smoking, yes, that's fine. Just tell her to stop doing this. So the management options now, then you will say, okay, so what happens basically with the fibroids as well? Because now we need to keep 2 things in mind here. If it was only fibroid, she's approaching towards menopause, and at menopause and after that, the fibroids start shrinking anyway. So if that was just an isolated problem, we probably wouldn't have worried much about. We would have gone just for some treatment for the heavy bleeding, maybe Mirena coil. If she's not with combined procedure. But then we have the symptoms because of the pressure symptoms. Okay, so here we can offer her myomectomy or hysterectomy. I wouldn't offer straight away hysterectomy. It's better to go for myomectomy rather than hysterectomy. That will depend, but we can tell her. I will tell you in a minute how to say that. So then when you come to that, then this is exactly you will explain her. Yeah. So the fibroids usually cause like this way. They have a bleeding. And they also respond to the hormone, our estrogen hormone, which gives us period and stuff. So your age is 47 and the average of menopause is about 52, and around about that time when the estrogen levels go down, usually the fibroids start shrinking. So the common treatment in these type of particular circumstances we offer could be just, if it was only the heavy bleeding was the problem, we could just offer you to have that one of the coil that calls Mirena coil that works on the lining of the womb to make it thinner, and that can reduce your bleeding as well. However, in your particular circumstances, because you're having problem on, you are having these pressure symptom on your bladder because of this, and that's why you have to rush for the bladder and others. If you think your symptoms are really bothering, then obviously we can remove this fibroid for you, and that will obviously relieve that pressure on the bladder. Okay, so we basically are going to keep the options open here for her. And that can relieve the pressure, and then hopefully will take your symptoms away of that going and rushing frequently to the toilet and emergency, because we still are not sure if the frequency in urgency is
Due to the
purely
fibroid.
because of the fibroid. Yeah, there could be some detrusor activity going on as well. So keep those options. So that's why we say the may, that could help with that one. However, and then we see pelvic floor exercises in forma, they're very important. They must be done, to relieve your symptoms of that and cough and sneeze. And then ask her how she feel about it. If she says, yes, that's fine, I would like to go ahead, then again, you're going to say, so I'm going to discuss with my consultant, to about this fibroid and all this management discussion we have done. And then sometime, because of your symptom of that you need to go more frequently, and then you need to rush for passing urine. Sometimes there is a special test because urodynamic test that also needs to be done, but I will discuss with my consultant to check if they would like to do that before they consider and book you for removal of your fibroid. Okay.
Okay.
So
Yeah.
that's what. So with the exercises, we will send her obviously with the exercises. We can address her bleeding for the time being. So we can offer her either tranexamic acid or some progesterone only pill even. Yeah, because again, we need to do that. And then you also here we will speak about full blood count. if she say. Then if you're talking about surgical options, then we'll say, so I'm just going to do this test to check your hemoglobin levels, because if you're bleeding so heavily, then you could have iron levels may be low, so we will correct them. And meanwhile, while we are discussing and making this plan, what will be the appropriate management plan best suitable for you, I can start you on these pills. So they have only one hormone called progesterone, and they can help reduce your bleeding meanwhile. All right. So this is what we will do for her. Regarding the examination, which you said to her that I would like to examine you, when there are ultrasound scan findings or CT scan findings done, girls, don't worry about the bimanual examinations in those ladies. You do have that picture, bimanual examination. Your scans are more, give you more reliable information than bimanual. But yes, you will examine this woman, and the examination will be actually to check for the prolapse, vaginal prolapse. Okay. All right, that's all done.
I didn't
Any
ask
good
about
questions?
I didn't ask about the bowel symptoms because of the pressure of the fibroid and such.
Yeah, you can ask about always with these ones, leakage and these sort of, if they have urinary leakage, remember that always ask about the bowel as well. Do you find any problem or difficulty in emptying your bowel? Okay.
So,
Madam, we need to tell about GnRH and Alox or ulipristal in this case.
Okay, so number one, I'm glad you just said it. Ulipristal is not used anymore for the fibroids to shrink their size. Okay, this has been banned since last year for this particular use, because ulipristal has been causing very severe hepatic toxicity. So that has been banned. Ulipristal is still used for emergency contraception because that's a single use and that doesn't cause. So ulipristal is gone out of that window. GnRH, what we have now said here again is we still are not sure what the consultant would like to do. Yeah, we have given the picture, we have given the structure and the framework. Yeah, that we're going to, because yes, the when we speak to the consultant, and consultant say let's do the urodynamic, and when we do the urodynamic, then there will be that come as a disorder overactivity as well. Yeah, in that case maybe we don't go for myomectomy, because that's a major surgery, hemorrhage and all those risks. So we can deal with her with Marina at the moment, and then iron and whatever, and then just leave it for the shrinkage. So the GnRH, whether we need to give, we will be giving you the decision. That discussion will come when we have decided to go for myomectomy. Yeah. Then we will say, okay, so then depending upon the size and all that, said, okay, so we are planning for the surgery, let's give GnRH to shrink the size, because they have so much side effects as well, menopausal symptoms and all that stuff. So if you put the patients on GnRH, and at this stage, then if we haven't still decided we're going for the surgery, we're not going to achieve anything other than, giving her that all symptoms of the motor symptoms. Okay.
Thank you.
And that's why you will say, once that have, you give ideas though that this is possible, this we will be doing, but I need to discuss with them, and then I'll arrange your appointment, and then we will discuss with you and explain you, if we decided to go ahead with that surgery after consultation with you, then we will give you the details about the procedure and also what we need to do to prepare prior to surgery. This is how
Dr.
we
Safia, what about UAE here? Shall we offer it or shall we mention it in the management? UAE. Uterine
uterine embolization.
Yeah.
Uterine artery embolization. Yeah, we could actually. That one could be a good option as well. Yeah, to shrink the size, and that can take pressure symptoms away. Yeah, we can. Of course. UAE can be. Yeah.
So the first step we'll do urodynamic study to exclude any
we need to do urodynamic study. She will need urodynamic study. So that's what I'm saying. I'm going to discuss with my consultant, because he may like to do that special test. So that's regarding incontinence. But fibroid management, yes, I would actually offer UAE. That we can't do. I mean, I will explain her the option that the one can be, we can do this to reduce their blood flow, to shrink the size of the fibroid, and I will relieve your pressure symptoms as well. Or the other option is we can remove the fibroid. However, I need to discuss this with my consultant.
Also, Dr. Safia, about the fibroid itself, shall we contact the radiologist to know more about the fibroid, because we don't know it is intramural, submucous, subserous, where it is.
Yeah, it is not given. It's not given the location of the fibroid, and Mirena can be put in such a big fibroid, Dr. Sabia.
We can do what?
Mirena can be inserted in a huge fibroid, the uterine, if it is
Yeah, if it's
distorting.
not some mucus and it's not distorting the cavity, then we can.
Because it is not written here, Dr. Safia.
Yeah,
So
it's
shall
not
we
given.
contact
So
the
yes, so
radiologist?
yeah, you can take more information from the radiologist as well. Okay.
Will we do an MRI?
Okay, when we are talking about the standard, let me explain here why we have done slightly different here than the routine. When we are talking about like somebody in 30s or early 40s or something like that with the fibroid, and the fibroid or even with the pressure symptom, the fibroid is the main problem, then obviously you will go just as a standard protocol. Okay, so regarding about, starting from combined pill or Mirena coil, then you will be talking about myomectomy, shrinkage, GnRH, all this. This women, the only reason why we went slightly different, and we're not straight away saying we're going to, okay, we can remove this fibroid or we can do this and all that blah is, because she's 47, yeah, her fibroid itself is going to get resolved in 3-4 years as well. And the second thing is like she has pressure symptoms. So that's why we're focusing more on towards either shrinking the size of the fibroid or on removal of the fibroid. Okay. Otherwise, yes, you just stick to your normal the normal ladder step approach we have for the management of the fibroids. So here first we have to establish obviously what is the main issue that woman has. Yeah. So she says heavy bleeding, but maybe that's not really a problem. It's more the leakage, pressure symptoms which we feel is because of the fibroid. But then we do urodynamic and then come back as a. So obviously the time even is not going to allow you to go into all the details. So just give our framework at this stage that these are the possible things. So let me discuss with my consultant on the urodynamic and then we will discuss further. So yeah. Right then. So that's all for today. So regarding those recordings and stuff, I have sent email to admin and I have replied back that he will be sending you guys email today evening or tomorrow morning. So that's about that. Next one will be I think is surgical skills and post-op complications. Let me just see, because then you all get confused during the week. What are we doing next? So let's decide now what we're doing next session. Okay. Yeah, I know this. My admin is gone really a bit relaxed at the moment. Messed up with the advert as well. Okay, let's see. Yeah, so next one is core surgical skills and post-op care. Yeah. So for post-op care, please, as I said, like that one scenario which I have read, so with some septicemia. If anybody has more information about that, what was in the investigations or into the notes of concern, because I couldn't find from those what the information she gave. That patient appears to be normotensive as well, a bit tachycardic, but normotensive, so it wasn't going towards any septic hematoma or something like that. Neither urine output was okay as well. I mean, slightly reduced 20 minutes per hour, but still was the normal range. So there was something in the investigation that girl told me, because the examiner, she wasn't getting anywhere. The examiner was asking what is the cause of this fever or whatever she's having, and she was not able to find, and the examiner was repeatedly asking her to go back and look into the investigations. So there was, I think, the day 4 exam in India. It might have been another days as well, but there was day 4 India exam. So please try to get that information. Okay, so goodbye now.
Thank you. Thank you.
Thank you. Bye.